हेलो 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 हेलो
Dr. Yukti Shah, Assistant Professor of Pathology Department, on behalf of Dr. M.K. Shah Medical College and Research Center, am honored to welcome you to today's continuing medical education focused on intricacies of lymphoma diagnosis. Today, we convene not only to share knowledge, but also to deepen our understanding of this intricate aspect of pathology that lymphoma is. May I humbly welcome Dr. A.T. Leua sir, the Dean of M.K. Shah Medical College, Dr. M.M. Prabhakar sir, Medical Superintendent, and Dr. Chaitri Shah, Additional Medical Superintendent, and Dr. Falguni Patel, the Head of the Department of Pathology, Dr. Nisarg sir, who is the Professor of Pathology, and Dr. Gauri Shankar Shimali sir. With enormous pleasure, I consider it a great privilege of our institute to invite our distinguished guests of honor, the stalwarts of the field of pathology, Dr. Anita Borges ma'am, Dr. Sumeet Gujral sir, and Dr. Pravin Mahajan sir. And it is with great honor and privilege that I invite Dr. Falguni Patel, the head of the Department of Pathology of our college, to commence this educational journey.
Regarding lymphoma update. As a professor of pathology, it is my privilege to welcome all of you for these sessions. CMEs. CMEs is an opportunity to stay updated on the latest advancement, refresh our knowledge, and refresh our skill for better patients' care and community. Today's session is informative and enriching with such an esteemed guest who are willing to share their knowledge about lymphoma with us. I encourage all of you to engage with discussions, ask these questions, and share your expertise regarding the subject. I wish you all a very good and informative and rewarding CME sessions. Thank you very much, all of you, to coming and make this event successful. Thank you so much.
With a lightning round of applause, I request Dr. Nisarg Parikh sir to present a bouquet to Dr. Anita ma'am as a token of our gratitude. I now request Dr. Nidhi Sheth to present a bouquet to Dr. Pravin Mahajan sir. I request Dr. Falguni Patel sir to present Dr. Sumeet Gujral sir with a bouquet. I now request Dr. Manan Jadhav to present Dr. Gauri Shankar sir with a bouquet. No good deed should begin without the name of Almighty. So let us begin this academic session with lamp lighting. I humbly request everyone to proceed for the lamp lighting ceremony. આપો ને મેમને. I consider it a great privilege to welcome the Dean of Dr. M.K. Shah Medical College and Research Center, Dr. A.T. Levo, onto the stage to embark upon this CME program. So please join me in a round of applause to welcome him on the stage.
Very good morning to all the distinguished guests, speakers of very, very high reputation of our country, my dear delegates, all aspiring medical graduates from various medical colleges of state of Gujarat. Especially I welcome Dr. Anita Borges madam, that we are lucky to be here with your team and members. Today Dr. M.K. Shah Medical College and Research Center has organized this continuous medical education program to shed the light on topic of utmost importance, lymphoma and challenges it provides in diagnosis. As a Dean of Dr. M.K. Shah Medical College, it is imperative that we not only educate our students, but also engage our community in understanding the significance of its disease and recent updates in its management. Lymphoma, a type of cancer that affects the lymphatic system, poses significant challenges to patients and healthcare providers. With its diverse subtype and varied clinical presentation, diagnosis and treating lymphoma, it requires multidisciplinary approach and up-to-date knowledge, for which we are here. All members of the medical communities, it is imperative for us to stay updated for the latest development in lymphoma, research and training. Through continuous learning, like the program which we are organizing regularly, and this is a part of CME, we can work towards better outcome and improve quality of life for individual affected by lymphoma, and a difference in the life of patient and families affected by lymphoma. So this is just a short my introductory knowledge, and welcome you all for this important CME, and have a nice feast of knowledge and interaction today by this important CME. Thank you very much. I will welcome you again.
Thank you, Dr. Dean, sir. And we have a word from our chairman, Dr. Shah, who could not be with us here today, but he has asked me to welcome all renowned faculties and dignitaries and delegates to his institute, and he is heartily thankful to all faculties and dignitaries for sparing their precious time to share their knowledge. And learning is a lifelong process, and he hopes that knowledge or skill acquired today by the delegates will be helpful for having great patient care. So thank you on his behalf. So now without further ado, let us commence our exploration of lymphoma on this enlightening CME session. Okay, so what is lymphoma? Lymphoma, a complex and diverse group of cancers arising from the lymphatic system, presents unique challenges in its diagnosis. In today's session, we will delve into the intricate world of lymphoma pathology, exploring the latest advancements and diagnostic techniques and procedures. The discovery and understanding of lymphoma evolved over time through a combination of clinical observation, pathological examination, and scientific research. Its formal recognition began in the 19th century. Thomas Hodgkin, an English physician, described cases of what would later on be known as Hodgkin's lymphoma back in the year 1832. His detailed observations of enlarged lymph nodes and their association with systemic symptoms laid the foundation of understanding lymphoma. Lastly, I will take a minute and say that the first modern classification system for lymphoma was proposed by Rappaport in 1956, which divided lymphomas into, as we all know, Hodgkin's and non-Hodgkin's. Okay, so led by extreme experts in this field, this CME aims to enhance your understanding of lymphoma pathology, equipping you with knowledge and skills necessary to provide optimal diagnosis. It is with great privilege that I invite a true expert in our field, someone whose knowledge and dedication has made a significant impact in the field of pathology. Dr. Sumeet Gujral sir is the professor of the Department of Pathology at the ever-prestigious Tata Memorial Cancer Center in Mumbai with a keen interest in oncopath and hematopathology. Sir has been an active member of the National Cancer Grid. Sir has also been an editor of the upcoming WHO classification of hematolymphoid neoplasms. So everyone, please join me in welcoming Dr. Sumeet Gujral to the stage for his session.
Thank you and good morning. How do I start? Now make it full screen. It comes as a alert. Now, thank you. Thank you, Dr. Falguni and the Institute for having us here. My first, the opening batsman, and I'm going to talk on the classifications of lymphoma and what's new in the new classification, which has just come up. It's already available online. The print version of the 5th edition will be coming soon. Means why do we classify anything? I was reading today morning and with Pravin in the cafeteria, when I would put the word classification in the Google, there's a statement by no less than Albert Einstein. It says that chaotic diversity to uniformity, some kind of uniformity bringing out of lot of diversity which is chaotic. There are many definitions of classifications. And we classify everything. We classify whether you go for a job or you go for anything, we end up classifying. So here's lymphomas, as my friend she mentioned. Lymphomas have been classified for so many decades now, and multiple classifications we've had. Many. But importance is that, what is the global relevance? I mean, for lymphocytes, if you read this, I'll just read this few lines. The lymphoid development is a continuous spectrum, like any other cell. And if you read the classification, they're divided based on some broadly, 5-6 steps of B cells and 5-6 steps of T cells. But it is not true. It's something like there is a difference between we define neutrophil and a metamyelocyte. But there is obviously many stages in between. Morphologically, we define 2 or 3 stages in myeloid. But it is a continuous spectrum. So it's a little tricky to classify based on a big disease, a big spectrum, continuous spectrum of development of a lymphoid cell into few subtypes. But however, it gives us some basis of understanding the disease, making subsets team. And we have more than 400 authors from all over the world. This is, you can see the editors from different parts of the world. India is being represented. Luckily, thanks to Tata Hospital, I was picked up, and once I was there, I could have around 14 editors, 14 authors from India. So we have now authors from all institutes. We have from AIMS, PGI, Vellore, TMC Kolkata and Tata Memorial Hospital. Anita has written chapter on Hodgkin's lymphoma. So we are now 14 authors from India in the WHO hematolymphoid. My colleague Santosh Menon is editor in male genitourinary book, and another lady from AIMS, she is editor in lung tumors book. So it started in COVID, and we had a lot of meetings. First we had meetings with the editors, then we had to select the authors and have the meetings with the authors. So basically, to give an overview, it's something like the older classification. It follows a lineage-based framework. It doesn't work, no. So we need immunophenotyping, and then dominant clinical attributes is an acute, chronic, is cytopenias, and then dominant biological attribute. Sorry, which one? Oh yes, no, it won't work on that. Is it LD screen? No. So whether it's a fusion, rearrangements, or mutations. So based on this, broadly the classification has been done, and the tumors have been organized in order of increasing levels of specification, like first category, then family class, followed by an entity and then subtype, like mature B cell becoming DLBCL GCB type. In the new WHO book, they have got rid of provisional entities mostly. Essential and desirable criteria for each disease have been defined. Another chapter has come up on non-neoplastic lesions which mimic lymphomas for both B cells and T cells, which was not there in the previous editions. And there is a dedicated chapter on germline predisposition syndromes. So it is basically both lymphoids as well as myeloid. I'll be talking mostly next 15 minutes on lymphoid neoplasms. How do we diagnose lymphoma? It's like in the previous classification, same thing. Morphology is the basis, followed by the multimodality approach, means history, clinical, IHCs, FISH, then molecular defined. Now there are lymphomas defined based on molecular, which we know, with like DL, BCL with MYC and BCL2. Now this is a statement which is molecularly defined or based on FISH. And then there are these entities which are defined a little better in this new WHO, virus and immune deficiency related proliferations and lymphomas. Now I'll discuss mainly about 2-3 common lymphomas in WHO. One is the large B-cell lymphomas. Now large B-cell lymphomas is a big family, and if you read the definition, it is composed of medium to large size cells which have a round to ovoid nuclei and a vesicular chromatin and a prominent nucleoli, at least 1 to 2 nucleoli. And there's something, another entity called as high-grade B-cell lymphoma, which is very close to large B-cell lymphomas. These are intermediate size blastoid cells. We'll discuss about these two types, large B cells and high-grade B cells. So if you read this slide, there are almost 18 types of large B-cell lymphomas, 18 types. DLBCL is one type, which is NOS, one, and then 17 more. Now NOS, we cannot write NOS till we work up the whole thing. Otherwise, we'll just leave it as DLBCL. If we write NOS, then we need to rule out other lymphomas by doing more tests. I think I've mentioned this, I'll skip. In the new WHO, it says that it is not mandatory to define DLBCL on cell of origin by IHCs, because it is not the best surrogate to genomics. So if you can do CD10 BCL6 MUM1, it is good, but it is not mandatory to define ABC versus GCB based on the new WHO. It's not mandatory. Similarly, for FISH is mandatory for large B-cell lymphomas. Mandatory as per WHO, but they have made an algorithm I'll share with you, where you need not do CMYC and BCL2 in all lymphomas. We'll just see that. Now the role of NGS is still not come out in the new WHO, though there are some articles which mention clearly there are types of DLBCL which are molecularly like, there are some types which have very good prognosis, excellent prognosis, they are 100% survival. Like there are a couple of subtypes like here, if you read this MCD and N1 subtypes, there are two subtypes of DLBCL where you give R-CHOP and one more drug, ibrutinib, they have 100% survivals. The data is of 5 years now, 3 to 4 years data is there. There are a couple of publications, but it is still not come in the WHO. So WHO has not made mandatory NGS as of now. So if you read this slide, it mentions clearly here, ABC versus GCB was by Alizadeh group, which came in almost 20 years back, 24 years back. Now the new article by Wright, which came 4 years back, defines DLBCL into 5-6 subtypes. If you read this yellow color, MCD and N1, MCD is M5, MYD88 mutations, and CD is for CD79 beta mutations, and N1 is for Notch1 mutations. These are commonly seen in the bad lymphomas, which are called as bad ABC types, but they have the excellent prognosis. So these, if you treat with ibrutinib, they have very good. So ABC has some subtypes which have excellent prognosis, and on the contrary, the worst lymphomas, double hit lymphomas, or the lymphomas with MYC and BCL2 come from GCB category, which is a good prognosis. So that's why it is not good idea to define GCB, ABC based on IHC and confuse the patients and the doctors, because we know that GCB are generally good, but the worst types come from GCB. And similarly, ABC is bad, but there are types of ABC which have excellent prognosis. Now my colleague Gaurav Chatterjee is working on lymphoma genomics in our lab, and we have made a panel, and panel has been designed like all of us designed, importance giving to the diagnostics, like BRAF mutations you see here, BRAF V600E for hairy cell leukemias, STAT3 mutations which are now almost diagnostic standard for large granulocytic leukemias, LGLs, ROA mutations, IDH, DNMT3A for T follicular helper cell lymphomas. But now interestingly, these mutations are also seen in CHIP. CHIP is chronal hematopoiesis of indeterminate potential. So AITL has some semblance with myeloid leukemias. So that's why genomic classification is also won't be enough, because if you read that genomically AITL is more similar to myeloid neoplasms. So it is a little tricky how the further classification will come. So morphology, I think it won't be only molecular, because if you see the new classification, many new entities have come now based on molecular. But as you see, like here it is shown, T cell lymphomas have molecularly more similarity with myeloid stem cell disorders. Then you define based on prognostication, which are the good lymphomas. So we have some mutations like TP53, EZH2, these are BCL2, because we have like BCL2 mutation, you can give venetoclax. So which drugs you can give. So based on that, we have made a 250 gene panel, and hopefully by this year end, we should be giving service to the nation. Nikhil Patkar is already doing on myeloid neoplasms in our hospital. So he has set up almost 7 years back genomics panel for myeloid leukemias. For lymphoid, we should be starting in few months from now. Approach to, I'll just show you now next few slides. There's something called as large B-cell lymphoma, which I mentioned, and then something called as aggressive B-cell lymphoma. Now aggressive B-cell lymphoma is different from large B-cell lymphomas. Aggressive B-cell lymphoma contains many types, and large B-cell lymphoma is one type. Now, the most important approach to aggressive B-cell lymphomas is morphology, because based on morphology, these are some common types of aggressive B-cell lymphomas, which are large B-cell, high-grade B-cell, mantle cell, maybe the blastoid variant, Burkitt, and blastic. They all are high-grade aggressive, but they are defined based on morphology first. So WHO has defined morphology definition for each tumor, and broadly, if you see here, how to differentiate the two common types, large B-cell lymphomas and high-grade B-cell lymphomas. It is defined based on morphology. IHC will not help you here. So first you have to see the morphology and define whether you're calling it a large cell lymphoma or a high-grade B-cell lymphoma. Then you do the IHCs and CMYC and BCL2. If CMYC is positive, we call it large B-cell lymphoma with CMYC. If c-MYC is positive in this, then we call it high-grade B-cell lymphoma with c-MYC. But to call it high-grade or large cell, it's your morphology. So to start with morphology, you need some stains, CD320 MIB1, 10 BCL2, BCL6 MUM1, and then you define, then you do the fish. Then this is cell of origin, so you know it's GCB type or ABC type. Now this algorithm is not for the best labs, but for if you don't want to spend a lot of money and you want to cut down, so there's an algorithm how to approach DLBCLs. So first you do cell of origin based on the 3 markers. So the recommendations are all cases of GCB we should do c-MYC by fish. All cases of GCB you should do c-MYC by fish. And if c-MYC is positive by fish, but break apart probe, then you should do BCL2 by fish in those cases. But if c-MYC was negative, then you stop there. Don't do anything. And ABC you need not do. The good practices is you do c-MYC and BCL2 in all DLBCLs. But since it's expensive, so this algorithm has been defined. So I will not go into the details. Then there are subtypes, like a large B-cell lymphoma with IRF4 gene rearrangements. We have high-grade B-cell lymphoma with 11q, which was something like Burkitt-like, 11q. So these are the other markers apart from c-MYC and BCL2. Now we know this new entities have come. We used to call it double hit sometimes back. Now we call it DLBCL with MYC and BCL2, and other entities high-grade B-cell lymphoma with MYC and BCL2. And these are the high-grade lymphomas are generally the lymphomas of the dark zone. You see this is a germinal center which has a light zone and the dark zone. Light zone is light because it has more follicular dendritic cells and it has centrocytes. And the dark zone is dark because it has centroblast and fewer FDCs. And all the high-grade lymphomas, they come from the dark zone. So these are some pictures to show you different types of aggressive B-cell lymphomas. Once again, morphology is very important here. Then you take help of the other techniques, IHCs and FISH. These are the common 6-7 protocols which we have today for high-grade B-cell lymphomas, starting from B-cell ALL to DLBCL. We need to know the treatment protocols as a pathologist. So how many markers you should do in large B-cell lymphomas? Actually, the list can be very long. It can be 7, 8 or 10 antibodies for each DLBCL you need to do. And preferably c-MYC if you can do, it's a good idea to do that. But at least CD320 and MIB1 should be mandatory because sometimes we have called something as DLBCL or on MIB1 was very low, possibly it was a margin zone lymphoma. Sometimes margin zone lymphoma can show you large size cells and nuclei. So there can be, so MIB1 helps sometimes, but then if you have a doubt, it's a good idea to look at the history also. And look at the PET findings. So maybe you change your diagnosis based on PET findings and history. And because many times MIB1 can be high in the low-grade lymphomas. So MIB1 is not the gold standard to call it a high-grade lymphoma or to call it a low-grade lymphoma. But yes, surely for low-grade lymphomas it is helpful. In low-grade lymphomas it's generally 2%, 5%, 10%. Another common lymphomas is Burkitt lymphoma. Now in the new classification, Burkitt lymphoma is defined, there are 2 changes. Now you have to do EBV for all Burkitt lymphomas. c-MYC also has to be done by FISH. In our practice, we don't do either in Tata Hospital. We don't do c-MYC for Burkitt's because Burkitt is mostly diagnosed based on morphology and BCL2, 10 and MIB1, the 3-4 markers, and we diagnose Burkitt's. And we look at obviously the clinical picture. But the recommendations are you have to do c-MYC in all Burkitt's and Epstein-Barr virus by FISH, by ISH, EBER-ISH. Now this is another chapter which has come in new WHO, tumor-like lesions. I'll go quickly now. These are the tumor-like lesions, PTGCs, Castleman's, infectious mononucleosis, IgG4 related diseases. And these diseases have overlap amongst themselves. Like Castleman might have features of Rosai-Dorfman, they might have features of IgG4. So there is still less understood about these diseases, but they are called as tumor-like, mimics. And now going to the blastic leukemias, which are very common in children, there are 4 types, well-defined types, which are 11 subtypes. Other defined types, 7 types. Then NOS, 6 subtypes. And then there's something called as NFC is not further classified. So NFC is the type where, you know, most of us in India and most of the other poorer countries in Asia and Africa would be calling most leukemias as B-cell ALL NFC, because we do not do the complete molecular profile. So you need to do flow and morphology at least to call it, to diagnose a B-cell ALL, and if you cannot do molecular, you can just stop at B-cell ALL, not further classifiable. Now this entity has been introduced in the new WHO. Why do we do this? Because, you know, I showed you 17, 18 types of ALLs. We know that there are few of them are excellent prognosis where the survival is more than 95%, and there are few of them are very bad, like BCR-ABL1, TCF3 HLF. This is a new entity. Now these patients, kids do not live more than 6 months to 1 year. So here comes the importance of molecular testing. You could upfront tell, okay, this is going to go a very good prognosis and this disease is bad one. So there is the role of this WHO classification. Some entities have been removed from the WHO, like hairy cell leukemia has been redefined now. Hairy cell leukemia variant, sorry. Hairy cell leukemia is a very well defined entity and it's still there, but hairy cell leukemia variant, which was the older entity where the count is very high, the tumor cells have prominent nucleoli, it has been redefined into a new entity called as splenic B-cell lymphoma leukemia with prominent nucleoli. Now why it is different? It has been redefined because it doesn't have BRAF. Hairy cell leukemia is defined based on BRAF mutations. Now you have to have, obviously, morphology, flow, clinical, cytopenias, big spleen, and BRAF mutations. But now the hairy cell leukemia variant, which didn't have all these features, it had some markers of hairy cell, so it has been removed, so less confusion now. Similarly, another entity, B-cell pro-lymphocytic leukemia, it has been now excluded. This entity is not used now because most cases of B-cell PLL either are variant of mantle cell lymphomas, or they could be progression from a known case of CLL, or they are the same category as previous page, splenic B-cell lymphoma with prominent nucleoli. Just to give an example, this is classical CLL and this is the classical PLL or hairy cell leukemia variant. So if I see in peripheral blood elderly gentleman with this kind of cells, I will not, it doesn't look like CLL, it doesn't look like even blastic. They're all lymphoid cells with prominent nucleoli. So we used to call these as either PLL or hairy cell leukemia variant based on the flow findings. And the flow findings are also very iffy. They were not very classical. They're not well defined. So now they have become into new entity called as splenic lymphoma with prominent nucleoli. Splenic large B-cell lymphoma with prominent nucleoli. B-cell lymphoma. Follicular lymphoma, yes. Follicular lymphoma, now it has been seen that grade 1, 2, 3A have similar prognosis, so you could call them one entity, classical follicular lymphoma. You need not divide them into 1, 2 and 3A. It's very tricky because centrocytes are larger cells. Centroblasts are very large, centrocytes are large. The lymphocytes are small. So many of us, I used to think many times, even now sometimes, we have difference of opinion between two pathologists, which is a centrocyte, which is a centroblast. Now centroblast has to have a prominent nucleoli, but you know, our fixation, our processing can be tricky. So there can be difference of opinion on the morphology, but the WHO says that grade 3B is a different disease. 1, 2 and 3A are low grade, or you call them classical follicular lymphoma. Grade 3B is now known as follicular large B-cell lymphoma. Like DLBCL, this is FLBCL. And then there are two new entities, old entities defined, blastoid as well as diffuse pattern of follicular lymphoma. Now this chapter has come up, which is again, I think I have 3 minutes. This is another chapter which has come up, which is actually from different chapters they made it one chapter. Like lymphoid proliferations associated with immune deficiencies. Now we've been learning much more about immune deficiencies and lymphoid proliferation. Now when we do not when I see a slide, and if we cannot put it into lymphoma, we start thinking, is it an immune disorder or some EBV related disorder? We never diagnosed many viral infections. We never used to diagnose EBV related proliferations. We never used to diagnose immune deficiencies, at least not me, I never diagnosed many. But now you know that there's so many of immune disorders which come with the lymphadenopathy. We have to be careful. So, how to make it simpler? The WHO has come up with 3-part nomenclature to define these kind of disorders based on morphology, the 2 viruses, EBV and Kaposi sarcoma. Thankfully, we have less Kaposi sarcoma in most part of India. It's more in the northeast where there is drug addicts, and maybe more in HIV and drug addicts, but EBV is all over. And then clinical history, inborn error of immunity, HIV infection, post-transplant, autoimmune diseases, iatrogenic, immunosenescence. So putting these things together, we can define, these are the entities given on this side. There can be hyperplasias, they can be intermediate like mucocutaneous ulcer, not lymphomas, somewhere in between, and then classical lymphomas as you see in immunocompetent patients. Like this case, just to show an example, young boy came to us as diagnosed as AITL, multiple biopsies, multiple chemotherapy cycles. Young boy, AITL, he was asymptomatic. We were also not sure what to call it, but on, I think here, yeah, it turned out to be in some syndrome called as PIK3CD syndrome. It basically on immune, immune profile, PID profiling by genomics, primary immunodeficiencies. So my point is here is, if something is not fitting into lymphomas, you have to get the history and think about drugs, think of viruses, think about autoimmune disorders or primary immune deficiencies, which is a big area which we do not know. So I think WHO has done a good job to make one chapter on this, and it helps us understand it better. Hodgkin's lymphoma is okay. I think I'll skip this. It is very well written now. These 2 chapters. Anita has written classical Hodgkin's and NLPHL by Sylvia Hartman, and this is 6 types of NLPHL defined by Yashoda. It will come. Going now last 2 minutes to T cells. T cells also has another chapter, which are mimickers, which are tumor-like, like Kikuchi's. Now Kikuchi's autoimmune disorders can look like B cell lymphomas, can also look like T cell lymphomas. There we mentioned SLE, here we call it Kikuchi's. They are similar. So autoimmune disorders can look like B cell lymphomas, can also look like T cell lymphomas. So if you have a doubt of a B cell lymphoma, it could be autoimmune. If you doubt of T cell lymphoma, it could be autoimmune. Then indolent, I have not seen a case, but there are few cases reported, and ALPS. ALPS we see quite a few cases. So ALPS is again can look like blastic lymphoma. So one has to be careful if there are TDT negative, double negative T cells in a lymph node. TDT negative, double negative, you may be dealing with some autoimmune disorder. Peripheral T cell lymphoma defined 2 types, but you need not do it. If you can, but not mandatory, based on TBX21 GATA3 and 2 more markers. These are the smaller entities I skip. I will skip this also. Now AITL is defined. Now the new term is nodal T follicular helper cell lymphoma. It is defined 3 types. Nodal T follicular helper AITL type. Second is follicular type. Third is NOS type. And as I told you, as we discussed, there are these common mutations seen in AITLs. In our practice now, we see more T follicular helper cell lymphomas than AITL, which we diagnosed much less many years back. Now because we have more panels, more understanding, bigger IHC, more IHC markers we do regularly. So AITL is becoming more, in our practice, is more common than PTCL, NOS or PTCL. These are the 2 common mature T cell lymphomas, PTCL and AITL. I think ALK negative ALCL is divided into 2 types, DUSP22 and TP63. I think I will, to conclude, good histomorphology remains the basis for optimal classifications. We have essential diagnostic criteria, which is very important and desirable. Obviously, we should try and achieve more markers and do a desirable diagnostic criteria. We mentioned about this, and for my younger colleagues, attend clinics, make friends with medical oncologists and learn pathology lymphomas. Thank you very much. I'll come down, I think it's I'm already 5 minutes behind, so let's not have any questions.
May I please request Dr. Hansa Goswami ma'am to present Dr. Sumeet Gujral sir with a memento. Yes. That was so enlightening, sir, and I'm sure it has charged one and all present here for the sessions to follow. And throughout this conference, we will have privilege of hearing from distinguished experts who will illuminate us with various facets of lymphoma. And now, everyone, it is with great honor and privilege that I invite Dr. Anita Borges, ma'am, to the stage. She's not only a highly esteemed pathologist, but also a beacon of knowledge, and her presence today is a testament to her compassion to the field of pathology. And might I take a moment and bring to everyone's knowledge that Anita ma'am has been awarded several awards and orations, both in India and abroad. And she's currently associated with SL Raheja Hospital, Mumbai. And please join me in welcoming Anita ma'am as she graces us with her expertise on the topic of approach to lymphoma diagnosis. Thank you.
Let us get out. Stop this. All right. I don't know, is there a security launch? Good morning, everybody. Let me start by thanking Professor Falguni and, of course, my good friend Nisarg, who broached the possibility of holding the CME in Ahmedabad at the M.K. Shah Medical College. I've known Nisarg for many years, and it's very difficult to say no to somebody whom you have had as a student and then as a friend. Sumeet started the ball rolling. We're telling you what's new in the field of the classification of lymphomas. Now, my job is to tell you how to approach a lymphoma diagnosis. It's a difficult subject. I'm sure all of you know, and I think that whenever anybody says that there's going to be a CME on lymphomas or a CME on soft tissue tumors, people just rush to it. And I see the crowd over here, and I understand that we have this sort of presentation because there are people that are watching online. And I can only tell you one thing. There is no substitute to experience, okay? Because it's easy to say, and to show you that you should think of this, you should think of that, you should be cautious about this, and you should, sort of do this, that, or the other. But in the end, I have a, phrase for it, and I'm sure Pravin knows because yesterday I was talking about it a lot, and that is, it's very difficult to know when you don't know, okay? And that only comes from experience. The more you see, the more you realize what are the gaps in your knowledge, and something goes like a flag, comes up like a flag in your diagnostic mind that says, I think I need to look at this better, or I need to do something more, or I need to get some other opinion on this case. And this, my friends, is the real problem with lymphomas, okay? Because you can fall into a million traps if the flags are not going up in your head. Okay, so let's start with this. So it's not just about how to make an approach to lymphoma diagnosis. The issue is, how do you start to make a diagnosis on a lymph node that comes to you, which is not tuberculosis or metastatic carcinoma or some other very simple kind of problem that you see in a lymph node. It's not like, you know, you're dissecting nodes for a breast carcinoma and you just want to know, is this metastatic or not? Somebody has taken out a lymph node where there is you know, the issue is not just one of these things that I have mentioned. So you have to know how to start to look at a lymph node diagnosis, okay? And I will just tell you quickly, you must carefully evaluate the H&E stain section. That stands to reason, because many people don't look at things very carefully. You know, it is a little bit, to me, lymphoma diagnosis is, for me, a lot like looking at a kidney biopsy and looking at a liver biopsy, okay? You can't do what you do when you're looking at squamous carcinoma or some other such thing. You can just pass the thing around and you get a fair idea of what's going on. This means actually carefully evaluating a lymph node, which we always have to do with liver, because there are very subtle kinds of changes, and also what you have to do in nephrology. So that's the kind of attention. Otherwise, what is in oncology? I mean, oncology to me is a mug's game. Okay, it's much, much less difficult than doing a liver biopsy or a kidney biopsy. Now, once you have done that, you have to arrive at possible diagnoses in your head. Then you have to correlate it with clinical data. Some people look at the clinical data first and then look at the lymph node. You order immunohistochemistry as necessary, and in my experience, I feel that if somebody has taken out a node and there's no tuberculosis and there is no metastatic disease, and it is just a lymph node, it's not that you're looking for metastatic disease, then you must do immunohistochemistry. So don't get disheartened, but that is what lymphoma is all about. Send it somewhere if you think that you need the immunohistochemistry, all right? And then you have to interpret the immunostains. Once that happens, you put everything together and make a diagnosis. Now, what do I mean by evaluate an H&E very carefully? And it means you have to look at all compartments of the lymph node, and the lymph node has many compartments. And I'm not talking about cortex and paracortex and stuff like that. Every young person, and by the way, you see, all of you are very young. How many postgraduate students are there? Can you put up your hands, please? How many? Oh, a fair number of postgraduate students are there. So I think that you have to make this a practice, okay? The overall architecture. And here I'll tell you something that I say again and again. Architecture is not the same as cell content, okay? If somebody asks you about the architecture in this building, you're not going to talk about tables and chairs, are you? It's the broad features that you see. And in the lymph node, it is the capsule, it's the marginal sinuses, it's all the sinuses in between, the afferents that come in and the efferents that go out. That is architecture, and I see so often lymph node architecture is destroyed. Lymph node architecture is not destroyed. What has changed is cell content. That is very important, because I can use the same hall and I can use it as, for a dance evening, or if this was flat, I could put tables and chairs. Cell content changes, architecture does not. When architecture changes, you know it has changed. It is destroyed in tuberculosis, it is destroyed in metastatic carcinoma. Most of the time what is happening is not destruction of architecture, it is cell content, because the lymph node is a plastic organ, isn't it? It's constantly changing physiologically. Are you really telling me that that architecture has changed because this is a quiescent lymph node and I don't have reactive follicles. No. So please, try to look at the compartments, the B compartment, the T compartment, you know, the medullary cords, do you see plasma cells, etc. And please don't go on about this architecture has been destroyed. The architecture is there. It's the cell content that is continuously changing in a lymph node. If there is any issue about that, please ask it to me at some stage or the other. Okay? So you have to look at distortions in architecture, and I told you when those distortions occur. And the cell content, is this focal, is this partial, is it diffuse? Okay, and then we have to arrive at possible diagnosis. And those diagnoses it's a pattern diagnosis that you make at low power. Is it nodular, is it diffuse, is it mixed, whatever. Is it and then you go to high power and you have to do this cytological. And please, a lymph node, and I think I said it in the previous slide, if you can afford it, it's an expensive lens. Please, if you're doing enough lymphoma work, please get a 2x lens, okay? You can't do this low power overall architecture and cell content diagnosis. You can't really look for something that's nodular or diffuse or mixed type or other sinuses involved, etc., unless you have a really good low power lens. So 2x. I'm not saying that you can't do it at 4x, but it makes life much easier, okay? So then after you have done this, then you make an entity diagnosis, okay? And the entity diagnosis, you've made your observations, you've interpreted those observations, and then you come to the diagnosis. I think Sumeet made a very important point. And you should have everything in place on your table when you are making, or otherwise you'll have to go and get that information. And you know what kind of information? We get so often, cervical lymph node. I don't take it as cervical lymph node. Yeah, I know it's in the neck. But is this in the, in the jugular chain? That means, is it in the anterior neck or is it in the posterior neck? And I know, and I'll tell you why. Because there are many things that don't occur in the posterior neck, okay? Some things are very common, and toxoplasmosis is one of them. And toxoplasma can give you some very, very weird looking pictures. And if I knew that this was in the posterior triangle, and I'm struggling with whether this is a Hodgkin disease, I'm not going to make a diagnosis of Hodgkin disease in the posterior triangle of the neck unless it is in the supraclavicular fossa, okay? Now, when someone comes to me and says cervical node, I want to know if it is supraclavicular. Why do I want to know whether it is supraclavicular? Anybody would like to tell me? Any of the young people at the back? Because? Oh, it's not about metastasis. There is one thing that you know as a clinician, or should know as a clinician, about the supraclavicular lymph node, that there is no primary or any other disease that occurs in the supraclavicular lymph node. No lymphoma occurs only in the supraclavicular lymph node. That is it is a sentinel for what's happening in the chest and what's happening in the abdomen or what's happening above it. So please, somebody sends you a supraclavicular lymph node, you have to ask what's going on in the chest and what's going on in the abdomen, and then somebody will tell you, oh, there's a huge mediastinal mass, and your diagnosis becomes very easy. So these are the kinds of pictures. Is it a child? Is it an adult? And Sumeet told you, autoimmune disease. What is the general picture that is going on? Duration. Something that happens suddenly cannot be a lymphoma. No lymphoma happens suddenly. Okay, so all of this is extremely important. Now you have to order immunohistochemistry as necessary. To confirm a diagnosis made on H&E, nobody is going to treat a patient with Hodgkin's lymphoma today, even if it is barn door open and shut, and you can see that on H&E. All medical oncologists will want you to confirm that with an immunoprofile, okay? I'm just telling you this. You should be able to make the diagnosis on H&E, but there are so many mimics, and Sumeet is going to talk to you about it, that you must confirm this. Sometimes you have to immunophenotype. You know that it's a lymphoma, but you need to know whether it's B or it's T or what kind, etc. And of course, you'll have to immunophenotype if there's an uncertain diagnosis, okay? So if a lymph node has been biopsied, that's what I've been saying so far, with a suspicion of lymphoma, basic immunohistochemistry should be done, especially if it is a core biopsy. We are not going to be so lucky to get whole lymph nodes anymore. The era of the radiologists and so many other people on ultrasound or whatever, putting in a needle core, even in accessible lymph nodes, is here to stay, whether we like it or not. And therefore, immunohistochemistry is going to be the order of the day. Now, this is what Sumeet has already told you, so I'm not going to repeat it. You can't see it from there. I can barely see it on my screen. This is for the first time that the WHO has talked about reactive processes and other processes that mimic lymphomas or can be confused with lymphomas. So that's just what I've said for the B cells and for the T cells. Now, after this whole story, you have to interpret immunostains, okay? So how do we interpret immunostains? You can't interpret it, whether it's for lymphomas or anything else, unless you have the knowledge of normal patterns of expression in different compartments of the lymph node and stages of differentiation. Because the same thing might show a different profile when it is, better differentiated or less differentiated, as the case may be. And it may change if you have a lymphoma. For instance, we know that CD5 is expressed only in T cell cells, in T cells. But it starts to get expressed in a B cell lymphoma, which is quite common, and that is CLL. Now, I need to know that when I am interpreting immunostains, okay? And where is that stain? Is it cytoplasmic? Where is it expected to be in these instances, okay? And you remember about clonality assessment. Clonality assessment is not easy anyway, but you can do it on B cells because you have, if there is plasmacytoid differentiation, you can look for, light chain restriction. But for T cells, it's tough, and you either need flow or you need to get T cell gene rearrangements. So let's just look at some normal structures. Now, what would you think over here? I don't know if I can, yes, maybe you can see my cursor, I don't know. I'm moving the cursor, but I don't think that you can see it. I can see the cursor. Can you see it? No. It's there in the top left-hand corner. So the cursor, let me see if I can get it into the mode where it's a laser pointer. Chalo. Pointer options. Laser pointer. Can you see it now? In the, yes? Areva, that's good. So now, what would you say about this top left-hand corner? Lymph node architecture is effaced. In all you young people, look at these idealized lymph nodes where you see, oh, there is a ring of follicles at the periphery, and then you say that's the cortex, and then you have a paracortex. Now here, let me tell you, can you see a cortex and a paracortex like how you imagine it? The answer is no. And yet this is an absolutely normal, physiologically stimulated lymph node. Okay? You can see all there, the CD20 is being expressed. The follicles are everywhere. They're not forming a nice ring around the periphery. It all depends on how you have sliced the node. How reactive is that lymph node? Does it occupy, does the B area occupy the whole lymph node or not? So that is telling you about B, and you see over here CD3, and you can see that there is a follicle here at the periphery which has not taken up, the 3 brightly, and we can see that a little later. But there is another little thing that looks like a nodule that is attached to this what is obviously a B cell nodule, and that is we call it a stimulated T cell nodule. So there are T nodules. We call the B things follicles, and together that makes the cortex and the paracortex, because wherever the T zone is, but you don't imagine it like you see it in the kidney, it never happens. And you know why you people think of it? Because the lymph node has a reniform shape. It looks like a kidney, and you're told about cortex and paracortex, and therefore you feel, it must be like the kidney, which has a cortex, and then it has, a medulla. It's not like that. We use the same words, but you don't see it in a lymph node, because the kidney has a fixed structure that does not change from day to day. The lymph node, the physiological content of that lymph node is changing even as you sit, depending upon what lymph node and what is stimulating it. So there is no fixed structure or content to, there is a fixed structure, but there's no fixed content. Now here is another lymph node. I'm not showing you the H&E, but here is what you people normally think of as an idealized thing. See, there's CD20 like a ring around the periphery, and an unstained area which is 3, which is the paracortex. So cortex, paracortex, and then you see, there's B over here, so there are a lot of immunoblasts. There are probably some plasma cells, and sometimes plasma cells pick up CD20, but so, and you see that what has not picked up CD20 has picked up CD5, which is another marker. It's for T cells, okay? And here is 79A, which is marking all of these B areas, because 79A does mark the B areas as well as some plasma cells. And here you see BCL2. Now, what is this BCL2 telling you? You can see, we all know that BCL2 is not seen in the follicles, center of the follicles, yes. But everything else over here is BCL2 positive. Okay, so you must remember this, that we should only use BCL2, unless you are trying to classify a diffuse large B-cell lymphoma, only when you have an issue of whether some nodular or other parts of the lymph node which are expressing CD10, and we'll come to that in a minute, are they BCL2 positive or negative? Okay, that's the only time when you really need to use BCL2. Yeah, because everything in the lymph node, apart from stimulated follicular center cells, which are always CD10 positive, express BCL2. Now, this also is telling you the same thing. You can see here a nice reactive follicle. You can see that this is CD10, and that's CD10 in the BCL2 over, and that's CD3. Why have I shown you CD3 and I have shown you 4 and 8? Because there is a lot of, that's why we talk about follicular helper T cells, and where are they? They're in the follicle. They're helping the cells to actually do, B cells to do what they're supposed to do, and that is differentiate into antibody producing cells. That's what T helper cells do. So in the center of the follicle, we are all told that this is all B. No, there is a lot of T that is sitting in those follicles. Important. Why? Because if there is a huge amount of T that is sitting in that follicle, can happen quite normally, and you do a BCL2 and the BCL2 is come up brightly, you'll say, aha, that's a follicular lymphoma. No, you have to compare it with how much T there was in that follicle, and that may be that it's the T cells that are actually picking up the BCL2. Because why? Why are T cells picking up BCL2? Why? Because all T cells pick up BCL2. So understand that. It's only what does not pick up BCL2 is a reactive B cell that is in the follicle. Okay? The mantle will pick up BCL2. Every other thing, including T cells, will pick up BCL2. So please, you're not supposed to read BCL2 as positive or negative unless you are evaluating B cells that are in the follicle center. Have you got that? because that is extremely important. We see all kinds of errors as a result of this. Okay, here we have obviously a reactive follicle. Now look at the mantle on this picture. This mantle is IgD positive. Yeah, some of them are also IgM. Very interesting, because it's important not to, if you have a primary follicle, that will also be BCL2 positive. There's no reaction center, and all of those things will be IgD positive. And I think Sumeet has told you about the dark zone and the light zone, so I'm not going to go. See, CD23 is picked up by the follicular dendritic cells. I don't know if you can see, particularly those of you sitting at the back. There are a few immunoblasts that have picked up CD30 in the interfollicular space. And here you have, kappa and lambda light chains that are in the normal proportion. This is polytypic, and it's in the medullary cords. So now we have to interpret immunostains, okay? And how do we interpret them? All assessments have to be made on the population of interest. And that is your biggest problem. How do you know that this is the population that you are interested in? That, my friends, is where experience comes in. If cells are large, there's a mixture of large cells and small cells, perhaps the large cells are the population of interest. I'm saying perhaps, okay? You need, therefore, that experience to be able to tell you. So just lagawing the immunostains is not good enough. You actually have to interpret them, okay? Because lymphomas very seldom show you a pure population. We all know that, of either B cells or T cells, except perhaps in something like Burkitt's or, some blastic kind of lymphomas. Even there you will get some admixture. And lymphoma cells, as I told you, may be a minority, and you need to know which is that population of interest. And please, once upon a time, I'm sure nobody does it anymore, people would give plus, plus, plus. CD3, 3 plus, CD20, 2 plus. There is no place for all of that. You need to interpret whatever you're interpreting on the population of interest. Now, you might ask me what panel. There's a huge panel, and I'm not even going to go through this. All of you will sooner or later know what you are supposed to do. And you're supposed to do it based on what your pattern that you have seen, what kind of cells that you have seen, okay? Now, I just want to tell you, I'm going to ask anybody at the back over there, all right? What is the immunostain that has been done over here? You see, there is... What is the immunostain that has been done here? Come on, somebody put up their hand. Yes, none of the people at the back are answering. It's all the wise people who are sitting in the front who are answering. Yeah, like Parimal and, all of them. This is BCL2. See, I've said follicular hyperplasia. In follicular hyperplasia or follicular lymphoma, which we used to grade 1, 2, the difference is what? That BCL2 is being expressed and it is not being expressed. So this is BCL2, okay? Now, I want the young people at the back, and I do not want all the wise ones that are sitting in front, okay? To answer this question. Now, you see this, Sumeet, you gave me, an idea to use an egg, okay, for the follicle with its... you remember? You have shown it before. So I have to tell you, but except that now I've gone one further and I've sliced all the egg like this. And what's in the center, what is yellow, is the follicle center, right? What is the white is the mantle zone. Okay, very good. So I've shown that over here. Now all the people at the back, unless you want me to point out and ask who's who, this is BCL2. So should it be positive or should it be negative? Negative. Excellent. Very good. It's like a sing-song thing. Now BCL2 is pointing to the white. Should it be positive or should it be negative? Positive. Okay. White again. This is what obviously the mantle. So now what? Positive or negative? Positive, excellent, all right. Now CD10. Is it positive or negative? Positive. You see, you got the hang of it. What about CD10 in this white part? Should it be positive or negative? Negative, see? What about CD3? In the yellow part, what are you going to say about CD3? Huh? Now everybody is, because you can't chant one thing, no? Positive or negative, yes. So, what is it? It is positive in the follicular helper T cells. Very good. What about CD4? Yes? Same thing, no? Follicular helper T cells. Excellent. What about CD8? Negative. Okay. What about CD5 in the white in the mantle? I see. This is a normal follicle, no? So it is negative. Yeah? And what about CD5 in the yellow part? What should it be? Yeah, it's again positive in the follicular helper T cells, okay? So what is the message that I'm giving you? You need to have this almost in your sleep. You should be able to do this, okay? So in a follicle, you do not evaluate BCL2 in a CD10 negative zone. End of story. That is what you should do. What about this in a follicle, and these are follicles? If CD5 is positive in the mantle zone, that is abnormal, and you will have to think of a mantle cell lymphoma there, okay? Because normal B cells do not express CD5. So have you got the message? Yes. So how to evaluate an atypical lymphoid process? I've almost finished my time, okay? We won't, I'm just going to finish with this and then we'll see. You have to be familiar with reactive patterns of proliferation, and that's easier said than done. Don't assume that every abnormality is a lymphoma. You have to correlate it with the clinical history and blood parameters, and then you have to ask yourself 3 questions, okay? Is this a lymphoma? And that is the real problem, okay? If it is a lymphoma, then it's relatively easy. I mean, not very easy, but is this Hodgkin's lymphoma or is this non-Hodgkin's lymphoma? And then you've come to one or the other, then what is the subtype, okay? And when you come to this, is this a lymphoma? It's not just about reactive and is this a reactive process, lymphoid process? Is this a malignant tumor? Other than a lymphoma, which is looking like a lymphoma, okay? And I call these things the masqueraders. And these masqueraders come, meaning, you know, masquerader is somebody who puts on a mask. And nowadays we see all these masks everywhere, no? You go to IPL, you go here, you go there, everybody's wearing a mask. Everybody has got a mukhota, including our politicians, yeah. All right, so then you have to consider benign lesions that simulate lymphomas and vice versa, tumors that simulate other tumors that simulate lymphomas, and lymphomas that simulate other tumors. These are the 3 things that you need to do. And what are the common patterns in which this happens? And that's my last slide, okay? Polymorphous proliferations. When you have a very polymorphous kind of proliferation in a lymph node, with or without large cells, like you get in a viral lymphadenopathy, infectious mononucleosis, okay? You get these big immunoblasts, and then you get plasma cells and, you know, lymphocytes, etc. Sometimes or metastatic carcinoma, like you get in, I don't remember, never remember it, you know, Simke type and Rigo type or whatever of metastatic nasopharyngeal carcinoma, then you might wonder whether you're dealing with Hodgkin's or a PTCL. Follicular or nodular proliferations. Obviously, in a follicular hyperplasia, you saw one example. Follicular lymphoma and nodular lymphocyte predominance, Hodgkin's lymphoma can be confused with the reactive follicular hyperplasia, particularly nodular lymphocyte predominance, because there is a condition known as PTGC, progressively transformed germinal centers, which can be confused with nodular lymphocyte predominance Hodgkin. Okay, then focal areas of atypical cells with or without necrosis. And the main mimicker is Kikuchi's disease. It is so much a mimicker that it has appeared also in the new WHO, where they are talking about reactive processes that can look like lymphoma, and they look like partial involvement of the lymph node by NHL or HL. Then you have these mitotically active proliferations, just like Sumeet mentioned, that's autoimmune lymphoproliferative syndrome. It happens in children who have an autoimmune problem. It is with, this FAS and FAS ligand. And these are so mitotically active that you might consider them to be high-grade non-Hodgkin's lymphoma of either lymphoblastic or Burkitt type. There are a few others that are there, but ALPS is one of the... and then you have this diffuse or sinusoidal infiltration of undefined cells, okay? Some things like histiocytic disease, some metastatic carcinoma, and you can mistake them for ALCL or some other BCLs, or the other way about. You get an ALCL and you might think that it is a carcinoma, all right? So I think with that, I am going to stop here. There are any number of cases that I can show you, but this was an introduction of how to approach a non-Hodgkin's lymphoma. Thank you very much indeed.
Thank you, ma'am, for an informative lecture. I would now request the head of our department, Dr. Falguni ma'am, to present Anita ma'am with a memento. I would like to ask all the students who have enrolled for paper or poster presentations to proceed with that. Thank you so much, Anita ma'am, for such an enriching and informative lecture. And Dr. Pravin sir's commitment and expertise in the field of pathology is known to one and all. And so on behalf of Dr. M.K. Shah Medical College, may I please request Dr. Pravin sir to continue his session. Thank you.
So good morning, everyone. At the outset, I would like to thank organizers for inviting me here, and also I would take a moment to thank my mentors, Dr. Borges and Dr. Gujral. I have learned so much about lymphoma from them. We do have a small group of people who meet once in a month or once in a 2 month for discussing the lymphoma cases. We call it a lymphoma meeting, and I learned so much just by being there, showing our difficult cases to these stalwarts. And when I was told to speak on this, I was told that the target audience is actually postgraduates. So most of my talk, you will see I have kept it something which will help most the younger colleagues of ours. So I was told to take two talks, which was pattern-based diagnosis to lymphoma, lymphoma with diffuse pattern and nodular patterns. So we will have in the afternoon lecture on Hodgkin's lymphoma and its mimics. So I am not going to address them during my talk when I will talk about the nodular lymphomas. How do we diagnose and classify? Some of the things will be little repeat. First 4 or 5 slides maybe repeat what already said in the morning, but I will again repeat it for the sake of those who might have come late, or for the PG students they may understand it little better. So how do you diagnose and classify lymphomas? We see first is architectural pattern. What is there? What is happening there in architecture or the contents of the lymph node? And then of course you have to see the cellular morphology. How are the cells looking? What kind of cells these are? What are the sizes of the cells? Whether cells are small, whether cells are intermediate, medium size, or large cells. And of course, once you have arrived after seeing the architecture and the contents of the lymph node and the cellular morphology, one has to take help of immunohistochemistry to make the diagnosis. As already you heard that no medical oncologist who treats lymphoma will accept your report if it is not accompanied by immunohistochemistry. But you have to know your morphology, because if your morphology is not good, then whatever markers you have for lymphoma, maybe 25, 30, may not be of use if you don't do the correct immunomarkers for that morphology. So most often the diagnosis of the lymphoma is made by doing immunohistochemistry, but there will be seldom instances where for diagnosis of lymphoma you might have to resort to the molecular techniques. So on morphology, what you see, you have to check whether, because I am talking about diffuse and nodular pattern lymphomas, first you have to check in a nodal lymphoma, and I am going to talk about mostly on a non-Hodgkin's lymphoma. So whether the morphology is diffuse or nodular. Nodular, we also use this term interchangeably with a follicular. Once you know whether it is a diffuse or nodular, you try to see what kind of cell it is. In that, whether you are seeing only the single type of cell all over, or whether you are seeing a mixed cell population, means there are not only one type of cell, but there is a polymorphic cellular population, which are this cellular characteristic. And of course histology. You have to know what is your impression on histology, and then do the appropriate markers. This is again a repeat what you see on a low power and what you see on a high power. So on the low power, what you see is architecture, wherein you see what is happening to capsule, what is happening to sinuses, what is happening to efferent and efferent lymphatics, and then you try to see the contents. Contents means what is happening in the follicles, what is happening in the interfollicular areas, what is happening to the medullary cords, and then morphological patterns, which is commonly you see in a lymph node, is either a diffuse pattern or a nodular pattern, but there are rare patterns like even sinusoidal pattern you may see, or interfollicular patterns you can see. On a high power, then you move on to high power. No diagnosis should be made directly going on to the high power. First you have to see the low power, and then you move on to the high power, wherein you start to see the cytological details. So in cytological details, what things you have to note is note the cell size. You have to note whether the cell size is small, whether it is intermediate or a medium size or a large size. And then you start to see if the cells are monomorphic, whether they are of the same size, same cell type, or they are of a different cell type. And then you should also know whether what I am saying is actually a blastic or a blastoid morphology, or it is whether it is a mature morphology or a mature chromatin. So just to give what is, we always hear from medical oncologists or our medical colleagues that this is a low-grade lymphoma or a high-grade lymphoma. Even as a pathologist, one should know when we say something is a low-grade, when we say something is a high-grade. So majority of low-grade lymphomas actually are mature lymphomas. So how they are characterized? They show you small cell morphology. They show you mature chromatin. There will be absence of significant amount of mitosis and apoptosis. And if you do Ki67 proliferation index, invariably they will have a low Ki67 index. But when I am telling you these are some simpler rules, you must remember as you get experience in lymphomas that there are exceptions to everything here. Like if I say that the mature lymphomas which are low grade always have low MIB1 index, there will be instances when a follicular lymphoma which looks just grade 1 and 2 will have a Ki67 index something like a 50 or a 60%. That doesn't mean that's a high grade lymphoma. On morphologically it is a low grade lymphoma, so you have to make that diagnosis of low grade lymphoma. Low grade lymphomas usually present with generalized lymphadenopathy and high stage disease. Now that is kind of contrast, right? They are low grade lymphomas, but they present with high stage disease because the patient doesn't become symptomatic. Patient doesn't become symptomatic early, so that's why the disease process has time to grow, and that's why the multiple lymph node gets involved. Even the bone marrow can be involved, but patient can still be asymptomatic. That's how they can present with a high stage disease. When you are talking about high grade lymphomas, you have to remember that the immature or blastic lymphomas are always high grade lymphomas. But not all clinically high grade lymphomas are actually blastic or blastoid. I mean, there will be mature cell lymphomas which are of large cell type or intermediate cell type, which are actually high grade lymphomas. And though these are characterized by high mitotic rate as well as high apoptosis, and on Ki67 index, you will see majority of them will show you very high Ki67 index. And they usually present with low stage disease because patient becomes symptomatic early. That's why the disease is caught early. So if I was saying immature, blastic or mature, then what is, you should know when we say something is blastic or immature and when we say something is mature. So in blastic or immature, you see that the chromatin, what we call is a fine chromatin, or it is very homogeneous chromatin. It will have maybe a conspicuous nucleolus or may not have also conspicuous nucleolus. Now, if you see it in a blood smear, the blastic or a blastoid cell always show you a prominent nucleolus, but that doesn't happen when you see in a HNE. HNE, you may not be able to see a nucleolus in something which looks blastoid or blastic. So so blastic lymphomas are all B and T lymphoblastic lymphomas. But there are mature neoplasms. These are not immature neoplasms. There are mature neoplasms which have variants which are called blastoid variants. And those lymphomas are like, you have a blastoid mantle cell lymphoma. There is a very rare variant of a follicular lymphoma which is a blastoid follicular lymphoma. And some high-grade B-cell lymphomas which are of intermediate size, which you cannot put them into category of diffuse large B-cell lymphomas, can also show you a blastoid type of morphology, and some of them can be actually double-hit lymphomas. In a mature lymphomas, what kind of chromatin you see? You see a clumped vesicular or hyperchromatic chromatin, and so these are the signs that you see in a mature chromatin or a mature cell. And how do you say something is a large or something is a small cell size, or something is a intermediate or medium size. Now you have to compare it with something which is, if there is a bystander histiocytes in that population, you have to take help of that. If the histiocytic nucleus which is on the left side, you see of that size, if anything, any cell which has a nucleus bigger than the histiocyte nucleus, then you call it a large cell. So it is a large cell. If that is of the same size of histiocytes, you will say it is an intermediate site cell. Or if it is smaller than that, or it looks like something closer to mature small lymphocytes, then you will call it a small cell lymphoma. Now you have to remember thing that sometimes in a neoplastic process, that even you may not have histiocytes, or histiocytes which are quite looking abnormal, or the lymphocytes also which are reactive, they also start to look atypical. So in such scenarios, you have to have experience only to say when you have to say small cell or a large cells. But you can also take help of RBC. If there are RBCs there nicely seen, which are intact RBCs, the RBC is as size of the small lymphocyte nucleus also. So if there is, you can't make out on a lymphocytic size or small lymphocytic size, you can take off of RBC also. So first I will start with the lymphomas which show you nodular pattern, or what we say interchangeably follicular pattern. So if you in those patterns, what you have to actually first segregate whether it is a normal reactive pattern. Dr. Borges has already told you like how do you say something is reactive follicles versus neoplastic follicle, and I will repeat it again in my few of the slides. But if it is a normal reactive process, what you encounter in a lymph node is a follicular hyperplasia, or something what is called as progressively transformed germinal centers. Now progressively transformed germinal centers is a mimicker for a nodular lymphocyte predominant Hodgkin's lymphoma. I am sure it will be covered in the afternoon lecture. So I will be mostly talking about the abnormal process here. Now Hodgkin's lymphoma, both types, classical and nodular, do show you a nodular pattern. Again, I will not going to talk about it because it will be covered. So I will be basically talking about these four nodular type lymphomas, which is follicular lymphoma, mantle cell lymphoma, small lymphocytic lymphoma, that is what we call SLL or CLL, and marginal zone lymphoma. Now what you have to remember that all these four lymphomas can also show you diffuse pattern. So but I will be covering this during this lecture about the nodular lymphomas. Now you see this case wherein this is a 60-year-old some of my slides are moving there but not moving here, so कुछ नहीं होता है. इसमें भी नहीं होगा ना. You can't say all. Finish.
फिर से क्या एक बार
हाँ चलेगा.
Yes ma'am, yes ma'am.
वो भी क्लोज कर दो आप.
हाँ.
प्रेजेंट करना. अभी आ गया. Okay, sorry for that. So this is a 60-year-old female who presented with generalized lymphadenopathy. Now this is what you will see, this recurrent history like in low-grade lymphomas which have a nodular pattern. You will have this kind of history. Mostly they will have a generalized lymphadenopathy. So 60-year-old female, which she has got a generalized lymphadenopathy, and this is a lymph node biopsy. What you see here, if you can see, you can definitely make out that these are follicles, right? These are follicles of almost of the same sizes, and they look quite monotonous looking follicles. What you don't see here, what you see here actually is the follicles which are trying to hug each other. They are quite crowding. These follicles are crowding. That much you can make out on a low power field. And if you take really nice thin section, then sometimes that can be a clue on a section that there is some cracking or a thing starts to happen between the follicle and the adjacent lymphoid cells or the stroma. So that thing you can see sometimes in a follicular lymphoma. So that is what it is seen here. And then you see the follicles which are of different sizes, but they still look quite monomorphic follicles. They don't show you kind of polarization which you expect in a normal follicle or a reactive follicle. Here you see these quite monomorphic looking follicles of different sizes, very close to each other, and you hardly see any mantle zone here. It is almost thinned out, very atretic or atrophic mantle, whatever you want to call it, but it is thinned out actually. So you hardly see any mantle, very little mantle, and then you have these follicles of varying sizes. And then you have to go on high power and check what kind of cells which are seen within the follicles. Note that in these follicles you don't see any tingible body macrophages. If you see tingible body macrophages, most likely that follicle is actually a reactive follicle. But here this is a neoplastic, but you don't see tingible body macrophages, and in you see that there are only probably two type of cell population. One is this small or rather intermediate size cells which have got elongated nuclei and can have a clue the grooves which they are like a centrocytes. And then you have some large nuclei which have nucleoli. I will have some maybe higher power view also to show you, which are then called centroblasts. And you have seen how to recognize the centroblasts earlier. It was mentioned in the earlier lecture. So if you have a population which is mix of centrocytes and centroblasts are not that many. So it definitely looks like something which is a low grade follicular lymphoma because there is a grading system to it, and I will come to it. So this looks like definitely on morphology. I am dealing more with a follicular lymphoma rather than follicular hyperplasia. But in order to distinguish between the two, you have to do immunohistochemistry, and then you resort to immunohistochemistry. What you see on a CD20, and that you have to see critically, that if CD20 is positive in follicles, it is not only positive in follicles, but it's within the interfollicular cells also. So what has happened that the neoplastic cell population is not only restricted to the follicles, but it has spilled beyond the follicles. That means this is a lymphoma which is invasive lymphoma. You don't talk about invasive lymphoma or non-invasive lymphoma, but you have to remember there is something called as in situ follicular lymphoma as well. So if you had something like that, which is very, very rare occurrence, but when you say follicular lymphoma, you will see that neoplastic cells are not only restricted to the follicles, but they have extended beyond the follicle into the interfollicular area. If you see the CD20 like that, you should know that this is follicular lymphoma. But you can take help of other markers. Definitely you have to do it. You just don't do one marker and then arrive at a diagnosis. You do other markers to make your diagnosis foolproof. So this is a CD3. CD3 is there in more of interfollicular areas and very less in the follicles. And as you have learned already, that there is some cells which are positive in follicles also. These are CD3 positive follicular Herpel T cells. These are not the neoplastic cell population. This is not, these 3 positive cells are not cells of interest. Then you see, look at the CD10. So once you know you are thinking of follicular lymphoma, you have to do marker for follicular center cells, which is CD10. And then CD10, you see they are nicely positive in follicles, but it's also again spilling into the interfollicular areas. That is again a clue when you are trying to differentiate from follicular hyperplasia versus follicular lymphoma. And of course, BCL2 you have to do. BCL2 is positive within the follicular center B cells, and it is also positive within interfollicular areas. So I think the role of BCL2 has already been highlighted. And you see the MIB1, very, very less MIB1, even maybe up to 10% or so. That is also characteristic when you see a follicular lymphoma, which is of a low grade, that MIB1 will be very low, whereas in reactive follicles you have high MIB1. So this diagnosis is clinched on doing all these markers, CD20 being positive, CD10, BCL2 being positive. Sometimes you can also use BCL6 and for showing that these are follicular center B cells. If you see in a node where the follicles, which are looking abnormal follicles, which are outside the nodes, like this is in the adipose tissue, adjacent to the nodes in the adipose tissue, the moment you start to see this extranodal disease, you have to think that this might be dealing with a lymphoma. That is a good clue when you are trying to evaluate a lymph node. So if you have to just again repeat what was said earlier by Dr. Borges, that how do you say something is follicular hyperplasia versus follicular lymphoma? If you see this follicle is a reactive normal follicle, and what we say is that there is a polarity is maintained. In the sense, you will have one side which is a dark zone, which is mostly of a centroblast, and then you will have a light zone which is mostly containing of centrocytes along with FDC cells, follicular dendritic cells, and then you have mantle zone around it. So mantle zone towards the actually light zone is usually thick, and towards the dark zone is usually thinner mantle zone. So that's how the polarity of the follicle is described. If that is maintained, that means this follicle is reactive follicle. Versus in a follicular lymphoma, you don't see that polarity. You don't see those nice thick and thin mantle on one side. You don't have a segregation of dark or the light zone, and you see the very monomorphic looking follicle. And then if you do CD20 in a reactive population, you'll only see nicely positive CD20 in the follicles, very little or anything within the interfollicular areas, these CD20 positive B cells. But CD20 in follicular lymphoma will not only be in the follicles, but will also within the interfollicular areas. If you do CD10, CD10 is only restricted to the follicular or germinal centers only, not in the interfollicular areas, not even in the mantle zone. But if you do the CD10 in follicular lymphoma, it is there in follicles as well as in the interfollicular areas. BCL2 has already been told that BCL2 in reactive process is in all cells except follicular center B cells. So you will in T cells as well as cells in the marginal zone or the mantle zone, but not in the cells which are in the follicles, which are of a B type. T cells again in the follicles will express BCL2. MIB1, you have to compare this MIB1 in follicular hyperplasia versus follicular lymphoma. You see this polarity maintained in a MIB1. Again, in the dark zone, you see a lot of MIB1 there, almost going up to 90%. And then it is little less in the light zone of the follicle. Whereas in MIB1 in the follicular lymphoma will be low. And it is not like what you see in the reactive lymphoid follicles. So follicular lymphoma, if you have to know something about it, that it is the second common non-Hodgkin's lymphoma, and the first common is diffuse large B-cell lymphoma. In Western country, they say that they have more follicular lymphomas. Almost 20 to 20% of their lymphomas are actually follicular lymphomas, and maybe even in our country that will happen sooner or later. 80% of all follicular lymphomas are systemic nodal tumors, but you get extranodal disease as well. Median age is usually elderly patients 60 to 65 years, and they show you this specific translocation, which is translocation 1418, and that is found in 85% of the follicular lymphomas. And the grading of the follicular lymphomas, which is based on seeing how many centroblasts are there per high power field. You have to take into consideration 10 consecutive high power fields when you count it. And if the centroblasts are anything between 1 to 15 centroblasts per high power field, then you call it something called as a low grade follicular lymphomas. There also there is a grading of grade 1, grade 2 and grade 3A. That is not now recommended by new WHO. It says that anything which is grade 1, grade 2 or grade 3, you can just call them as a classic follicular lymphoma, and you don't need to differentiate between grade 1, grade 2, grade 3, because they have found that there is hardly any prognostic significance to this kind of grading. There is a lot of inter-observer variability. Somebody says this is grade 2, somebody will say grade 3A, so that is also there. So basically you just lump them and call them classic follicular lymphoma. And what in the older classification was a follicular lymphoma grade 3 is now called follicular large B-cell lymphoma. Why? Because these are the lymphomas which actually behave like a diffuse large B-cell lymphoma. They are actually little different even on a genetic front from the usual low-grade follicular lymphomas, and they are treated like diffuse large B-cell lymphoma. So you just call them follicular large B-cell lymphoma. And how we make that grading? When you see only the sheets of centroblast on per high power field, and there will be absence of centrocytes. If you see that kind of morphology in follicular lymphoma, then you make that diagnosis. Now there are already mentioned that there are follicular lymphoma which have got uncommon features like blastoid or large centrocyte type follicular lymphoma, and there is a follicular lymphoma which has got a diffuse pattern which also expresses CD23, and it's usually BCL2 negative, or it doesn't show you BCL2 translocation, and those usually occur in inguinal region but can be seen in other areas as well. So this is a follicular lymphoma grade 3B or a follicular lymphoma, large B-cell lymphoma, wherein you see that these are all the centroblasts, and you don't see any centrocytes in this. So once you see like that, you say this is follicular large B-cell lymphoma, and you see now the MIB1 is quite high in this, as opposed to what are the example of low-grade follicular lymphoma. So just I wanted to tell you about the BCL2, the clone which we use sometimes can be negative even in when you are suspecting follicular lymphoma. The usual clone can be negative also, so you might use a clone which is, there are other clones available like E17 or E36, and those can be positive. So your usual clone is negative for BCL2, but you can try the another clone where it will come positive, and because you are strongly suspecting, you can use those clones. Now this is also a 56, another example of a nodular lymphoma. You see 56-year-old male, and this patient has only got axillary lymph node, no other lymph nodes are there. So this is single node, 56-year-old male, and what you see on the low power, you make out these are the nodules, right? Nodules or follicles, whatever you want to call it, and they are quite close to each other. They are almost hugging each other. They are quite crowding. So you think that this is definitely going to be something which is like we are dealing with something like a nodular lymphoma. Again, you move on to little more another power, and then you again see this like nodules or follicles, and which are quite close to each other, of almost like a very monomorphic looking, one should say. And if you see on little on high power, one start to see that the cells are composed of mostly of this very small looking cells. They look small cells, and then interburst are like this large histiocytes. But if you see the cell population on high power, you can make out these are like a small cells. They don't look like usual centrocytes, and you don't see anything like a centroblast, but definitely it looks like a nodular lymphoma. In such case, you have to resort to IC to differentiate different nodular forms of the non-Hodgkin's lymphoma. But it definitely looks that it could be it looks like a low-grade lymphoma. You hardly see any mitosis or apoptosis. Then you do the markers. Now you see the CD20. Is CD20 positive in these nodules? No, it is not positive in nodules. You can make out that these nodules are negative, and the interfollicular cells have taken the CD20, and even on the high power you can make out these nodules are not CD20 positive. So what are these positive? These are actually positive for T cell markers, CD3 and CD5. These are T cell markers, and you see that the nodules are T cells, and you don't see any, because these nodules are T cell rich. You may think that you might have missed some Hodgkin's or RS like cells in that, and so the CD30 was done, but you don't see anything which looks like a Hodgkin's cells or RS like cells. Again, I have to tell you, because I said that I did CD30 to check for Hodgkin's lymphoma. But if on a morphology you are not sure if that is a Hodgkin's or RS like cells, then interpreting CD30 is also very critical. You don't interpret anything which is like you say, because CD30 is showing large cells, this is Hodgkin's lymphoma. You have to be very sure on your morphology that those cells are actually like RS cells or Hodgkin's cells. Then only you make that diagnosis. Do not rely solely on CD30. And you see that those large histiocytes which are there are CD68 positive, and CD23 do show the preserved FDC meshwork in those nodules. It is not disrupted. Again, if you want to show something which is a T cell lymphoma, you try to show whether there is a loss of any T cell antigen to say if it is a neoplastic process. So that's why this all T cell markers are present. CD2 is preserved, CD4 is also preserved and expressed. CD8 is less than CD4, and CD7 definitely looks down-regulated when you compare with the CD2 or CD3, CD5. So definitely looks like this is an abnormal population. And if you do the CD10 and PD1, these are the marker for follicular helper T cells. You see that these follicles have taken up CD10, which is weakly, and as well as PD1, which is nice positivity. So these actually are T cells. These nodules are T cells. They look neoplastic. Why? Because there is a down regulation of CD3 and it looks abnormal on morphology. And they are follicular helper T cells because they are expressing two follicular helper markers, CD10 and PD1. So this is actually a follicular T cell lymphoma. It's very, very rare. Because I am talking about follicular lymphoma, which is B cell lymphoma, more common, but there is a variant of a T cell which is a follicular helper T cell lymphoma, which has only follicles and very indolent tumor it is. And this tumor can have two patterns. One is a follicular lymphoma-like pattern or PTGC-like pattern or progressively transformed germinal center-like. And it is, as already mentioned, it is a TFH phenotype. It has overlapping features with angioimmunoblastic lymphoma, and it often presents as a localized disease and very indolent course it has. So again, if you have to say that the nodular lymphomas, if you categorize them from smaller nodules versus very large nodules, usually the larger nodules are seen in these conditions: progressively transformed germinal centers, nodular lymphocyte predominant Hodgkin's lymphoma, as well as classical Hodgkin's lymphoma. And the small or indistinct nodules which are seen are mostly in lymphomas like mantle cell lymphoma, marginal zone lymphoma, also CLL and SLL, and we have already seen follicular lymphoma. So this is a case of a small lymphocytic lymphoma. What you see here, you can definitely make out even on the low power, it looks so blue, it looks so monomorphic at least. And what I'm trying to see is whether I see any, is it a diffuse pattern or a nodular pattern. Now sometimes that can be challenging in the cases like this, that you on a low power may not be able to make out something is nodular or diffuse. Then it is not a bad idea to lower your condenser and see that whether you can make out some nodularity to this proliferation. That can also be done. But as you gain more experience, you don't need to do this lowering of the condenser. You just start to realize that, okay, this may be diffuse or nodular, and this probably is a nodular because you can make out there are some pale staining nodule like this in between these, quite closer to each other. And if you move on to high power, you start to see them better. There are some these pale staining areas are there. These are small nodules. What you call them, actually these small nodules are in CLL, SLL, what you say them is proliferation centers. Those look pale because they have some cells which are little larger than what usual the neoplastic small cells are there. So these are also called pseudo follicles because they are not like actual follicles. These are like a pseudo follicles and also called proliferation center. If you go on to move power and you start to see that there are mostly the small cells and nucleus are quite round, and then in between there are some large cells. Again, it is better seen on the high power. You see now, these are mostly small cells. You have a chromatin which is like, there are like a chromocenters all over. It's not like a prominent nucleolus is there, and very round nucleus, very round. It is not irregular nucleus, very round nucleus having chromatin which is clumped and giving like a chromocenter like thing. And then you have these large cells, little larger than the small lymphocytes, maybe 1.5 times these lymphocytes, and you start to see the prominent nucleoli in them. See here, these are called paraimmunoblasts. These are called paraimmunoblasts, which you see in a proliferation center in SLL, CLL. And some of the small lymphocytes can also see something like a prominent nucleolus and some little vesicular chromatin. Those are usually called pro-lymphocytes. So in a proliferation center, apart from small lymphocytes, you do see some paraimmunoblasts and some pro-lymphocytes. And if you see this morphology, this perfect morphology, then even on HNE you can make this diagnosis that this is a CLL or SLL or small lymphocytic lymphoma. And some people believe that this chromatin is like a soccer ball like chromatin, where you see this alternate dark and light zones are there in the nucleus. The chromatin looks like that. So if you do the IHC, you will see that because it is a B cell lymphoma, CD20 should be positive. You see hardly any CD3. CD3 is there in reactive small T lymphocytes, And of course, CD5 is positive. It has to be CD5 and then CD23 positive. So with this, only this much also you can make the diagnosis that this is small lymphocytic lymphoma. But you have to show that there are other markers which are negative, like CD10 is negative, BCL2 is positive, and MIB1 is very low. Now you might ask that it was already reiterated twice by me and madam also, that BCL2 is used in making diagnosis lymphoma, for a diagnosing a lymphoma I am saying, only in situation where you have a problem to distinguish between follicular hyperplasia and follicular lymphoma, then only it has got a significance. Otherwise, for making a diagnosis, you don't need to use BCL2, but here it has been used. And now you may ask why I did that. I think it was done by my over enthusiastic resident, which, you know, when you say low grade lymphoma, you put all the markers, and BCL2 was also put, and obviously BCL2 is positive. It was going to be positive. It was not required here. So do not do BCL2 unless you have to differentiate between follicular hyperplasia and follicular lymphoma. So SLL, CLL is an indolent mature B cell disease. Most often they may come with no B symptoms actually, and patient will have multiple lymph nodes, can show you splenomegaly, and they usually can present with anemia, thrombocytopenia or neutropenia. These are the symptoms when they start to present with, then they are needed to be treated. They can also be associated with autoimmune hemolytic anemia and extramedullary involvement of the sites like liver, skin, GI mucosa or kidney can also be involved. What you have to remember that the CLL, SLL can go transform into something like a high-grade lymphomas, what we call is a Rister's transformation, wherein it gets transformed into something which is a more high-grade. It looks more like a maybe high-grade B-cell intermediate type or DL B-cell type, and you will start to see very confluent areas of large cells. There is a rare Rister's transformation which has been described is called as Hodgkin's lymphoma-like, wherein actually Hodgkin's lymphoma is developed within the CLL and SLL. You have to have a background of Hodgkin's lymphoma within that, like lymphocytes or histiocytes, and then you see the RS-like cells, then only you say Hodgkin's lymphoma transformation in CLL, SLL. Otherwise, a CLL, SLL can also have a large cells which are RS-like cells. So you do not make that diagnosis of Hodgkin's transformation if there is no background of the Hodgkin's lymphoma there. Pro-lymphocytic progression already has been touched upon, so I will not mention. Now you moving on to the other nodular type lymphoma, which can also show diffuse areas, but this is a mantle cell lymphoma. And here you can make out that there is some vague nodularity here and looks quite monomorphous. Again, on the low power only one can make out it looks quite monomorphic and looks like it is a single cell type lymphoma. And then you see the other area of the lymph node, you start to see that there is definitely nodularity here. You can make out the nodules here. They are a little larger than what you expect, but they are still there. There is nodularity. And what you see here, there is a adipose tissue, right? And the lymphocytes are infiltrating into the adipose tissue. That is a clue that you are dealing with something which is a neoplastic or probably a lymphoproliferative lesion. And then moving on to a little higher power, you start to see these hyalinized things. These are hyalinized vessels. So in mantle cell lymphomas, one of the clue is that if you see this kind of population, monotonous, nodular, and you see that some hyalinized vessels, you start to see, you have to think that it could be a mantle cell lymphoma. Another clue is that you start to see these pink histiocytes, large histiocytes, these pink histiocytes. So hyalinized vessels, pink histiocytes, and then you start to see these lymphocytes. Now lymphocytes, if you see, are not like round what you saw in CLL and SLL case. They are quite irregular. They are quite irregular lymphocytes. So these are like a small, what in old days they used to call it small cleft lymphoma. So these are quite irregular and quite hyperchromatic. You don't see any nucleolus in that. So that is a clue again in mantle cell. Remember, small cells but irregular nuclei, and then you do appropriate markers to clinch the diagnosis. CD20 has to be positive because it's B cell lymphoma. Then CD3 is negative, CD5, then CD23. So mantle cell lymphoma by definition should be CD5 positive. Now you may ask that if you see that whether this CD5 looks negative actually, but then you compare it with CD3. you see that in CD3 you have very strongly positive small lymphocyte, T lymphocytes, and then these areas are hardly any staining there. They look quite blue. Now you look at same areas, you start to see that apart from some darkly stained cells in CD5 which are actually reactive T cells, you see that there is some at least blush-like or maybe weak positivity in these cells in between. So I believe that there are cells which are not taken up by CD3 are actually showing weak expression, which is also clue that this is could be a mantle cell lymphoma, which is showing a weak CD5 positivity. It is CD23 negative. If I am saying there is a CD5 expression, then CD23 should be negative, because if CD23 was positive, then you will make that diagnosis as SLL CLL. You again, if you see the CD5 on higher power, you tend to see that there are these weakly positive cells in between, which are actually not T cells but a B cell. So when you are always comparing CD5, you have to compare it with the CD3, because CD5 being a T cell marker, it will be there in T cells, but what the cell population or the population of interest is actually 20 positive or CD3 positive, and then you have to compare it with the CD5. Say cyclin D1 is negative in this case. Now you must have heard cyclin D1 is the marker for making the diagnosis of follicular lymphoma, which is negative. Now what should I do? Whether I should do some other marker? Very good. So SOX11 is another marker you can do when there is a cyclin D1. You have strong suspicion on histology itself that it is a mantle cell lymphoma, but your cyclin D1 is negative. So you do another marker which is a SOX11, and this is a SOX11 positive, cyclin D1 negative mantle cell lymphoma. Then you may ask why cyclin D1 is actually negative in this case. So if you know that the mantle cell lymphoma shows you 11-14 translocation, one of the pattern is cyclin D1, CCDN1. But if that is not a DN1, it can be DN2. It is cyclin D2, cyclin D3, or cyclin E. So if the partner is something which is a rare partner, you will get a cyclin D1 negative, but SOX11 will bail you out. And this case is showing fair, it's a high MIB1 index, even though it is categorized as a small B cell lymphoma, can show you high MIB1 index, and that is very important prognostic factor for mantle cell lymphoma. So you should never give out any report of mantle cell lymphoma without MIB1. You have to do MIB1. It is compulsory because it is one of the prognostic factors. And whatever they have found that more than 30% if the MIB1, those patients do not do well. So you have to give mantle cell lymphoma diagnosis with the MIB1 proliferation index. Mantle zone lymphomas can show you this three type of patterns. This is mantle zone pattern, wherein you see the follicles are there in between small follicles, and then mantle zone is expanded. You have nodular type of pattern which we saw, and then you can have a diffuse pattern. Now in order to know that these lymphomas can have this kind of patterns, it is very important that you pay attention to morphology, because that can also challenging if you are not got the whole node biopsy. This day and age you are going to get only true cut biopsies, and on true cut biopsy you may not be able to see the nodular pattern. So if your histology or a cellular morphology, if you are not seen properly, then also you will be in trouble. This is something which shows you what is mantle cell pattern. You see there are follicles, and then this is a German central which looks relatively normal, and then you have this very expanded mantle zone, and also these same cells are going within the interfollicular areas. You see again on the high power, these abnormal cells which are there in mantle zone, and then those are also going beyond the mantle zone also. You see that cyclin D1 is only taken up in all those cells, and the normal general center has not taken. So this is like a mantle zone pattern of a mantle cell lymphoma. So if you see this two high power field, which one is you think is a mantle zone lymphoma, MCL? Can you make out for postgraduates? This is actually mantle zone lymphoma, and this is what it could be. This looks like a follicular, right? And this is a mantle. If you see, the small cells or whatever centrocyte-like cells are like quite elongated nuclei. Quite elongated nuclei you see. They are not like this, smaller and irregular. They are irregular, but their nuclei are quite elongated, like stretched out nuclei. You might be able to see grooves also in them. So these are like a centrocytes. Very rarely centrocytes can look abnormal, but normally this is how centrocytes look. So this is mixture of centrocytes, and this is like a centroblast. If you see the large cells with 2 or 3 prominent nucleoli, and some of them are hugging actually the nuclear membrane. This is a centroblast. And what are these cells? These are 2 nuclei coming together, kissing cells. These are actually FDC cells. So you should be able to make out what is the cell population here. So it is mostly centrocytes, very few centroblasts. So it looks like this is from a low-grade follicular lymphoma, as opposed to this is a mantle cell lymphoma, wherein see small cells with irregular nuclear contours. Now this is a true cut biopsy. I was telling you, like, you know, you will get more of a true cut biopsy. Here in true cut biopsy, there is an abnormal lymphoid population. I am saying abnormal because I can't make out if there is a reactive follicle or a zone which is like intrafollicular zone. So I am saying this is definitely looks like a abnormal population, and then you go on hyper and you definitely see that this is an abnormal lymphoid population. And the cell size here, there are even some intermediate cells or small cell, but there are definitely large cells also. It is low power, so you move on to the high power, you start to see there is some even like a giant cells. And then there are some very large cells here and there, and then some background, some small cells are there. So it has a kind of pleomorphic or polymorphic like morphology, and you do the markers, it is CD20 positive, CD3 negative, CD5. So as I said, you always compare CD5 with CD3. CD3 is negative, but CD5 is positive. That becomes a clue. Even though it is a T cell lymphoma, it is positive in CD20 positive B cell lymphoma. That means it's an abnormal, it is a neoplastic. So it is a CD5 positive, and as well as cyclin D1 lymph positive. So this is a mantle cell lymphoma, which has got very odd morphology. What odd morphology? That it has got a pleomorphic cells in it, and it has very high MIB1 index, almost going up to the 90 or maybe even more than 90%. And this is actually a pleomorphic type of mantle cell lymphoma. So you have to remember that you can get a blastoid mantle or pleomorphic mantle, and you try to make that diagnosis also. You have to have a high suspicion for this kind of variants of mantle cell lymphoma, because they do very badly. Means the prognosis is not good. So mantle cell lymphoma mostly present with stage 4 disease in 70% of the cases. There are 2 types. One is one more aggressive, which has got nodal presentation, which is SOX11 positive, and there is more indolent one type, which is SOX11 negative and present as a leukemic form, and very rarely nodal disease. So these lymphomas present with generalized lymphadenopathy. They can present with hepatosplenomegaly, peripheral blood. In most cases, they say you will see atypical cells in the peripheral blood, and leukemic diagnosis can be there at the time of presentation, anywhere between 20 to 70% of the cases. And something you have to remember, that intestine, there are like a type of mantle cell lymphoma can be there, which is seen as a polyps, multiple polyps, which is called as lymphomatosis polyposis. And the usual classic mantle cell lymphoma can progress on recurrence or relapse as a blastoid or pleomorphic variant. And the biomarkers which new WHO says are of high risk in mantle cell lymphoma are, one is a cytomorphology. That's why you should be able to diagnose blastoid and pleomorphic variant. High key proliferation index, P53 expression by ISC also. So they recommend that if you are diagnosing mantle cell lymphoma, apart from giving MIB1 index, one should try to do even P53 immunohistochemistry. If it is overexpressed, those also are going to do badly. The prognosis will be bad. And obviously T53 mutation, when you do the molecular studies, any P53 mutation in follicular lymphoma is of bad risk or high risk. Now we are coming to the last of the nodular lymphoma, which is the marginal zone lymphoma. And here you start to see that again looks monomorphic, even on the low power, looks quite blue. When I say looks quite blue, that means these are cells which are small and they don't have that much of cytoplasm, because cytoplasm looks eosinophilic. If it was looking rather eosinophilic, the appearance on the low power, one would have thought that there are either large cells having lot of cytoplasm, or there are mixture of cells which are like histocytes and other which have got more cytoplasm. But here it looks quite monomorphic, and you can make out on the low power also that there is a nodularity to this infiltrate. It is an atypical infiltrate. Nodularity to it, you can again see in this power also nodularity to it. And then I will go to one more high power. You see this small atretic germinal center, and then there is an expansion of this zone by this atypical appearing small lymphocytes. I mean that you are seen in a something like a mantle zone pattern of mantle lymphoma also, but this lymphoma, marginal zone lymphoma, also shows this kind of pattern, where small follicles and then expansion of these cells. cells can have a monocytoid look. That means they have slightly irregular nuclei and little more cytoplasm. Not so large, but can be cytoplasm is there. So you tend to say this is monocytoid differentiation in there. You don't see much plasma cells, but marginal zone lymphomas can show you plasmacytic differentiation. That is also clue that in a small cell lymphoma having small cell morphology, you start to see more of a plasma cells. You might be dealing with marginal zone lymphoma. And then you do the ISC. On ISC, marginal zone lymphoma is a diagnosis of exclusion. When I say that, that means I am trying to say that once you rule out follicular lymphoma, mantle cell lymphoma, and you rule out CLL and SLL, then you can make the diagnosis of marginal zone lymphoma, because marginal lymphoma doesn't have a specific markers like you have cyclin D1 in mantle cell lymphoma. You have CD10, BCL6, BCL2 for follicular lymphoma, and CD5, CD23 in CLL, SLL. So here, if you do the IC, you will see CD20 is positive, CD3 is negative, as compared to the 5, CD3, 5 is also negative, and CD23 is there in a FDC meshwork, which are like a small and somewhere slightly enlarged, but it's there. So there are small follicles are there. There is no CD10, there is no cyclin D1, there was no SOX11 also, and ME1 is quite low. So this is what I was saying, this is a diagnosis exclusion. You can only prove that this is B-cell lymphoma. You have ruled out other special types. So then like a CLL, SLL, mantle and follicular, then you make this diagnosis of marginal lymphoma. Again, marginal zone lymphoma can show you these 4 patterns. One is a diffuse pattern, another is nodular or a follicular pattern, another is an interfollicular pattern. That means you will have a normal looking reactive follicles, and then interfollicular areas will have this kind of cellular population, and then something which is called as a perifollicular pattern. So this perifollicular pattern is very rare, difficult to diagnose, but you can encounter in sometimes in your practice. So marginal zone lymphoma is usually a localized or generalized localized disease, or can also present with generalized lymphadenopathy. Bone marrow involvement can be seen, and peripheral blood is very rarely involved in this. B symptoms are rare. Mostly you can they come as a asymptomatic lymphadenopathy, and you have to have clinical and radiological evaluation to rule out something which is like a extranodal marginal zone lymphoma or splenic marginal lymphoma, now which is secondarily involving the lymph node. On histology and just by markers, you may not be able to distinguish between these 3 types of marginal zone lymphoma. That's why you have to have clinical and radiological evaluation. There is rare variant which is pediatric marginal zone lymphoma. We don't need to go in details, but these are usually occurs in children and have more indolent course. They have indolent course, marginal zone lymphoma. Survival is 5-year survival is anything between 60 to 70%. And the worst prognosis is when you see the factors like advanced age, high clinical stage, or B symptoms. And so just to summarize about these 4 lymphomas, what you see in SLL and CLL on low power is that you see diffuse infiltrate, you see pseudofollicles or proliferation centers, and the nuclei are round. Whereas in marginal zone and mantle cell lymphoma, you have nuclei which are slightly irregular. And in marginal lymphoma, you will have a marginal zone expansion or a diffuse expansion. You can have follicular colonization and a plasmacytic differentiation. Whereas in the mantle cell lymphoma, you can have diffuse or nodular infiltrate. You can have mantle impaction and atrophic germinal center. And follicular lymphoma has been described in details. So what we do in our lab, this is my last slide. What we do in our lab, we start with these 5 markers. If any lymphoma which comes, which is like small cell morphology or a morphology which I am not able to say whether it's small, intermediate, then we resort to this panel, CD20, CD3. First panel is CD20, CD3, CD5, CD23 and CD10. Now this panel is useful not only diagnosing small B-cell lymphomas also, but if you have doubt, like it could be something like a T-cell lymphoma also is very helpful, because if you are CD20 positive, that means it's a B-cell lymphoma. With that, if you do CD3, which is CD3 negative, that means it is not a T-cell lymphoma. If it is B-cell, then you do is what is CD5. If CD5 is positive, and then along with that CD23 is positive, that is SLL and CLL. CD20 positive, CD5 positive, but it is CD23 negative, and then it is positive for cyclin D1 and or SOX11, then it is a mantle cell lymphoma. CD20 positive but it is not CD5 positive, then you do CD10. If it is CD10 positive, you do other markers like BCL6 and if required BCL2. Sorry. And then if these markers are positive, you make a diagnosis of follicular lymphoma. If there is no CD5 or CD10, then you think of a marginal lymphoma. As I said, it is a diagnosis of exclusion. Now the literature is talking about there are two markers like IRTA1 and MNDA markers which are shown to be positive in marginal zone lymphoma, but they are not 100%. All these markers comes only in some 40 to 50% of the cases. And what you have to remember is that CD43 immunostain is also can be seen in up to 50% of the marginal zone lymphoma. So if you have something like that, you might do CD43, and if it comes positive, then you can also suggest that it is a marginal zone lymphoma. So with that, I will end my talk. Thank you. I think I have overshot my time, so maybe. Do I have any questions for me? Looks like they have understood it, so. Thank you.
Sir, please, one second. I would humbly request Dr. Manan Jadhav, Associate Professor, to present Sir with a memento. I would now request Dr. Falguni ma'am to present a memento to Dr. Hansa Goswami ma'am, and may I please welcome both of them on stage. We will now pause for a 30-minute tea break, and tea is being served opposite the central library area at boys and girls common room respectively. Dr. Pravin sir's lecture. And so may I please call upon Dr. Pravin sir for his lecture.
अच्छा इनको बंद कर दिया. Okay, then now we'll move. Before the tea break, I did about lymphomas, basically non-Hodgkin's lymphoma, which show you nodular pattern. And now we will move on to lymphomas, which show you diffuse pattern. Now, if you see in a diffuse pattern, again, I will tell you that you have to look when you see something like it looks like. When you say something diffuse, that means you are not seeing any nodules or follicles. That time you will say this is a diffuse pattern. And once you know that this looks like diffuse pattern, what you see is, again, you see what is a cell type, whether it is a single cell type or whether it is a mixed cell type. So in single cell type, like in small cell, we already touched upon the small cell or low grade lymphomas, which are nodular as well as diffuse. So I will not talk about those now. Then you have intermediate size cells where you have two types of lymphomas, which is Burkitt lymphoma and lymphoblastic lymphoma. And then in large cell diffuse lymphomas, you have large B cell lymphomas. And in T cell lymphoma group, you have something called as ALCL, which is anaplastic large cell lymphoma. So if before we move to the actual cases, I would like to tell you, like I have already mentioned in one of my slides in the previous lecture, that how you say something is blastic or blastoid. Now the blastic term you usually say for immature lymphomas, and in lymphoma you have a lymphoblastic lymphomas. So either it is a B lymphoblastic or T lymphoblastic, and then you have a blastoid lymphoma, which is actually variants of a mature lymphomas. Now it can be very difficult sometimes to tell something which is blastic and when you say blastoid. Now blastic term you only reserve for lymphoblastic lymphomas. Blastoid is something which looks like blast, and it is seen in other type of mature lymphomas. It is difficult to say. As you can see, there are two type of cases here, A and case B. And if you look at these morphology here, just on these pictures, you can't say which is blastic and which is blastoid. It's very difficult because the cell size is intermediate in both. You see the chromatin, which is like a very fine, evenly distributed chromatin in both cases, and you don't see nucleoli or vesicular type of chromatin in both the cases. So you can't tell which is blastic or which is blastoid. So case number A is actually, when you see the history, then things starts to fall in its place. Now the history is, in case A is a 9-year-old boy. This is a cervical lymph node, probably a supraclavicular lymph node, and patient also got a large mediastinal mass, and because there was this supraclavicular lymph node, they biopsied it. Actually it is not very large lymph node, but you can make out this is complete slice of a lymph node, and you start to see that the sinuses are quite preserved, but you don't see any follicles. You don't see any proper follicles, either primary follicles or secondary follicles. It's something which is happening which looks like quite diffuse here, at least in very scanner power. And then you start to see, on if you move on more 10x, then you see that definitely there is this very abnormal intermediate site cells which are infiltrating in between. This is diffuse infiltrate. Again, on little high power, you start to see that it's as compared to this small darkly stained nuclei which are of a reactive cells, reactive lymphocytes. in comparison to this, if you see these cells of like cells of interest, you see that they have this round, slightly irregular nuclei, very fine chromatin. You don't make out any nucleoli in them, and this is something which looks like a blastic morphology or a blastic chromatin. Again, on high power, same thing. If you compare with a very darkly stained, this nuclei of a round, very clumped chromatin of a mature reactive lymphocytes, vis-a-vis these cells of interest which are of intermediate size, and they have this fine blastic chromatin. Then you do the markers. You have to prove, because you are suspecting a blastic lymphoma, whether it is B or T, and then you do the markers. CD20 is negative, CD20 is positive in this residual, probably a germinal center there, and the cells of interest are all 3 positive. They are also TD2 positive, which is a marker for lymphoblastic lymphoma, and of course CD34 is another blast marker which not only comes in lymphoblast but also can be seen in myeloblast. So this proves that this is a T lymphoblastic lymphoma. The other markers can be positive in this case, or can be CD10 positive, which in those cases you call them CALA positive TALL. And then sometimes you might have to do MPO or c-KIT, because some of the lymphoblastic lymphomas can show you some myeloid markers. They are not, I mean, you can't define just on histology calling them biophenotypic, but you just need to note it whether they are showing some aberrant expression of myeloid markers. You may want to do it, or you can skip it, and maybe it's quite high here. So it is a T lymphoblastic lymphoma. So case A, what I show is actually lymphoblastic lymphoma, which is actually blastic, and this is case B is actually in an elderly male which has got generalized lymphadenopathy. So elderly male, you are unlikely to show the blastic lymphomas. You can, but not the very common case scenario. And what you see in this is a true cut biopsy. You see the fragments of the infiltrate, which is, again, I would say even just by on the low power one can make out it looks quite atypical, because you cannot make out any follicles or interfollicular areas. And you have to observe something, like what you are observing here, something which is anything which is normal, anything you can observe. Here you can make out there are acini which look like maybe salivary gland acini. There are some serous acini and some mucinous acini. So probably this was probably a node which is close to maybe angle of mouth, where, you know, or below the angle of mouth, like a submandibular gland. So that way it gives you clue also where the level of the lymph node also. So again, you see on a high power, same thing, you see these intermediate types of cells diffusely infiltrating and have something, a chromatin which is fine chromatin, which is blastic or blastoid chromatin. And then of course you start to do the immunohistochemistry. First you will have to rule out whether it is a lymphoblastic lymphoma, even for the age, or is it some kind of other blastic lymphoma. Even you have to think in terms of whether it is extramedullary myeloid cell tumor, or it is also called myeloid sarcoma. And of course, if it is a variant of a mature lymphoma which is showing a blastoid morphology. And then you do the marker. This is CD20 positive, so that means it's a B cell lymphoma, that much is sure. And then you do the marker CD3 and CD5. Again, if you see the CD3 is there, darkly stained reactive T cells are there. Vis-a-vis, if you see CD5, there are darkly stained T lymphocytes, but in between cells also probably are weakly positive, and if you see on a high power, they are actually weakly positive. So there is some CD5 expression there, and I had told you if you start to see this weak kind of expression, you should suspect that it could be mantle cell lymphoma also. And then you do see a cyclin D1, and cyclin D1 is nicely positive, and SOX11 is also positive. Now this has proved that this is CD20 positive, CD5 weakly positive, cyclin D1 and SOX11. So it is actually with very high MIB1 index. This is actually a blastoid type of mantle cell lymphoma. I have already shown you what is classical mantle cell lymphoma looks like, pleomorphic mantle cell look like, and this is one of the variant blastoid mantle. You have to suspect it on a you have to have a high suspicion when you are looking at something like this, then only do the appropriate marker to arrive at the diagnosis. So if you encounter anything like blastic or blastoid morphology, you have to first rule out is a lymphoblastic lymphoma. For that you do markers like TDT, CD34 and CD10. Then you rule out blastoid mantle cell lymphoma by doing specific markers like cyclin D1 and SOX11. There is a rare variant of follicular lymphoma, which is a blastoid follicular, and of course you will then do markers for follicular lymphoma like CD10, BCL6. And also, as I already mentioned, you should not forget about myeloid sarcoma or extramyoidal cell tumor, which will be CD20 negative, CD3 negative, but they are most of the times are CD43 negative. So that is a clue. If you are seeing something which looks blastic or blastoid, and you have CD20 also negative, CD3 also negative, but CD43 is positive, that is a clue that you may be dealing with this tumor. And of course, then you can do the specific markers like MP or c-KIT to prove that it is a myeloid, or you may want to do other marker like CD61, 71 to show the expression towards like lineage towards erythroid or a megakaryocytic lineage. So, and you have to remember anything which shows you blastic or blastoid morphology are of intermediate size type lymphomas. Then this is like a starry sky pattern. Why do you see starry sky pattern? Because you have this in between histiocytes which have engulfed the apoptotic bodies, because cells are turnover is so fast that whatever apoptotic bodies are there, they are taken or engulfed by the by histiocytes, and that's what gives you this starry sky appearance. That means in a very blue or a dark background, you are seeing something like a very pale looking large cells which are like a stars in this background. Now, so starry sky pattern, whenever you say the first thing comes in mind is a Burkitt lymphoma. But just remember that not only in Burkitt lymphoma, but any other lymphoma which has got high proliferation index can also show you starry sky pattern. So this is a 39-year-old male and jejunal tumor. So if you see here, you can make out it is a diffuse infiltrate. You don't see any nodularities, definitely. So it is a diffuse infiltrate. You then move on to the another power. You see that it now looks like a quite monotonous, like they are of a single size population, and looks like this is probably a intermediate size cells. Okay. Now you see these tingible body macrophages which has got apoptosis. Those gives you that starry like pattern, and you see now the cells, these nuclei, which are quite monomorphic looking. They have maybe some multiple nucleoli, and if you look closely, what you see is that the nuclei are actually, they are like a jigsaw puzzle. They are settling into each other. They are like angulated nuclear membranes, and they are trying to fit into each other. This is very characteristic of a lymphoma, which is a Burkitt lymphoma. You see that because the nuclei are so closely packed, the nuclear chromatin is so fragile that it starts to actually compress because of the adjacent cells, and that's how the nuclei looks like they have been like put into like a jigsaw. And then you have to prove that because I am suspecting a Burkitt lymphoma on morphology, obviously IHC will be done. CD20 has to be CD20 positive because Burkitt lymphoma is a B cell lymphoma, and it has to be CD10 positive. You can't call anything Burkitt lymphoma if it is not CD10 positive. And of course it has to be BCL2 negative also, but rarely some cases can show you weak BCL2 positive. So any case, if you are suspecting, like if it is an intermediate cell type monomorphic lymphoma which looks like a Burkitt or high grade lymphoma, and your BCL2 is strong, it is unlikely to be Burkitt's lymphoma. It is something like a high grade B cell lymphoma which has maybe a double slit lymphoma or some other variant or NOS high grade B cell lymphoma. So BCL2 has to be negative or can be taken weakly positive or focal positive. Then you do other markers like CME. You know that Burkitt's lymphoma shows CME translocation, but CME immunohistochemistry on protein expression is always see you very diffuse CME positivity. More than 90% of the tumor cells usually show you CME positivity. So if anything less than that or less than 50%, you should rethink whether it is Burkitt lymphoma or not. Then you will have a Ki67 or proliferation index is almost touching up to 100. Anything below 90%, if it is there, again you have to rethink if it is Burkitt lymphoma or not. And if this, let's say the morphology is not so well, because your fixation is not good, your processing is not good, you can't make out the morphology so well, then you can resort to two markers. There is a nice paper by Dr. Naresh which he has given like with the minimum panel how can you make the Burkitt lymphoma, then additional IHC panel how can you make Burkitt lymphoma, and then molecular studies. So he gives them some scores and then they arrive at a diagnosis. So if let's say this morphology was not so like a Burkitt lymphoma, but you have a suspicion because young patient like a right iliac fossa mass or a large cervical mass which is the location for Burkitt lymphoma, and then IHC is not really helpful, like BCL2 looks little weak, then you might resort to two additional markers, CD38 and CD44. Burkitt's lymphoma will show you diffuse CD38 positivity and CD44 is negative. That also gives you a clue that it can be Burkitt lymphoma. So Burkitt lymphoma is an intermediate size single cell type lymphoma. As already mentioned that now, but WHO, this latest WHO expects that you should do EBER-ish or whatever EBER you have. Mostly EBER-ish is only, EBER RNAs by ish is only recommended, that you should do and say whether this Burkitt lymphoma, whether it is EBV associated or not EBV associated. And the typical sites are usually large mandibular or cervical mass or right iliac fossa mass. And then with the typical morphology and those classical immunomarkers, you can make this diagnosis. Now I have covered this intermediate size cells. Then we'll move on to a diffuse pattern which has got a large cells, and we know the definition of large cells already. Like it has to be more than what is a histocytic nuclei, or twice the size of the nucleus of the small lymphocytes. So diffuse lymphoma, like a large cell lymphoma, there are spatial types which are almost 17, Dr. Gujral has already told, and then you have NOS category. When you cannot put them into this 17 categories, then you call it DLBCL, NOS, that means not otherwise specified. And that is in a B cell lymphomas. If you have a T cell lymphomas, you have anaplastic large cell lymphoma as a diffuse large cell lymphoma. So DLBCL definition is already covered, but I will just repeat it once more. It is a neoplasm of mature large B cells. Nuclear size is equal or to exceeding normal macrophage nuclei, or more than twice the size of the normal lymphocyte, and it should show the diffuse growth pattern. Now it has got some morphological variants. Do you need to put that in your report? No, but you should remember it, because if you have problems differentiating it from not just lymphoma but even from other malignancies, can be a differential, especially in small biopsies, then you should know like what are the morphological variants of large B-cell lymphoma. The first is more common and is usually seen in 80% of cases, is actually this centroblastic morphology, wherein you see this nucleus has got a vesicular chromatin and this nucleoli are there. They can be 1 to 3, and then at least 1 or 2 of them can be hugging to the nuclear membrane like this. So this is like a centroblastic morphology. Another morphology is immunoblastic morphology, which is seen in almost 10% of the cases. And you see here, which is very large nucleus having vesicular chromatin and a very prominent nucleolus, which can be basophilic to or amphiphilic to, even here it looks quite eosinophilic. And then you have something called as a plasmablastic. Now plasmablastic is something like immunoblastic, only large vesicular nucleus with prominent nucleolus. But you start to see this chromatin going from the nucleus towards the periphery like a cartwheel-like thing, which you see in normal plasma cells also, and this paranuclear Hoff-like region. If you see this morphology, one would think that this is like a plasmablastic morphology. And then if you can have any combination of multi-nucleated cells of centroblast or immunoblast like nuclei, and then you call them an anaplastic type of morphology. Now very rare and very less commonly seen variants in large B-cell lymphomas can be spindle cells. You can see rosette, you can have myxoid stroma, you can have signet ring morphology as well, and some fibrillary projection sarcoma. So what you have to remember, one, that even if these are so rare, they do not occur as a pure morphology. That means if let's say a tumor which is like a large cell but looks spindly, which is CD20 positive, but it will never be like spindly all over. I mean, if you get a good biopsy, you will see in some areas at least the typical morphology of large B-cell lymphoma, which is not spindle, which does not show rosettes, or which does not show signet ring morphology. So that is a clue. And cell of origin is talked about in details in the morning. So how do we do it, whether you have to do it or not? The recent WHO says it is not compulsory, you may not do it, but we are still doing it because some clinicians do still want it, like you should tell them what is a cell of origin. This all came from studies which were done by, this was a gene expression properly, which were done by NGS, where they found that there are 2 types of this. DLBCL NOLs can be 2 types. One is germinal center B cell and other is activated B cells type. And now when we use immunohistochemistry, then you have to call them GCB, which is germinal center B cell type, or non-germinal B cell type. You don't call them directly ABC type. You have to say non-germinal B cell type. And you use this very commonly used algorithm. There are other algorithms also used to say whether it is GCB or non-GCB, like Choi and Tally. But Hans is the most popular one, which because it uses only 3 markers, which are readily available in most of the labs: CD10, BCL6, and MUM1. And the cutoff for each marker is that if anything is more than 30% positive, then that marker is considered positive. So first you start with CD10. If just do CD10, if CD10 is positive, it doesn't matter what is BCL6 or MUM1, is it positive or negative. If CD10 is positive in more than 30% of the cells, it is GCB-like. It is a GCB-like phenotype. If the CD10 is negative, you do MUM1. If the MUM1 is positive, it doesn't matter what is the status of BCL6, you directly call it non-GCB-like. If CD10 is negative, MUM1 is also negative, then you resort to BCL6. And if the BCL6 positive, you say it is GCB-like. And if it is negative, then you say it is non-GCB-like. Now you have to remember that you you may not be able to classify all the large B-cell lymphoma, diffuse large B-cell lymphoma, into GCB or non-GCB-like. There will be some which are actually can be unclassified, and that is fair enough. You may not be able to classify, then you can write not classifiable by Hans algorithm. And actually, if you match it by whatever this algorithm on IHC or immune expression, what you type them in GCB or non-GCB, 80% of the cases will match with what is the gene expression profile of this lymphoma. So it's not that bad match. It does match relatively better. Now you must have heard 2 things. It was even in the morning lecture you heard like double-hit lymphomas. In the old WHO there was triple-hit lymphoma also, and something called as double expressors also. Now double-hit lymphoma means you are doing something by molecular, by FISH, and you're trying actually to show that there is a translocation of MYC and BCL2. If MYC and BCL2 both are there, it is a double hit. In addition, if there is a BCL6, then they used to call it a triple hit lymphomas. So now these are called actually diffuse large B-cell lymphoma / if it is like a diffuse large B-cell lymphoma, or if it is like a just high grade, very blastoid, intermediate looking morphology, and then you have translocation for MYC and BCL2, you called it with a double hit lymphoma. That means diffuse large B-cell lymphoma double hit, or high grade B-cell lymphoma double hit lymphomas. So most of these are actually of a GCD type, which actually if you say that why they tried to segregate between GCB and non-GCB, because they found that GCB type usually do better than ABC type. ABC type do badly. The prognosis is not so great. But the one what is here, like this double hit lymphomas, even though they are of GCB type, they do poorly. And about 3 to 6% of the all DLB cells are actually double hit or triple hit lymphomas. And double expressor you say when it is actually by immunohistochemistry. That means protein expression. And for that you do 2 immunomarkers, CME and BCL2. So for CME to call it positive, you have to have 40% or above cells positive to say CME is positive. For BCL2, cutoff is 50%. So if these both are positive, then you call it a double expressor phenotype. And most of these cases are actually of a ABC type by gene expression profile. And of all the DLB cells, 25 to 30% of them are actually double expressors. So this has already been, I have just mentioned about it, and Dr. Gujral has also mentioned, so I'll skip it. I am still doing it, although they say it doesn't make sense, but I think I do it because if you see that, let's say tumor is behaving very aggressively clinically, and then I have something which looks like a double expressor, and also it is GCB-like, then they might want to do actually FISH studies. So in that sense, it might be useful. That is the only thing I think that is useful. You have any other suggestion? So the most common marker we do to prove that this is B-cell lymphoma is CD20. It's easily available, very robust marker. In fact, even if the tumor is infected, the CD20 does come positive, and it is actually a savior. It is very good marker. But sometimes CD20 can be negative, so you will have to resort to other markers like CD19, CD79A, PAX5, or CD22 is not readily available for immunohistochemistry. but like OCT2 or BOB1 can also be done to show that this is like a B cell transcription program. Mostly, if you see heavy chains, they are mostly IgM positive, but they can be IgG or IgA positive. I mean, nobody does it usually, but if you want to do it, this will be the expression level. They can express plasma cell markers like CD38 and 138. CD30 is variable, and it can be a good clue, like if you have like a large cell lymphoma morphology, there is like a geographic necrosis, and then CD30 is also positive along with 20. You might think that this could be actually EBV positive large B cell lymphoma. That gives you a clue to do EBER-ish and prove that it could be a EBV positive large B cell lymphoma. CD5 positive can be seen in large B cell up to 10% of cases. If it happens, then obviously you have to do cyclin D1 and SOX11 to rule out whether it is a pleomorphic variant of the mantle cell lymphoma. But just remember that sometimes CD5 negative but cyclin D1 can be positive in large B cell lymphoma. Those are not actually mantle cell lymphoma. There is no translocation 11-14, but cyclin D1 just comes positive. But even if it comes positive, don't call it pleomorphic mantle cell lymphoma unless you have SOX11 also or CD5 also. Cyclin D1 positivity in large B cell lymphoma is shown to be not so diffuse, but it comes like a patchy or weak positivity. NCCN guideline says that you have to minimally do this many markers: CD20, CD3, CD10, BCL6, MUM1 to say whether cell of origin, BCL2 and MYC to say whether it is double expressor or not double expressor, and obviously Ki67 index to show what is the proliferation happening there. And in certain circumstances, you might want to do additional markers like cyclin D1, kappa lambda by IHC or maybe by ISH, and some plasma cell markers like CD138, then viral markers like EBER or HHV8. So DLBCL is actually the commonest non-Hodgkin's lymphoma. Almost 32%, 40% of NHLs are DLBCL. It is very heterogeneous group. That's why they are trying to find out whether, that's why gene expression profile, the study was done to say if they can segregate into something which are prognostically also different, and whether you can handle them differently by how to give the chemotherapy, whether you can treat them differently. That was an idea, because it is like a waste basket term when you can't classify into something which is specific large B cell lymphoma. You just lump them into diffuse large B cell lymphoma, NOS. These mostly occur in adults, but remember it can occur in children also. And they mostly arise de novo, but transformation from low-grade lymphomas like CLL, SLL, follicular lymphoma or marginal zone lymphoma, and also NLPHL can give rise to diffuse large B cell lymphoma. Nodal site is most common, but extranodal sites are involved in 1/3 of the cases, and bone marrow involvement can be anywhere between 11 to 27% of the cases, and sometimes you might see the discordant morphology when the bone marrow is involved. What is meant by that? That in nodal lymphoma, it is a large B cell like a lymphoma, but if you see the bone marrow, it will be like a low-grade B cell lymphoma, anything like CLL, SLL or follicular lymphoma, something like that. So that means what the tumor probably was something to start with, was a low-grade lymphoma, which actually is there in bone marrow, but now it has transformed into, like at the nodal site, into the large B cell lymphoma. I have chosen one of the special type from the large B cell group because you can't talk about everything, just for a reason. This is a 38 male HIV positive, and if you see at this morphology, you can see that there are these large cells which are growing in like a small nest, and also probably cords also, if you can make out, like here. There are like a cords, and in between there are fibrous septae. So it is like a compacting, it's like a packaging. I mean, if you have such a morphology, if I tell you this is from the anal canal or the rectum, is a large mass. Now there you definitely have a differential, not just lymphoma, not because this is a lymphomatic and it is lymphoma. As it comes on your table, you have to you definitely will have a differential that whether it is a carcinoma also, right? Or even if it is anal canal, whether it is a melanoma, something which is a melanotic melanoma. So you have to do markers. That means what? The large cell morphology can have a differential according to the clinical context also. So you have to remember. And when do you start to suspect it is a lymphoma? You start to suspect it is like if you have little discohesiveness of the cells, you have very apoptosis is there in the background. That way you start to suspect it could be hematolymphoid and not the epithelial malignancy or melanocytic malignancy. So in this it is difficult to say, And probably I must have done markers which were like a CK just to prove it is not epithelial, or a SENDAD to prove it is not melanocytic, and then lymphoma markers. But I will just dwell upon the lymphoma markers only. If you see on the high power what kind of morphological variant it looks like a immunoblastic. It is a large vesicular nucleus and prominent nucleoli. Some cells look like multinucleated also. You can see it better here. Multinucleated cells. So there is a immunoblastic morphology mostly, but there is some anaplastic cells. There are some anaplastic cells as well. Then you do the markers. CD20, CD3 both are negative. Now this kind of tumor is usually CD20 and CD3 negative. And CD3 is also negative. So if you have something, this is how I approach. If you have something which is like a large cell lymphoma, which is not like a typical, you will put them directly into some category of diffuse large B-cell lymphoma or diffuse large cell lymphoma, and your differentials of, let's say, your non-hematolymphoid malignancy. I start with CK, S100, and also do LCA along with CD23 and 30. Now this is LCA positive. That tells me it is a hematolymphoid. I wanted to know if it is B or T, both are negative. I wanted to know if it is like something which is CD30 positive lymphoma, which is also not there. But the good clue is that LCA positive. So I am dealing with hematolymphoid malignancy. Just remember, the exception to the rule is that some hematolymphoid tumors can also show you weak focal LCA positivity. In that case, you still will have to do other markers to prove it is some other type of tumor. So LCS positive proves that it's hematolymphoid. You do other B-cell markers like CD19 and CD17. Probably PAX5 was also done, which was negative. Yes, PAX5 was also negative. ALK1 was negative, because you are 20 negative, 3 negative, 30 negative. You can have something called as ALK positive large B-cell lymphoma, which has a plasma cell markers also, and then also shows ALK1 positivity, which it is not. So ALK is also negative. PAX is not there. There was no kappa lambda restriction in this. And it showed a plasmacytic marker, which is CD138, but EBER-ish was negative. And the other markers which was done to see if there was any aberrant expression, CD71 was negative and Ki67 was high. So this is actually a plasmablastic lymphoma. Patient was HIV positive, but this was not a EBER-ish positive plasmablastic lymphoma. So plasmablastic lymphoma resemble like a immunoblast, and they have immunophenotype of plasma cells. Usually occurs in HIV individuals, but can also seen in any immunodeficiency. Immunodeficiency in that even you can have because of the in old patients because of the senescence. They are anyways, because of old age they are immunodeficient. So that's why even in old patients you can get plasmablastic lymphoma even if they are not HIV positive. It usually occurs in extranodal sites like mucosal sites, sinonasal tract, GI tract, skin, orbit, bone, and soft tissues. And lymph node are usually involved in less than 10% of the cases. It has morphologic spectrum from immunoblastic to plasmacytic to plasmablastic, and usually very monomorphic looking plasmablastic lymphoma is seen in a HIV setting. And if it is in the oral cavity, then 100% of them will be EBER positive in HIV setting. But otherwise EBER comes positive only in 60 to 70% of the cases. They will show you variable plasmacytic marker positivity, and usually CD20 and PAX5 are negative. They can be LCA negative also. So if just because LCA is negative, in this case, if let's say for example this was LCA also negative, then you still cannot prove whether it is a lymphoma. You will have to do so many markers to prove it is lymphoma, and also to disprove that it is not like a carcinoma or melanoma. You can see sometimes light chain restriction, and also see some aberrant expression of markers like c-KIT and CD71. BIB1 is always very high. You can prove that it is EBER related by doing EBER-ish or LMP, and it should be HH8 LANA negative, because if it is HH8 LANA negative, it becomes a different type of lymphoma which has got a plasmablastic morphology. So if you have a CD20 negative high-grade B-cell lymphoma which has got plasmablastic, anaplastic, or immunoblastic morphology, you have to do variety of markers to rule out these 4 or 5 entities, like all positive large B-cell lymphoma, in which it will be CD20, CD3, and CD30 negative, because it is not ALCL of a T cell type. CD30 should be negative, then it gives positivity for ALK along with plasma cell markers. And very interestingly, it also gives expression for ALK2 and BOB1. Then plasmablastic lymphoma, I already mentioned. There is close differential is a plasmablastic myeloma. So in the absence of clinical history of multiple bony lesions or bone marrow involvement, to see if it is like a plasma cell myeloma, it will be very difficult to say differentiate between plasmablastic myeloma and plasmablastic lymphoma. Because in rare cases of plasmablastic myeloma, even EBER can be positive. So it's become very important. In these cases, you will have to go back to clinical history, talk to your clinical colleagues, and then only make that diagnosis. The other very rare variants you can make out can be plasmablastic morphology are extracavitary primary effusion lymphoma and HH8 positive DLBCL. These extracavitary primary effusion lymphomas are EBER and HH8 both positive. If it is EBER negative and only HH8 positive, then you make a diagnosis of HH8 DLBCL. As I already mentioned, that some plasmablastic lymphomas, almost 30 to 40% can be EBV negative. Rare myeloma cases can be EBV positive. High-grade B cell lymphomas can be negative for pan B cell markers, that you have to remember, and they will show you plasmacytic markers, and they can be EBV positive or negative, and BOB1 and OCT2 can be helpful in such situations. So for B cell lymphoma having diffuse morphology, we have already covered small cell. Now we have covered intermediate and large cell. So anything like that, you have to first see on morphology whether it fits into Burkitt-like lymphoma or blastoid lymphoma or large cell lymphoma, and then you do the appropriate immunomarkers to rule out all these entities. I have already discussed about it, so I will not go into details. So if there is a hematolymphoid malignancy which is CD20 and CD3 negative, you should suspect all these categories. One is ALK positive large B cell lymphomas, plasmablastic lymphoma which can be LC negative, as I have already mentioned. CD20 negative large B cell lymphomas can be there. Primary effusion lymphoma, HH8 large B cell lymphoma, plasmablastic myeloma, all these are also CD20 and 3 both negative. And ALCL which can be CD3 negative or even LCA negative. So it is can be there. And extramedullary myeloid tumor, always remember something looks intermediate, blastic, blastoid, then you might be dealing with myeloid sarcoma or EMMT. In such cases, as I mentioned, CD43 is a very good marker to prove that it could be this type of malignancy. So this is a 16-year-old male, right neck mass. You can make out that definitely it is very diffuse infiltrate. And something here, it looks like maybe there is something which is involvement of the sinuses, like a sinusoidal pattern, but mostly it is a diffuse. You see like a diffuse infiltrate of something, and very on high power you definitely see that these are like a large cells. You go on much high power P, you see these are quite large cells having this large irregular vesicular nuclei. Some nucleoli can be seen, and then you start to see these kind of cells like a kidney shape or horseshoe shape like nuclei. These are hallmark of one tumor which is a anaplastic large cell lymphoma. So if you see this kind of morphology, young patient, you should start to suspect it. And in such cases, doing CD23 and 30 is very important, because no diagnosis of ALCL can be made without strong diffuse positivity of CD30. CD3 can be positive or negative. So you did the marker, we did the markers, LC was positive. CD20, CD3, as I said, CD3 can be negative, 20 has to be negative. And then it was CD30 nicely, strongly positive. And ALK is also strong and diffusely positive. So and in ALK, you have to pay attention that it is not only there in nucleus, but also in the cytoplasm. So it is actually staining both nucleus as well as cytoplasm. And that gives you a very good clue that what kind of translocation could have happened in this ALK positive large cell lymphoma, and I will come to it. The other markers you may do like the other T cell markers like CD4, it usually CD4 positive ALCL, and CD8 is negative. You can have a epithelial membrane antigen expression, and also you will show you a granzyme B or TIA, like a cytotoxic molecule expression can be seen. It is this case was negative for CD2, CD5 and CD7 also. So you can also have all T cell negative, all T cell markers negative also, except maybe CD4 positivity along with CD30 positivity. Ki67 is very high. And as I said that if you see, this is the different type of translocation which can occur between in the ALCL. And if you see this case, our case had a cytoplasmic as well as nuclear staining. So I can predict by saying that this probably is a translocation between NPM and ALK. That when you have this translocation, the protein expression is seen in nucleus as well as cytoplasm. Otherwise, for these rare variants, you see cytoplasmic expression and not the nuclear expression. and one of the variants, this MSN-ALK, shows only membranous type of expression. Now, ALK positive large B-cell lymphoma has very characteristically this kind of CLCTL and ALK translocation. So you just have to remember some things. ALCL has got 5 variants, like a common variant which I just showed you. It can be giant cell rich variant, lymphohistiocytic, small cells type, or Hodgkin's-like. Now Hodgkin's-like you have to remember because then it becomes a differential for Hodgkin's. So you should know that that can also happen. Usually common pattern is seen in almost 75% of the cases, and I already mentioned what kind of this hallmark cells can be seen in these cases. So if you see those cases, you should start to suspect highly that it is ALCL. Small cell and lymphohistiocytic variants, which are very rare, less than 10%, are usually have less favorable outcome, and very rare forms like signet ring, like sarcomatoid, or eosinophils, or epithelioid cell rich variants have also been described. You just need to know that sometimes you might get this very rare variants. They by definition has to be CD30 strongly positive, and ALK positive ALCL has to be ALK positive. They can show EMA positivity in 60 to 70% of the cases. CD30 can be seen in half of the cases. All T-cell antigens are actually, means you need to do it. If you don't do it, if that is also okay, but if you do it, you might say that some of them can be negative for CD2, 5 or 7 also, or some of them can be preserved also. Expression of CD4 usually seen, less CD8. You show the positivity for cytotoxic markers, as I already mentioned, and they can be 20% of them can be LCA negative as well, and can express CD50. So this is one of the very rare variant we had seen long back, which was like a very spindly looking tumor, and it was CD30 positive, and there were other T cell markers. So it was actually sarcomatoid variant of the ALCL. So ALK positive and ALK negative are the two main categories for ALCLs. We already saw what is ALK positive is. They usually occur in young children, and they are usually have these very hallmark cells. Lymph node and extranodal sites can be involved. But in ALK negative category, you have 3 types: systemic, cutaneous, and breast implant associated. Cutaneous and breast implant are a quite different category. I will not discuss. But in systemic types, these usually occurs in older patients, and lymph node and extranodal sites are also involved. There are actually 3 types which have been described, which is first is the DUS22 rearranged type of ALCL. It is almost like 20 to 30% of the ALK negative ALCLs, and they actually have a better prognosis. And the surrogate markers, some people have done the studies. If you are suspecting something is like, if you see something is ALK negative LCL, and you see something, the large cells which are donut-like large cells, this could be DUS22 rearranged, and you do a LEF1 marker, which also can be done for CLL, SLL. These markers, if you do and these cells are positive, then you can predict that this is a DUS22 rearranged ALCL. Another is TP63 arranged, which are around 10% of the cases of ALK negative LCL, and they do very poorly. And then if you don't have ALK, if you don't have DUS22 rearrangement, it is not TP53 mutated, then those IL cells are called triple negative L cells. So what is how systemic ALCL is different from the ALK negative LCL is different from the all positive LCL. Small cell variant is not described in ALK negative L cells. The cells in ALK negative L cells tend to be more pleomorphic, and they have more high NC ratios. So you know, when you have a ALK negative L cell, you can confuse it for something like how do you separate it from PTCL NOS, because there is nothing you can say. It can be PTCL NOS cases can also give a CD30 positivity, so that can be a challenge. The clue is that you might want to check out if there are hallmark cells and CD30 which is strong and very diffuse. These are some clues that you can favor ALCL ALK negative over the PTCL NOS which is expressing CD30. As a rule, you must rule out that this nodal involvement is not secondary to cutaneous ALCL, because those are relatively better tumors. So I have already covered single cell type, intermediate cells as well as large cells. Now if you have mixed cell type, in which you have B cell tumor, which is like a T cell rich B cell lymphoma, which is a mimic of a Hodgkin's lymphoma, which will be covered in the lecture. And then you have classical Hodgkin's lymphoma, because it is a can be diffuse morphology, which will again be covered. So we are left with T cell tumors which have mixed population, which is AITL and PTCL NOS. So the main question when you start seeing something comes when should I say something is T cell, and how T cell is different from a B cell on morphological grounds. So there are some clues to it. Like if you see in any nodal or extranodal sites, the primary reaction which happens even in reactive conditions is actually more CD3 cells. So just because there are so many CD3 cells doesn't mean that it is CD3 positive non-Hodgkin's lymphoma. That is not sufficient to make the diagnosis of non-Hodgkin's lymphoma. But in contrast to that, if it is a B cell lymphoma, you see that the majority of cells are actually CD20 positive, and then without doing even clonality studies, you can say for sure this is going to be a B cell lymphoma. And in B cell lymphoma, if there is a doubt, you can still do clonality studies by immunohistochemistry to show if there is kappa or lambda restricted. If you have in situ hybridization, you can still do kappa or lambda restriction and check if there is this kind of restriction there, and you prove that this is a clonal population. Vis-a-vis for a T cell non-Hodgkin's lymphoma, there is no, I mean, you can't prove it that it is clonal, although you can do markers for gamma delta or alpha beta chains. But again, you have to remember some reactive conditions can also show you this kind of expression of gamma delta or alpha beta. So it's kind of difficult in T cell lymphoma to prove clonality by immunohistochemistry. I mean, you can do the molecular studies for T cell regenerament, but on just morphology, it is difficult. So there has to be some clues on histology, which will tell you that you are actually dealing with something which is neoplastic and not reactive. So one clue is like in T cell lymphoma, if you do immunohistochemistry markers, you do the T cell antigen markers. If you show that there are some abnormal T cell expression, or if there is some loss of T cell antigen, that itself shows that this is not a reactive T cell population, but it could be a neoplastic population. And what are the morphological clue to say something is T or NK cell? That you see a paracortical lymphoid infiltrate, and sometimes it spares the reactive lymphoid follicles. You see prominent high endothelial venules. Then you start to see striking irregularities in the nuclei of the cells of interest or the cells population, and some cells will give you some clear cytoplasm. So if there are clear cells also in between that population, that is also one clue. Other thing is you cannot tell whether it is actually small cell lymphoma or large cell lymphoma or intermediate, because by and large the T cell lymphomas usually will have a population of small, intermediate and also large cells in it. So that is also clue that you are probably dealing with something which is a T cell. Although monomorphic form of T cell lymphoma is already seen, like ALCL is a completely different thing. Very rarely PTCL NOS can show you monomorphic morphology, but by and large the majority of tumors which are T cell non-Hodgkin's lymphoma of AITL and PTSL NOS type will show you different cell sizes, small, medium and large cells. And they will have a prominent inflammatory background, which also can include plasma, eosinophils and plasma cells. So I have seen T cell lymphomas, you need to do not only CD3 but do other T cell markers like 2, 5, 7, 4 and 8 to see if there is any abnormal expression or if there is some loss of T cell antigen, and also if morphologically if suspect ALCL, obviously you need to do CD30 and ALK1 to show that something is like a T follicular helper cell phenotype. You can do these markers CD10, PD1, ICOS, BCL6 or CXCL13. Now in order to say something is of T follicular helper cell phenotype, you at least have to show 2 markers positivity, at least 2, anything, CD10 or PD1 or CD10 or BCL6 or ICOS, anything, any 2 markers are positive, that means it is T follicular helper cell. And there you can also do cytotoxic molecules like enzyme ATI, A1 and perforin, and in some cases you might have to resort to EBER-ish or CD56 if you are suspecting NK T cell lymphoma. Now this is a one case where this is a 64-year-old female having B symptoms, and then she presented with generalized lymphadenopathy and right cervical lymph node. Now so if you see, this is kind of a fragmented biopsy, but even on this very scanner image, you don't see like usual follicles or interfollicular areas, and it looks like this is a diffuse infiltration. And you see on one power ahead, you see that it is definitely a diffuse infiltrate, but it's not that blue. If you remember, I was always talking about monomorphic, very blue looking in B cell lymphomas of low grade type, but here it doesn't look that blue. It looks like blue and pink and everything, so probably it is very polymorphous population is there. That much you have to think that I am probably dealing with something which is going to be polymorphous. And you move on to high power and you start to see that there are these vessels are there, and then there are different cell population is there. Some cells probably have some clearing of the cytoplasm, and you go on more high power, you start to see this high endothelial venules with plump endothelial cells. Now they are called high endothelial venules because of the thickness of these cells, because if you compare it with the normal capillary size vessel, you have a nucleus which is quite compact and very compressed one, but here it looks quite if I am showing you correctly, they look quite plump. Vesicular nucleoli are there, their size is more, that's why they are called high endothelial venules. So you start to see high endothelial venules, you start to see different size of cells, small, intermediate and large cells. Then now you think that this could be a lymphoma, and most likely it probably will be a T cell lymphoma. So you again on high power you tend to see small, intermediate and large cells, and then a high endothelial cell venules. You do markers, CD20 against CD3, even on a scanner you can make out CD20 is only restricted to few residual follicles or nodules of the B cells, and then it is the entire population is CD3. You do CD5, CD2 and CD5 other T cell markers to show if there is any loss of antigen. So CD2 and CD5 both are retained and expressed. CD4 is there and CD8 is negative actually, so it is showing only CD4 positivity. And if you compare CD7, if you are compared with CD2 or 5 or 3, you can make out that CD7 is definitely down regulated. So that is a clue that you are dealing with something. It could be a clonal, or it is a clonal population. And Ki67 is very high. And you do other markers, like you wanted to prove if this T cell population is actually of a follicular helper T cell type, then two markers were done, PD1 and CD10, both look positive, so it is of T follicular helper cell type. CD23 is very important to see in these cases, because if you see that the CD23 has not only just expanded, but it has gone beyond what is the nodules of the CD20. So it's like a extra follicular extension, or the growth of the FDC measures are there, and you can make out very nicely in this picture. And these FDCs start to go around these high endothelial venules also. So that's a clue that you are dealing with a tumor which is a angioimmunoblastic tumor. And sometimes in that you can see a bystander large cells, which are usually B cells, 20 positive, are also EBV positive, which was there in this case. And so this is the diagnosis. It is a nodal T follicular helper cell type, NHL of angioimmunoblastic type. So angioimmunoblastic type is a prototype neoplasm of a TFH category, which we have seen in the morning that there are 3 categories, and it is one of the 2 common PT cells worldwide. It affects mostly elderly patient, usually manifests with generalized peripheral lymphadenopathy, systemic symptoms, and also rash and autoimmune phenomena. So for this kind of diagnosis for AITL as well as PTCL annuals, don't make diagnosis of these tumors if there is no generalized lymphadenopathy. If patient doesn't have B symptoms, you have to have these clinical symptoms when you make the diagnosis of T cell lymphoma. This AITL can have polyclonal hypergammaglobulinemia and other hematological abnormalities like Coombs positive hemolytic anemia, and median survival is just 3 years. So there are 3 patterns of AITL. Those who are interested in lymphoma, they should know it. The pattern 1 is actually the architecture or the contents is quite preserved. You see these follicles, and it has got the mantle which is almost gone, or very atretic mantle. And what you start to see around these follicles, you start to see that the TFS cells or PD1 positive cells or whatever, CD10 positive cells starts to aggregate. And FDC measures are relatively preserved, but they can be some little expansion. Now this pattern is very difficult to diagnose. I mean, you just have to probably suspect it if they tell you that it is what you are clinically dealing, or it looks like a lymphoma, and they have very high suspicion of lymphoma. There will be symptoms, generalized nodes, and then you have lymph node like that, and you should also have high degree of suspicion on histology, and then use appropriate markers, and probably even suggest to do TCR clonality by molecular studies. You never know, but this pattern is very difficult to diagnose. Pattern 2, wherein you start to have some effacement of the contents, the follicles are now becoming little irregular, and then there are aggregates of the TFS cells, which are PD-1 positive cells, around the follicle, as well as they are trying to going into the interfollicular areas as well. And then FDC mesh curves can be retained, but they are starting to become expanded, irregular, and going into the interfollicular areas. And pattern 3 is relatively more common and easy to diagnose, wherein there is complete effacement of the architecture. There are no proper follicles which are retained. You have so many TFS cells which are there diffusely in the lymph node, and FDCs are haywire. They are completely gone outside the follicles, and this is relatively easy to make the diagnosis. So nodal TFS lymphomas, as I already mentioned, of 3 types: angioimmunoblastic and follicular type. I have already taken it in a low grade lymphomas. And when you cannot put them into angioimmunoblastic type, but still there is a TFH phenotype, then you can call it nodal TFH type lymphoma, NOS. This is left axillary lymph node. We are moving to some other category of the tumor. Axillary lymph node in a 75-year-old, again having generalized lymphadenopathy. It's very important when you make the diagnosis of AITL or PTCL, generalized lymphadenopathy. Again, on a low power, what you see is a diffuse architecture, and what is seen here that is this sinus is preserved, but there is a diffuse infiltrate, and this infiltrate is going beyond the capsule of the lymph node. That is a very good clue that you are dealing with neoplastic population. Again, you see the diffuse proliferation. You don't see any follicles, so it is diffuse proliferation, and then extension into the extra nodal adipose tissue. And then on high power, you start to again see that cell size is not just large, but it is small, intermediate, and large. Some high endothelial venules can be seen, but what is lacking here is you usually seeing a clear cell morphology. There is no clearing in some of the cells, but the differential here remains whether it is angioimmunoblastic or PTCL NOS. So I am talking about T-cell lymphoma, that's why I am saying this is the differential. And if you see on high power, again same thing, mixture of the cell size and some high endothelial venules. There are probably some eosinophils also in the background, so there is an inflammatory component to it other than lymphocytes. So you know that you are dealing with lymphoma. You do markers, 20 is negative, CD3 is strong and diffusely positive. CD2 and 5 are retained there, same as what CD3. CD4 is more than CD8. And CD7 again is very less or down regulated. And now you note the CD23. CD23, even though there is a kind of diffuse architecture to it, whatever the residual follicles are there, they are quite compact, and the FDCs are quite compact there. They are not like expanded, disrupted, like what you have seen in angioimmunoblastic lymphoma. So this is, then you do, again, you have to do TFH markers. TFH markers, CD10, if you see, is only residual, some follicle cells are positive, not in the interfollicular areas, where actually cells of interest are also there. So it's not there. And PD1 is positive, but PD1 is a less specific marker than CD10. CD10 is more specific marker, but less sensitive. So if you have done 2 markers, only 1 marker is positive, which is TFH marker, you cannot call it AITL. So Ibarish was also negative in this case, and Ki67 was high. So this is a PTCL NOS case. So if you can't categorize them into any specific category like AITL or ALCL, then you put them into a wastebasket category, which is a PTCL NOS, which is the most common type of the T-cell lymphomas. And it usually present with nodal sites, but extranodal sites can also be affected. More common elderly patient after 7 decades of age, and 65% of them present with stage 4 disease. That is very important. That's a clinical clue. And it also has very poor outcome. 20 to 35% of 5-year survival is there. So morphology can be highly variable. There can be mixture of cells. There will be loss of T-cell antigen, I have already mentioned it. Just have to remember that sometimes PT cell can also show you EBV positivity, but then to call it AITL, you have to have other morphological clues, then only, and TFH phenotype, then only you will call it AITL and not PT cell, which is EBV positive. And there is a rare variant which is Lennart or lymphoepithelioid variant can also be there. You just have to remember, because there are too many histiocytes, but in the background cells are actually atypical, and you have to suspect highly to make that diagnosis. And it is usually CD8 positive cytotoxic type T cell. So as in TLB cell NOS, they tried to see by gene expression profile if they can categorize into something which makes sense clinically as well as if for a treatment point of view. Similarly, even in PT cell, they have tried to do it. So they use these 4 markers. If the TBX21, first you do TBX21 and CXCR3, if the tumor cells 20% of them are or more are positive for this, then you don't need to do other markers, you just put them into category of PT cell TBX21 subtype. If the TBX21 and CXCR3 is negative, then you do the other marker GATA3 and CCR4. If the more than 40% or 50% of cells are positive for this, you put them in category of PT cell GATA3 subtype. And if none of them is positive, or they do not satisfy the criteria of like more than 20 or more than 50, then you put them into PT cell unclassified. And they have found that they make prognostically sense, because the GATA3 subtype does poorly. It has got more monomorphic morphology and less inflammatory cells. So even it matches with your morphology also, and prognostically they have very poor survival. Whereas TBX21 subtype, which is almost 58% of the PT cell NOS, they have polymorphous morphology and they have relatively better survival rate if you compare with the GATA3 positive subtype. As of now, in our lab, we are not doing it. It is not recommended also, but just one should know maybe in the future we might have to do it. So with that, I will end my talk. Thank you. Are there any questions for me? Yes. Yes. So double expressor is talking about the protein expression, and double hit is actually you are saying the translocation. So protein expression can be there without even translocation. It can be because of amplification, it can be because of mutation, other this thing, or it can even without anything happening at the molecular level also. So that's why that discrepancy is there. Sorry? Yeah.
So why is it so all double hit are not double expressors?
No, double hit can be double expressors also. But most of the double expressors are actually ABC type. And most of the double hit are actually GCB type. But double hit lymphomas can be double expressor. There is no doubt about it. Yeah.
All double hit are not double expressors.
So that discrepancy is always there. It's not. I'm not sure why it has happens, but it can happen. You see, translocation has happened, but then there is something which happens at a protein level which doesn't get transformed into protein. So protein level expression doesn't happen. So it can happen.
Thank you.
Like a BCL2 negative lymphomas. I mean, there is a translocation. If you do the fish, BCL2 will be positive by fish. But if you do our usual clone, it may not be positive. Why it has happened? Because there is some mutation for that particular clone where the actually antigen and antibody is binding. That epitome is actually mutated and is not able to bind to that BCL2. So that's why you have to use another clone which has got a different binding site to prove that it is BCL2 positive, which is like E17 or E36.
Thank you, sir.
Thank you. I think, okay, thank you.
Thank you, sir. That was such an informative lecture. And now I would like to welcome Dr. Jai Mehta, sir. Sir was not there with us in the morning session, so I would request Dr. Maulik Vora, who is the Associate Professor, to present Jai, sir, with a bouquet.
out where my thing is. Is there a pointer which goes there?
Doesn't work on the
Oh, it's on
screen.
screen? Okay, I'll do
We
that.
can
Oh,
do
okay,
it.
I'll do that. They need to. I don't know, it's not going well.
इकत second.
I have to go here and then full screen mode.
Can I please request everyone to maintain silence? The people at the back, please, you're expected to maintain silence. Thank you.
Okay, if everybody is settled down, so I'm going to talk on how do you diagnose or tackle lymphoid infiltration in the trifine biopsy. So as like the Americans like to say, in real estate, everything is about location. Just like real estate for marrow interpretation, it's all about location, where the cells are, where they are actually located in the trifine. So topography in marrow is very important. The cell lineages are distributed in a non-random fashion. Most of them reside in a designated place. Well, most of the times they are in a designated place. The marrow is a very highly dynamic environment. There's a lot of response to stimuli, for infections or neoplasm, and therefore there may be some deviation from normal which helps you in interpretation of the disease state. Immunohistochemistry is invaluable in judging marrow topography because it tells you where all these cells are located. So here's the kind of a cartoon for a marrow topography. The first thing that I do when I look at the trifine is to look at the bony trabeculae. It's kind of a landmark where you start looking at. There's a lot of information you can even derive from how the trabeculae are showing changes associated with metabolic bone disorders, with primary myelofibrosis, and so on and so forth. But that's the first thing that I start looking at, because the area around this paratrabecular zone, that's the area where you get myeloid cells. You get the myeloblasts, the promyelocytes, the myelocytes, and as they mature, they go towards the center of the marrow spaces. The erythroid islands are located kind of near the center of the marrow space. The megakaryocyte, the most easily recognizable cell in the marrow, is more towards the sinusoids in the marrow interstitium. The plasma cells are located more towards the capillary. So you get perivascular or pericapillary cuffs of plasma cells, and that's the normal pattern. Eosinophils, you can see sometimes, normally that's also towards the center of the marrow spaces. The osteoblast that you tend to see towards the inside of the trabeculum has a lot of resemblance to plasma cell, but the nuclear morphology is different. Having said that, IHC is invaluable for interpreting marrow topography. One has to understand that we decalcify the tissue. There's an acid decalcification which has been done on the tissue. So your immunoreactivities, the background staining, the intensity that one would see in a lymph node is not the same that you would see in a trifine biopsy. So you need to carefully select the antibodies, validate them accordingly, and make it work the way it should normally work for a trifine biopsy. So how do you tackle lymphoid aggregates? Now, benign lymphoid aggregates usually are a mixture of B and T cells. More likely that T cells predominate here. If they are composed primarily of B cells, and if they are multiple, then start suspecting a lymphoma. A wide variety of reaction patterns can occur with both benign and neoplastic morphologies. A follicular lymphoma, for example, will have a lot of T cell kind of reaction along with that. So that's something that you expect, and that will not make it a benign pathology. Vice versa, if a patient has taken rituximab, for example, post-lymphoma treatment, they tend to have a lot of reactive aggregates in their marrow, and you see them when the marrow has been done for response assessment. Lymphoid cells in the bone marrow, when you do lots of marrows, you'll see that about 5 to 10% of refined biopsies tend to show you a lot of lymphoid aggregates. T cells outnumber B cells normally, and it's mainly CD8 subset over CD4. As the age increases, you will start seeing more of lymphoid aggregates. So a third of marrows in the elderly population, you will start seeing marrow aggregates. They are usually non-paratrabecular. By and large, they are non-trabecular, unless there is some kind of a morphology, something like a chronic myeloproliferation, which is pushing the lymphoid cells towards the bony trabeculum. Then that's a possibility. It could still be reactive. So benign aggregates are usually single or few in number. Now, nobody has actually done this math and said, what's few and what is more. But that's like rule of the thumb. If you see 2, 2, 3, then that's kind of supposedly a few in number. But they are distributed randomly away from the bony trabeculae, typically round, well-circumscribed lymphoid aggregates. They don't spill out of that circumscription and out into the interstitium. Usually the components of these aggregates are mature lymphoid cells with mature chromatin in them. And they don't have a very conspicuous nucleoli. They are associated with histiocytes, plasma cells. Sometimes you even see germinal center formation. That's kind of reassuring that that's a benign lymphoid aggregate. Having said it, if you get splenic marginal zone lymphomas, they could show you germinal center. So there's a caveat for most things in medicine. Neoplastic lymphoid aggregates versus a benign thing, they will be multiple, they'll be irregular shaped. You will see them infiltrating out into the marrow interstitial spaces. Sometimes they'll entrap the marrow adipose tissue as well. Paratrabecular infiltrates touch and grow along the surface of the bone and conform to the bony contour of the bony trabeculum. If you get an intrasinusoidal infiltrate, it's almost always neoplastic. Again, the caveat that sometimes you get B monoclonal lymphocytosis, and they may be in the sinuses, but that's a very rare event. So here's the paratrabecular aggregate that I'm talking of, and that's the CD20 immunostain. You can see that not only is this aggregate kind of paratrabecular, it's hugging the trabeculum and it's conforming to the size, conforming to the contour of the trabeculum. That's how it should do. It should actually really stick to the contour and go along. That's what a paratrabecular aggregate should be. And on the right side is a CD34 immunostain highlighting the sinusoids inside the marrow interstitium, and that's the intrasinusoidal location of these large lymphoid cells. In this case, this was a intravascular large B-cell lymphoma. So there are patterns of infiltration of lymphoid infiltrates in the marrow. And how do you recognize individual diseases is by actually finding out. So location is everything. You can get nodular infiltrates, you can get paratrabecular infiltrates, interstitial, diffuse, and intrasinusoidal. So that's how a normal marrow would look like, versus this blue dots here that you're seeing are nodular lymphoid aggregates. When it's interstitial, they tend to merge along with the hematopoietic elements. Paratrabecular, I just showed you. Diffuse is just effacing the entire marrow interstitium, removing all the hematopoietic elements and replacing the entire marrow is diffuse. And intrasinusoidal is difficult to appreciate straight away on morphology unless your eyes have been trained to see that over a period of time. So unless you do an endothelial marker, it's slightly difficult, and it's a subtle way of finding that out. These are the histology images of reciprocal, what I showed you. These are nodular infiltrates. That's a paratrabecular infiltrate here. This is interstitial. Interstitial is difficult to pick up because it's going to be mixed with the normal hematopoietic elements. This is a diffuse replacement, and here's the intrasinusoidal one. You can see this large cells, like, almost like an inverted Y kind of opened up channel that is seen here. They are occupied by these large lymphoid cells. So focal infiltrates are more common and characterized by discrete collections of lymphoid cells. So they may be nodular, or they may kind of assimilate with the hematopoietic elements. The paratrabecular, I already told you. In interstitial infiltrates, the lesional cells infiltrate between the hematopoietic cells without really disrupting the marrow topography, versus a diffuse infiltrate which actually disrupts the entire topography. Intrasinusoidal, I already told you that these are typically subtle, difficult to appreciate easily on a routinely stained H&E section. So how do T and B cell lymphomas involve the marrow? typically, as a rule of thumb, low-grade B-cell lymphomas commonly infiltrate as in a nodular pattern. It's unusual for a very high-grade lymphoma to do so. There are some exceptions to the rule. Everything has an exception in medicine. There are 3 lymphomas which actually belie this kind of rule, and those are lymphoplasmacytic lymphoma, that's Waldenstrom's macroglobulinemia, marginal zone lymphoma, and hairy cell leukemia. They tend to involve the marrow in a diffuse pattern despite being low grade. Presence of a mixture of atypical lymphoid cells with histiocytes, plasma cells, eosinophils, a polymorphous background that you would see in a T-cell lymphoma, which Dr. Pravin just showed us. If you get that kind of a morphology, that's a clue to involvement, marrow involvement by a T-cell lymphoma. So coming to, I'll take you through individual lymphoma cases. How do they involve the marrow? CLL, SLL, we already learned, I think Dr. Pravin's already covered, but I'm just going to 2-3 things here. That CD20 is kind of a dim expression you get with CLL, and likewise CD5 is also dim as compared to the bystander T cells. CLL infiltrate is usually diffuse or multifocal nodular or rarely interstitial, but seldom paratrabecular. In fact, if you get a paratrabecular infiltrate, that almost always rules out the possibility of a CLL, SLL. And here you can see this multifocal nodular aggregates in the interstitium, CD20 and a corresponding left one showing you this nodular aggregates. Here's a diffuse infiltrate where the entire marrow has been replaced by this CLL, SLL cells. And you can see this very typical dim CD5 expression. CD20, it's one of those low-grade B-cell lymphomas where CD20 is dimmer in expression than the other low-grade lymphomas, 23 positive, and so is left one. For lymphoplasmacytic lymphoma, as I said, it's one of those one which beats the rule. It's usually diffuse. You can get patchy nodular or interstitial involvement as well. The morphologic and immunophenotypic distinction of LPL from a nodal marginal zone lymphoma is kind of difficult. It's not very easy to do that on a marrow, but if you do get an IgM subtype, then that pushes the diagnosis towards a Waldenstrom's macroglobulinemia. And here's the marrow which is diffusely involved. You can see this marrow interstitial space. At this power, can't identify the morphology, but what you can see here is there's a subset. So you can see there's very normal lymphoid cells here, but not normal, but the lesional lymphoid cells. On the left is something very lymphoplasmacytic looking, and on the right is an extreme degree of plasma cell differentiations. You can get a mixture of all these 3 components of the lymphoid cells. Here's the high power. On the left is the lymphoplasmacytic appearance. On the right, you can see that it's more pink. There's more cytoplasm in it. It's going towards a more mature plasma cell phenotype. And here's the immunoprofile. This is CD20 positive. And the holes that you can see, what is not marked in CD20 are the cells which are plasmacytoid or plasma cells. They are CD38 expressing. And on light chain immunohistochemistry, they are kappa restricted and lambda is negative. These same cells which are CD38 positive are IgM positive as well. This was a lymphoplasmacytic lymphoma of Waldenstrom's macroglobulinemia type. Coming to mantle cell lymphoma, so this can have multiple patterns again, or a combination of patterns, nodular, interstitial, paratrabecular. By and large, from what I have seen, is it tends to be more paratrabecular than the nodular one, but you can get a mixture of all of them. Typically co-express CD20, 5, and cyclin D1. Sometimes you can get CD23 positivity in mantle cell lymphoma, doesn't make it CLL, SLL, but 23 as a marker can come in most low-grade B-cell lymphomas. So that shouldn't deter you from calling something as mantle cell lymphoma, but what you need to kind of look at the morphology is that it's a cleaved lymphoid cell with inconspicuous nucleolus. So that is something that should take you towards a diagnosis of mantle cell lymphoma. Sometimes you get the blastoid variant of mantle cell lymphoma. Sometimes that's difficult to distinguish from lymphoblastic leukemias, but this is the blastoid variant and not the blastic. So it's TDT negative. Sometimes, or actually often it will lose CD5, start expressing CD10, but then you need to do either cyclin D1 or SOX11 to arrive at the correct diagnosis. So here's a very typical paratrabecular infiltrate with a mantle cell lymphoma. On the right side, you can see this CD20 highlighting that paratrabecular localization. You can see this, the morphology here. Not sure if you can appreciate, but this is the one that you should be looking at. Look at this, there's no conspicuous nucleolus at all in these cells, and that's the real morphologic pointer towards a diagnosis of a mantle cell lymphoma. CD20, CD5, cyclin D1, and CD3, and they're all showing you that paratrabecular accentuation. The difference between follicular lymphoma, paratrabecular infiltrate, and a mantle cell one is that you tend not to see lots of T cells with mantle cell lymphoma, but the follicular lymphoma cells will, lymphoma will show you lots of T cells along with them. Coming to splenic marginal zone lymphoma, how do you diagnose it? Yes, there will be nodular aggregates, but there's almost always a very subtle intrasinusoidal localization of the lesional lymphoid cells. Along with that, there should, you should have the history of enlarged spleen, and typically lymph nodes may or may not be there along with SMZL. Now, the intertrabecular nodules mimic the architecture and cell composition of the tumor nodules that you would see that in spleen, where you have a reactive germinal center, a mantle, and then a marginal zone around it, and that can be recapitulated in the bone marrow as well. Now, all these findings by itself are not really supportive of an individual diagnosis, but you need to see everything in kind of a comparison with the clinical findings. So here's the bone marrow. You can see this very typical intrasinusoidal infiltrate. You can see the CD20 highlighting that, and IgD. That's another marker which is very useful in trifine biopsies. It marks the SMZL cell. So you can see this intrasinusoidal localization with IgD. And these are the nodular aggregates that you see, and CD20 is highlighting that. Along with the nodular aggregates, you can again see this very subtle intrasinusoidal localization in the marrow interstitium. These are features which are very typical for us SMZL. Talking of hairy cell leukemia, the name derives from the cytoplasmic hair-like projections. You typically see them on bone marrow aspirate, not on the trifine biopsy. This is again one of those lymphomas which diffusely involves the marrow. It doesn't kind of come in a nodular fashion. Very rarely it can be intrasinusoidal, but that's exceedingly uncommon. So these hairy cells are round, they're monotonous. They have a nucleus which is ovoid. Sometimes they are indented. And they have an abundant clear cytoplasm which gives rise to that very classically described fried egg appearance. You virtually never see large cells with hairy cell leukemia cases. Unusual thing is that when you have hairy cell leukemia, there's almost always increase in reticulin fibrosis, but there is no collagen deposition in this. So once it's treated, the reticulin fibrosis actually reverts back, so the marrow reverts back to normal. The primary diagnostic antibodies here are DBA44 and TRAP. Cyclin D1, I find it very, very useful. I mean, unless I do see a dim cyclin D1 expression, I'm very hesitant to call something as hairy cell leukemia. The hairy cells carry the very characteristic point mutation in BRAF, the V600E. If you have the antibody towards it, you can use it to actually diagnose it. Helps you in distinguishing between the variant hairy cell leukemia, which is now not called the variant anymore in the new classification, but it's called the splenic red cell lymphoma with prominent nucleoli. Annexin A1, a lot of people prefer it. I don't particularly have a liking for it, and I'll show you why, because it marks a lot of myeloid cells. So if you have any amount of remnant tissue, or if you're going to check for residual disease or something, it marks a lot of things which you're not able to make out if these are hairy cells or not. So you need to compare that with MPO and CD20, and that becomes difficult. CD25 and T-beta are other good markers on trifine biopsy to actually diagnose hairy cell leukemia. This is a normal marrow where I've done the annexin A1. You can see, and it's kind of correlating with the MPO. So unless it's a chock-a-block diffuse replacement of the marrow by the hairy cells, I find it very difficult to interpret annexin A1, and I tend to ignore it. I have more faith in cyclin D1 in those instances. So here's the high power view. You can see this very fried egg appearance. Some of these nuclei are round to ovoid. Some of them are very indented, but that depends on how the fixation and the processing has taken place. Here's a diffuse replacement. You can see CD20 in the middle bar, just completely replacing the entire marrow. That's DBA44, and this is BRAF V600E mutation-specific antibody that is now available. So you can use that to actually confirm the diagnosis. So coming to follicular lymphoma, that's the prototype of what we have always been taught, paratrabecular lymphoid aggregates. You can get that, but you can also get nodular lymphoid aggregates. The infiltrate tends to hug or wrap around the bony trabeculae and conforms to the bony contour, as I emphasize. Usually, it's composed of centrocytic lymphoid cells, but Dr. Pravin also brought this up. When you have a lymph node biopsy, you can, it's what is called the discordant kind of marrow histology. You can get low-grade cells in the marrow we can get centroblast or even a DLBL in the lymph node. So that's the discordance, which is always something that one needs to keep in mind. And therefore, actually, diagnosing or subclassifying lymphomas on bone marrow is fraught with certain biological, difficulties. You can't make a confirmed diagnosis on a trifine biopsy, but that's the very typical paratrabecular infiltrate. You can see this very pale areas, and this is the lymphoid infiltrate here. You can see this paratrabecular infiltrate at low power, and likewise it's corresponding to the CD20 and the CD10 on immunohistochemistry. If you do a CD3, they will always have a large amount of CD3 population here. Coming to Hodgkin lymphoma, it's characterized by randomly distributed aggregates in the marrow interstitium. They have lots of histiocytes in it, though they stand out. You might even get a epithelioid granuloma kind of response to these infiltrates, so it's easy to pick it up on low power. And the morphology wise, you'll see, you tend to see more of mononuclear Hodgkin cells and binucleate Reed-Sternberg cells. For some reason, I don't know, that's what been my experience. Profile remains the same. A very large number of Hodgkin lymphomas in the marrow tend to show you EBV association, either with LMP1 or Ebers by ISH. So here's a marrow in this case. You can see this on the low power. You can see it's very cellular marrow. It's a reactive marrow, but these are the areas, those kind of areas which are standing out here, nodule, and you can see on high power, lots of histiocytes, and you can see that they're all spaced apart with a lot of polymorphous population here. And you can see on this as an arrow pointing towards that mononuclear Hodgkin cells expressed is 30. CD15 is slightly difficult. You need to be very careful when you look at it. You can see this here. There's one which is marked with the arrow which is pointing towards that RS cell, but lots of granulocytes naturally will pick up CD15. So you need to be very careful while interpreting 15. 20 is negative. PAX5 has that very dim characteristic expression in the Hodgkin cells. Now, bone marrow involvement by T-cell lymphomas is a difficult job. Just as it's difficult to diagnose a T-cell lymphoma in the lymph node, it's equally difficult to do that on the marrow, because it's very subtle and it's usually a polymorphic infiltrate. There's so many other cells which are also accompanying it. So it has to be done in a context. You should at least know if the lymph node is involved or not. The infiltrate may be interstitial or paratrabecular. And the reason it's important to know that is about 40% of nodal TFH lymphomas tend to involve the marrow, so you should carefully look for that. Having said it, sometimes despite large numbers of immunostains, despite doing flow cytometry, clonality analysis, sometimes it's difficult to make that diagnosis. Not to say that it can never be made, but it sometimes is difficult. So here's a very clear kind of a thing. This was a known diagnosed case of peripheral T-cell lymphoma. The marrow looks okay for most parts except just these two areas. You can see this one area here and this one area here, and both of these have been highlighted in the higher power views here. So this was obvious because there was a subtle involvement, but it was a known and diagnosed case of a peripheral T-cell lymphoma. It expressed CD3, CD2, CD4, and CD7. CD8 was negative in this case, and therefore it was easy to diagnose it. AITL becomes even more difficult because, again, it's just polymorphous. There tend to be so many eosinophils accompanying it. But a subtle clue is that you will get these cells which have clear cytoplasm, so they should probably stand out at low power for you to actually go and work it up. PD1 and ICOS are very important stains to do this diagnosis on a trifine biopsy, because PD1 and ICOS don't mark a lot of cells normally in the bone marrow trifine biopsy. Coming to another kind of a T-cell lymphoma which is important for you to pick up is a hepatosplenic T-cell lymphoma. Why is it important? Because it tends to have a very poor kind of outcome for the patient, so you should be able to pick it up. Has an interstitial infiltrate and an intrasinusoidal localization. These are lymphomas which arise from immature or resting gamma delta T cells. On immunoprofile, they express CD3, they're negative for 4 and 8, but the clue is the negativity for CD5. When you see in T cells, if you have a CD3 positivity and a negativity for CD5, it usually means it's an NK cell or a T cell, NK cell or a gamma delta T cell proliferation. So that's a subtle clue. If you get 5 positivity, 5 is very important for both B and T cells. If you get a 5 expression along with 20, it's either a mantle cell lymphoma or a CLL. And in T cells, if it is lost, it tells you it's either a NK cell or a gamma delta T cell. In this case, 5 is negative, 4 and 8 are negative, 56 is positive and will express TIA1 but not the other cytotoxic proteins, granzyme B and perforin, because this is a inactivated cytotoxic phenotype. So here's a marrow in a 49-year-old lady who had pancytopenia and hepatosplenomegaly. And look at this marrow. On low power, you can't make out much. Even on a slightly higher power, there's nothing much which is very, very obvious in this. But you can see this staining. You can see this CD2 and CD3, and everything just suddenly lights up like a Christmas tree. You can see this very small nodular aggregates, the ones in the intersinusoids, and likewise on CD7, it's even more. So that's how these stains are picked up. You can see this CD5. If you compare this CD5 with what I showed you on CD2 and a CD3, there's a complete loss of CD5 expression. That's the hint that you should now start investigating whether it's a gamma delta T cell lymphoma or a NK cell. 56 positive, TIA1 also positive in this case. Going from gamma delta to NK cell leukemia, how do you diagnose this? This is kind of rare diagnosis. You don't see many, but if you do come across, it's usually a diffuse infiltrate in the marrow. Rarely it's interstitial involvement as well. The nuclei. The thing to remember about NK cell lymphomas, leukemias, is that the neoplastic cells are rather monotonous. They don't vary too much in their morphology. The nuclei are indented and they tend to have a clear cytoplasm around them. You can see necrosis, apoptosis, angioinvasion depending on the quantum of marrow involvement. Again, CD5 will be negative, but in this case, it expresses all the cytotoxic markers along with EBV. You need to have an EBV positivity to call something as an NK cell disease. So here's a 68-year-old male, pancytopenia, hepatosplenomegaly. Again, nothing remarkable really at low power. You can't really identify much. But as you go towards the higher power, you can see this paratrabecular infiltrate, very pale cells here. You know, you can make out some of these indentations in the nuclei. That's the hint that this is something unusual happening, and then you will have to resort to doing immunohistochemistry. CD3 was positive here, and look at the one on the extreme right, CD5 negative. In this case, it's actually a T cell and probably not a NK because it's expressing 8 and 56 negative, and the EBERs are nicely positive. This is NK cell leukemic involvement of the Trifine biopsy. Coming to the last leg of the presentation, here's a biopsy in an adult male which was sent with a diagnosis of a plasma cell myeloma. And these are two areas I've highlighted with these two arrows here, this area here and this area here. Looks plasmacytoid, yes, and it was probably worked up and said CD138 positive and EMA positive. So is this a myeloma? My friends, you need to know that epithelial cells can also express CD138, and obviously they can also express EMA. So you need to understand this and remember this. This is CD138 positive, EMA positive, but this is also CK positive. These are not plasma cells. This is not a myeloma. This is a metastatic carcinoma. So when you do plasma cell evaluation in the marrow, always do it with two markers, CD138 and MUM1, because MUM1 will not be positive in carcinomas. And if you're looking at anything, ever trying to investigate epithelial disease, always do CK with EMA and not in isolation. Here's another case. This is a lytic lesion in the lumbar spine, young 32-year-old male, and this was called as a metastatic renal cell carcinoma because of this epithelial appearance and very nested growth pattern, but it was CK and EMA negative. This, in fact, turned out to be 138 and MUM1 positive with lambda restriction and kappa. I've highlighted one, so it's definitely worked. It's not a bogus light chain IHC. So this is lambda restricted plasma cell myeloma, purely on basis of morphology. Plasma cells are the biggest mimics of them all. They call the melanoma of the bone marrow. So that's something that you need to keep at the back of your mind. This is what plasma cells can do. So friends, Trifine biopsy, there are challenges. It's challenging without a prior diagnosis and extramedullary site to diagnose a lymphoma primarily on the bone marrow. Sometimes even if you have that information, it's complicated by a discordant histology. We know that sometimes follicular lymphoma looks low grade here and the node will show you a DLBL, and then you get all those phone calls saying that, oh, you goofed up. Immunostains are not diagnostic as standalone and must be correlated with other factors. There are inherent problems in classifying lymphomas purely on marrow examination, and therefore you need to have everything with you, the aspirate findings, the flow cytometry findings, and probably even the cytogenetics and the molecular findings. Antibody reactivities, sometimes things, when you're seeing in a conference and you're seeing all these stains which are worked out and cases which are nicely worked up and shown to you, remember that in a daily basis, things are not that very simple. Neuroendocrine carcinomas sometimes can involve the marrow, and they can show you PAX5 and DDT expression. So if you do some very patchy panels and you don't do a complete panel, you will end up making a wrong diagnosis. CD117 that everybody does in the marrow actually marks a whole bunch of cells. It's erythroid cells. It will mark mast cells. It will mark myeloid progenitor cells. So plasma cells as well. So these are all reactivities one should be aware of. CD117 is also expressed by melanomas and small cell carcinomas. So everything is in a context, not on an individual stain. And I already told you about 138. Always try to do along with one more plasma cell marker. That's always useful and a safer way to approach it. This is the last case I'm going to show you. This is a marrow which was sent in referral, citing a diagnosis of pre-B lymphoblastic lymphoma. You can see this TDT positivity, CD10 positivity. Not sure if you can really make out, but there are some very few dim positive, PAX5 positive cells here, and perhaps that was the trigger to call it a pre-B lymphoblastic lymphoma, and the CD3 is negative, but just like a single swallow doesn't make a summer, TDT positivity doesn't make everything B lymphoblastic lymphoma, and this actually was a blastic plasmacytoid dendritic cell tumor. You can see this was positive for 4, 56, 123, and TCL1. And always remember, Dr. Borges says that, when you get this TDT and you're not able to further classify it, do not forget to work it up by doing a CD123. And this case was one such thing. This was a blastic plasmacytoid dendritic cell tumor. Patient on specific query apparently even had cutaneous skin lesions. So TDT expression besides ALL can be seen in double-hit lymphomas, high-grade B-cell lymphomas, NOS. It's a separate category now in the new classification. Castleman disease with or without associated FDC tumors can show you TDT positive cells, and likewise angioimmunoblastic T-cell lymphomas can show you TDT positive cells. They will be sprinkled and not diffuse. Thymic tissue, hematogones, this will be physiologic expression of TDT. DPDC, and I just showed you AMLs, just like ALLs can show you myeloid antigens, you can get TDT in myeloid things as well. Merkel cell carcinoma expresses, again, it's a neuroendocrine tumor, and therefore also I just told you that neuroendocrine carcinomas can express TDT and PAX5. They can show you expression, and there is such a thing as an indolent TDT positive T-cell lymphoproliferation, which can also show you TDT expression. So thank you. I hope you enjoyed the talk.
Thank you so much, sir, for an informative session. And I would please request Dr. Nisarg sir to present Dr. Jai sir with a memento. Now as we approach midday, I think we'll break for lunch, and everyone please be informed that lunch is being served in the lawn area where the breakfast was served in the morning, and you will have your lunch coupons in the folders that were given to you in the morning. And we'll break for an hour, and we'll rejoin within an hour. Lunch is being served in the garden area. Everyone please take note of it.
speaking on the viruses, then flow cytometry will come. Hodgkin's lymphoma or Hodgkin's disease. It's not moving here, yeah. I think I will have to maybe log out and join again. One sec. I'll just try again. Yeah, it's working? Yeah. So Hodgkin's lymphoma and Hodgkin's disease. Before that, hello, बैठ जाओ. Lymphomas is the two types, Hodgkin's and non-Hodgkin's, as of today. Common types of lymphomas in adults, these are the 4 common types, 5, and in children these are the 4 common types. WHO will tell you there are 200 or 300 types of lymphomas, but practice-wise, these are the 4, 5, 6 labels we generally use, most of us in our practice. Why Hodgkin's lymphoma used to be called as Hodgkin's disease? Because tumor cells were scanty and background was inflammatory. So it was called as Hodgkin's disease for many years. Now we know it's a lymphoma, it's a tumor. So it's a Hodgkin's lymphoma, where the tumor cells are in scanty. Tumor cells are scanty, background is abundant. And background is basically inflammatory cells, immune cells, rich in eosinophils, histiocytes. So now here, if you read this yellow color line, based on morphology alone, Hodgkin's is the most easily diagnosed subtype of lymphoma. I remember even 20 years back, we used to diagnose Hodgkin's, maybe not doing IHCs and all, and it was told that you don't have to do Hodgkin's, IHCs, classical Hodgkin's, why do you want to do IHCs? Now, even with doing IHCs, we keep it pending for 10-15 days. So the older data is not the Indian, I'm not talking about Indian Hodgkin's diagnostic skills. I think this must be universal, even Western world. So we were lucky to talk to many experts during the WHO, writing the WHO chapter when Anita was writing, and we realized many of us have learned so much about Hodgkin's in the last few years, and will keep on learning, that many of the data which has been published on Hodgkin's survival curves has to be taken with a pinch of salt, because fistful of salt, or maybe bucket of salt. If you see the survival curves, ABVD or some other drugs given, and Hodgkin's behaved well, if they had stage 1, or they had more eosinophils, or they were GATA3 negative, or GATA1 negative, because many Hodgkin's are not Hodgkin's. Because I have diagnosed many Hodgkin's which turned out to be viral infections. I am smiling, but very sadly I have done it. And many cases have come back to us and then reviewed by my colleagues and by myself from outside pathologists, and said, oh, this is not Hodgkin's, this is a viral infection. So you have to be careful when you call. That's why the line is, Hodgkin's is the easiest diagnosed, because you see the RS cells, some inflammation in the background, we call it Hodgkin's. You may be right 90% of the times, but 10% or 15% is huge where we make mistakes. So Hodgkin's lymphoma, traditionally, classically 2 types, classical Hodgkin's and NLPHL. Classic Hodgkin is 4 types which we know it. It continues in the WHO the same way. These 2 subtypes are very similar, but they are different also. But they have been put in the same category of Hodgkin's because of the one reason. One, let it be there since it's there. Second, the tumor cells are scanty in both. They're very scanty tumor cells. However, NLPHL is more like a low-grade B-cell lymphoma expressing CD20. Maybe it's more like marginal zone lymphoma. But it has been still continued to be put in the category of Hodgkin's. I'll show you quickly some cases, then Then I'll show you some variants and close overlaps with Hodgkin's, and then in the last I'll show you mimics. So young boy, left cervical node, large node. You can see a diffuse pattern. As Pravin was mentioning, pink looking, it is a lot of histiocytes and lymphocytes in the background. We can make out on the low power, and there is a circle there. You can see that some blue cells sitting there. Possibly these are all CD20 positive mantle zone cells, possibly. And they're all tightly packed. The rest, most of the cells will be T cells with histiocytes, eosinophils. So that corner, there is no germinal center or secondary follicle here. There's just small blue cells somewhere. So next par, you can see there are some eosinophils and histiocytes you can make out. Case 2, 4-year-old boy, left cervical node, 2 centimeter in size. Again, pink looking node, and some, these areas like blue areas, some follicles, residual, but mostly expanded, looks like expanded T zone or interfollicular zone is expanded by a pink, very pink looking node. When you say pink, pink means polymorphous background, histiocytes, eosinophils in the background, or the tumor cells or the lymphoid cells have more cytoplasm. That becomes pink. Eosinophils. So you can go to the next part. You have some germinal centers here, one secondary center, secondary follicle here also, but this expanded paracortical zone. And here you can see eosinophils and some large cells. These are the large cells. And you can see eosinophils if you can appreciate from there. And they are here in clusters. So looks like Hodgkin's lymphoma. Do we need IHCs? We do IHCs. In my practice, I'm sure many of us, we do 5-6 markers up front. CD3, 20. 3 is a T cell marker. 20 is a B cell marker. Not the best marker for B cells. Best marker for B cells will be 19 or maybe PAX5, 79 alpha or 79 beta. But 20 is used because of rituximab. So 20 and 3 are the traditionally commonly used 2 markers, or postgraduate should know. Then we do CD30, which is a kind of a golden marker for Hodgkin's, which is actually not. It's positive in many other cells. We'll see that. CD15. Then we do EBV, LMP1, and we do PAX5, the most important stage. So without PAX5 and 30, we don't diagnose Hodgkin's. So without 30 and PAX5, actually we do all 6 markers, but these 2 are mandatory, 20, 30 and PAX5. If you do Hodgkin's lymphoma diagnosis without these 3, there can be more problems, because with 6 also we have problems. So we do stains. Now look at the background 3. We did 3. 90% cells are CD3 positive. So it is a T cell lymphoma. It is not T cell lymphoma because our cells of interest are not the small cells as of now. 20, you see, it's depleted. Very few. Some secondary follicles, mental nodules are there. And this is CD4. Background has got more 4 than 8. And you see this rosetting of tumor cells by CD4 positive T cells. Now the important stain is CD20. Now here you see CD20, it's showing you, can you see this is negative? This is negative. But if you come to this area, there are some weak positive cells and some moderate to strong positive. So 20 is variable in this case. Generally 20, in our practice, mostly it's negative to weak. Mostly negative. CD20 is negative in this mutated B cells. Here in this case, we see that 20 is variable. This area, the tumor cells are negative, if you can see this circle. Here there are some weak cell positive, 20 large cells, and here the large cells are strong 20. So this is called as variable expression of CD20. Oh, I can do that. Oh, yes, sorry. I will do that. Laser pointer. Pointer options. Yes. Thank you. So, yeah. See, this is the way you pampered. Thank you. So you can see these large cells are negative. Can you see all of us or no? Yeah. Now it was 15 positive EBV LMP1. EBV LMP1 is by IHC. the best is to do Eber-ish. But for Hodgkin's, somehow God has been kind. For Hodgkin's disease, mixed cellularity, EBV LMP works very well. And I don't get bashed up by my colleagues when I meet them once in a month. कि टाटा में अभी तक Eber-ish नहीं करते? तुम कहाँ पे रहते हो? किस दुनिया में हो? Tata is a government hospital. We are not privileged like Anita and Jai and Pravin. We do EBV LMP1. But now, thanks to my colleagues, we have started Eber-ish, because Eber-ish is an extremely important stain, because there are 7-8 types of lymphomas defined on Eber-ish. So if you don't do Eber-ish, you will not be able to, confidently diagnose those cases. 30 is positive. You can see this Golgi, membrane, all over. 30 is here, many cells. But 30 can be positive in immunoblasts also, plasma cells also. So you have to be sure that these are tumor cells. Now we come to PAX5, the magic stain. PAX5 is a B cell transcriptional factor. Now PAX5 is strong in which cells? Normal B cells. So the nodule of B cells is strong. Our tumor cells are here, which are weak. You see in the center? The large cells, they are weak. How do you say weak? You compare with the normal B cells in the background. That's all is pathology, you compare. So positive, negative is 1 point, second is intensity, third is heterogeneity. So you have to see all. Like I showed you 20, positive, weak positive, negative. This is called as heterogeneous. Now PAX5 is weak, 30 was strong. So when you say positive, negative, it should be in the cells of interest, and what is the pattern? Okay, so if your PAX5 is weak in your normal B cells, your tumor cells will become negative. So you have to be very sure that your PAX5 is very strong in the normal B cells. Another young boy, lymph nodes. Here again you see tumor cells and small blue looking, tight blue looking mantle zone cells, and tumor cells are in sheets, large cells, looks like carcinoma, ALCL, or maybe Hodgkin's. So all these differentials come to your mind. So we do IHCs, we'll do cytokeratin, LCA, negative, all negative, LCA negative, 3 negative, 20 negative, cytokeratin negative. What do you do next? So you see this morphology, sheets of tumor cells, all LCA negative in the in the large tumor cells. LCA is negative. This is only in the lymphocytes. 3 is negative, 20 is negative. So obviously you do 30. 30 we did, it was positive, but strongly. 15 was also thankfully very strongly positive. 15 we mostly call it negative, but we have to be careful in doing the interpretation of 15. It can be weakly positive. So that's why the Western literature says 60% of Hodgkin's are 15 positive, but our reporting mostly say 15 is negative, but we have to be careful. The PAX5 is here, it is weak, weakly positive. So Hodgkin's lymphoma. So this is a case of Hodgkin's lymphoma with heavy tumor load. So rarely you can get Hodgkin's. Generally Hodgkin's has scanty tumor cells, rarely you can have heavy tumor load, which can be confused with ALCL also. So the definition of classical Hodgkin's lymphoma, I've copied from the chapter written by Anita. It's a neoplasm derived from germinal center B cells characterized by scanty tumor cells, embedded in a reactive microenvironment rich in immune cells. The large neoplastic cells show a defective B cell expression program. PAX5 negative classical Hodgkin is extremely rare, but it happens. So then you need to do more markers, more transcriptional factors like OCT2, BOB1, maybe GATA3, STAT6. So multiple markers you need to do. So one B cell marker has to be positive, because Hodgkin's is a B cell lymphoma. If everything comes negative, then you do ALK. Anyways, ALK you would have done it when PAX5 is negative. So if ALK is also negative, then you start thinking of, is it a ALK negative ALCL or Hodgkin's? So those are the tricky situations. Then you do CD4, like Pravin shown you the cases, CD4, EMA, 43 for ALCL also. So I'm very happy. Jay stopped us because of post lunchtime. You'll always sleep. So answer, Joy will ask question, Anita will answer. Yes. Of course, of course. I said that. You have to do multiple, see PAX5 is only one. PAX5 negative Hodgkin's is rare. But if PAX5 is negative and you're suspecting Hodgkin's, you do OCT2, BOB1, GATA3, then I said STAT6. I do even MUM1. So these are all B cell markers, something, but MUM1 can come positive in ALCL also. So you don't depend upon one marker. So you do multiple markers. If all these transcriptional factors for B cells are negative, then you start thinking whether it's ALCL or something else. Next case. Diagnosis. Yes. पीछे बच्चे बैठे हैं जो सो गए. ये case you have to know. MD students should know this case. What's the diagnosis of this case? Postgraduates. Any third year here, final year students here? I will finish in my time only, I won't take more time, but I won't show more cases because I have a lot of cases. So it's good to participate. Anyone wants to say, guess, what is it? Any final year postgraduates? What pattern do you see? What do you see? Nodular pattern, one, thick fibrotic bands, so only one diagnosis. Hodgkin's disease, nodular sclerosis. Bas, yes. Yeah. You can see this large cells, lacunar cells or spider cells here in the low part. As Anita said, you make up your mind in the 2x. If you do not make up your mind in 2x or 4x, leave the case. You need second opinion. I do that in my practice. I get a difficult lymph node, I know 2x. I tell my residents, it's an interesting case, take Shridhar's opinion. Because I know I will take 20 days on this case. So before I take 20 days, I immediately send it to my colleague. And he'll also go, he gets worried because I'm happy that he's also, because it's difficult. If you do not know on the low par, what is it? I bet you will be signing that papers at least 6 times. Because multiple ICs, more ICs, more ICs, more ICs. Till, complaints against you that he's doing more ICs. So I'm going to the next par. You can see all this starry sky lacunar cells. They are not starry, they are not tingible body macrophages. They are just tumor cells which have clearing around the nucleus. Okay, you can see this donut, large cells, tumor cells. All these are tumor cells, and background is immune. There are eosinophils, you can see that. So you do again same stains, 3, 20, PAX5, EBV, 15, 30, 6 stains. 3 is background is rich. You see 20 now. 20 is negative here. You see the large cells? 20 is depleted. Hodgkin's classically, the classic Hodgkin's lymphoma, CD20 is depleted. Classically. Nothing is ruled here, but mostly it's T cell rich background, CD4 positive T cells. So that's why it's confused with PTCL, because the immunoblast can look like RS cells. So many times PTCL becomes Hodgkin's, Hodgkin's become PTCL. I'm sure we have diagnosed many in the past. So now again 30 done positive, 15 positive, you can see nice. This can't be immunoblast, this is surely RS cells, because there are other cells which could be immunoblast, like I'll show you here, this 30. Now this is tumor cell, looks like a big, huge pleomorphic tumor cells. But I'll show you some cells which are smaller, which looks like immunoblast. So you have to, everything is in context again. So morphology, then you read your IHCs. If you think on morphology these are tumor cells, 30 will be positive. You'll be happy calling it Hodgkin's, but they are all immunoblasts. So you have to be sure what are you calling as tumor cells. Okay, EBV LMP1 will not work here, and mostly nodular sclerosis is EBV negative. Even in Western literature, though they have more common nodular sclerosis, and in India most likely I think mixed heredity is more common than nodular sclerosis. There's only one publication by Naresh which says that. And in nodular sclerosis, EBV is mostly negative. Next case, again, Hodgkin's disease, nodular sclerosis. You can see nodules, sclerosing band. Next case, FNAC. Now, many of us do FNACs, and we can see this PAP stain and a Giemsa stain, RS cells, some eosinophils in the background, large size cells. If you have Prashant Timhare, you can do flow, and you can diagnose Hodgkin's, but we don't diagnose Hodgkin's on flow. Case number 6, young boy, known case of Hodgkin's lymphoma. Read it, known case, bone marrow is done for staging. Bone marrow is done only for staging, not for diagnostics. So our job when you do Trifine is to say involved, not involved. You don't diagnose at least Hodgkin's on the bone marrow. You can diagnose non-Hodgkin's like Jai showed you. But Hodgkin's you don't diagnose on bone marrow. Primary Hodgkin's lymphoma of bone marrow, no, don't diagnose. Actually, primary Hodgkin's lymphoma of extranodal, without nodal mediastinal involvement is not diagnosed. So Hodgkin's is almost always a nodal disease. It does not go to GIT or lacrimal glands or brain or bone marrow. It can go only in stage 3 or stage 4 diseases, not primary. So you have to be careful diagnosing primary Hodgkin's of non-lymph node sites. So this is a bone marrow, shows a nodular deposits like PTCL, Hodgkin's, they come as big nodules, pink looking nodules, polymorphous background. PTCL will have eosinophils, Hodgkin will also have eosinophils. Both will have histiocytes. Hodgkin will show you tumor cells, large size, bizarre looking, mummified cells, tumor cells. You do 30 and PAX5, as Jai showed you, EBV, and it'll give you a, consistent with involvement in a known case of Hodgkin's. Mimics of Hodgkin's are many, actually I'll come, but just to show you a slide, this is a case of CLL. I think Pravin showed you hypodense areas. If you can appreciate, this is a blue looking diffuse pattern. This on the low power you can say, this is a non-Hodgkin's lymphoma, one. And on second differential, if you ask me, I would think of CLL. If it's a child, I'll think of a blastic lymphoma also. In the low power. Scanner, I will have two differential, either CLL, if it's or mantle, if it's an adult. If it's a child, it's a blastic lymphoma. But now since there are these light areas, you see this hypodense areas, round areas, these are possibly proliferation centers. They are light because they have more cytoplasm, pro-lymphocytes. So if you go to high power, they will have nuclei, more cytoplasm, they look light. And many times they have scattered immunoblasts, para-immunoblasts, which are positive for 20, PAX5 and 30. So many times in the past we have called something as composite lymphoma, CLL and Hodgkin's together. It was actually only CLL with RS-like cells. It is not a composite lymphoma. So you have to be careful when you call it a two lymphomas in one, because RS-like cells can be seen in CLL. So basically, if you look at this next slide, it shows you what are the mimics of lymphoma, Hodgkin's. The commonest mimics are viruses, immune deficiencies and viruses. Epstein-Barr virus, infectious mononucleosis, Epstein-Barr virus, mucocutaneous ulcers, very, very common. Differentials of Hodgkin's. So the commonest differential of Hodgkin's lymphoma, which is a neoplasm, is viral infections and immune deficiencies and dysregulations. Second differential category is other B-cell lymphomas. NLPHL is a low-grade lymphoma. The rest of the two are high-grade lymphomas, T-cell rich, B-cell and gray zone. These are very high-grade, but they can look like Hodgkin's. We'll show you cases. Third is T-cell lymphomas. Peripheral T-cell lymphoma, AITL, ALCL, they can look like Hodgkin's. So you can see that Hodgkin's can look like viruses, other B-cell lymphomas, and many T-cell lymphomas. And sometimes, rarely with carcinomas, that's very rare. So FNACs can be very tricky to diagnose such cases. So don't diagnose Hodgkin's on FNACs. You can only say, suspect. Please do a biopsy for confirmation. So if on biopsy, after doing 10, 15 stains, we take 3, 4 opinions and we still go wrong. So my suggestion is do not diagnose, But since any node you do FNAC first, you do it, but write a report, I suspect, kindly do a whole node biopsy. Now, this was classical Hodgkin. Now we go to NLPHL, the other type of Hodgkin's lymphoma. So this is a 64 male, and a node is axillary node, large node. You can see this node showing a prominent nodular pattern. This looks like follicles here, nice germinal centers. But many nodules do not have germinal centers. And there are some nodules which are very big here. Possibly these big nodules are PTGCs, these ones. Now there's something called as, these are the reactive follicles. You can see the germinal center and the mantle zone outside. So these are progressive transformation of germinal centers where the mantle cells go inside. So they're becoming big nodules. They can fuse to 3 nodules, marginal zone, mantle zone cells. So these are called as big nodules, also called as progressive transformation of germinal centers. There's something called as RTGC, which is regressive transformation, which is seen in Castleman's disease, burnt out germinal centers, RTGCs. So this is big one, there becomes small one, follicles. So now our job is to look at these nodules and look for the tumor cells within the nodules. Like go to the high part and you see this nodule tumor cells. Like this, like this. They are like popcorn shape. Sometimes you don't get these cells. When you get these cells on, I'll show you the IHC slides. So these are the nodules, big nodules, and they are called as PTGCs. If in these nodules you find tumor cells, it becomes NLPHL. If you don't find tumor cells, you leave it as PTGC. So PTGC is a kind of a benign condition, you follow up. You don't do anything. NLPHL is also a low-grade lymphoma. It's mostly stage 1A, low-grade lymphoma. Now if you do 20, here it's on the contrary to classical Hodgkin's, here the nodules are rich in B cells. You see the nodules all full of B cells. All small lymphocytes are B cells. Large tumor cells are also B cells. So here everything is B. So that's why it's more like margin zone lymphoma. Because it looks like if you give me a low power, just show me 20. What lymphoma is this? I'll think of follicular or marginal. Why should I think of Hodgkin's? It is a B cell nodules, beautifully 20 positive. Now just because on morphology the cells are not like cleaved or follicular or mantle, and there are large sized tumor cells there, and the history, and obviously I'll do some other few more markers maybe. I'll do BCL6. I'll look at the large tumor cells. So it can be tricky to differentiate sometimes NLPHL, which has large number of nodules. Many a times NLPHL will have only 1 or 2 nodules, PTGCs. Now this case has many nodules, so it can be a problem diagnosing such cases vis-a-vis marginal zone lymphoma. So these are the tumor cells which shown you, and 20 is positive. As shown, the large cells, you can see these large cells, they are 20 positive. So small as well as large cells are positive. Now this is the 21 to show you FDC patterns. This is a nice normal, this is reactive follicular hyperplasia. Again, very classical of NLPHL. You'll have a big nodule, and at the edge you'll find the normal follicles. So it's a partially, NLPHL involves a node. It doesn't involve generally the full node. So you can find a well-preserved nodal architecture at somewhere at one edge. This is only for photograph, the PD1 rosetting. I was trying to convince myself if I can convince you. So PD1 is for T follicular helper cells. So this is classically seen in NLPHL, not seen in classical Hodgkin's. In classical Hodgkin's you have T cells. Here you have follicular T helper cells. In classical Hodgkin's it's T helper, but they could be paracortical. So they won't be PD1 ICOS positive. So these are the PD1 ICOS BCL6 positive cells. So this is NLPHL, another case. I think another case, 2 big nodules of PTGCs. These ones, you have to look for tumor cells in the nodules. Tumor cells can be outside also. In the nodules, outside the nodules. That sometimes, you know, you need to do 20. They're strongly positive for 20. They're negative for 30. They are negative for EBV. They're strong for PAX5. If they're positive for 20, they will be strong for PAX5. So 20 positive, Pax5 positive, 30 negative, EBV negative. Morphology is very classical. All the small lymphocytes are B and the tumor cells are also B. Yeah, this is a tumor cell again. So the definition of NLPHL is it's also a German center derived B cell neoplasm where the B cell program is maintained, composed of scattered large neoplastic B cells with multi-lobated nuclei within the nodules, can be outside the nodules also, dominated by mantle zone B cells and FDCs. History is very important here, very, very asymptomatic, large axillary inguinal cervical node of 6 months, 1 year duration. If you do FNAC, if it's a lymphoid lesion, all possibilities it will be NLPHL. It could be low grade follicular also, but NLPHL comes as a stage 1A disease. If it is stage 4 disease, the differential becomes like T-cell rich B-cell lymphoma. So T-cell rich B-cell lymphoma and NLPHL are similar diseases, two end of the spectrum. NLPHL is low grade, T-cell rich B-cell lymphoma is high grade. T-cell rich B-cell lymphoma is almost always stage 3 or stage 4 disease, B symptoms. NLPHL is stage 1, mostly 1A, no B symptoms. Rarely NLPHL can be stage 3 or 4. If NLPHL is stage 4, it is treated like T-cell rich B-cell lymphoma. It's same disease, but it's the two ends of the spectrum. So NLPHL and T-cell rich B-cell lymphoma, immunophenotypically they are very similar, morphologically also. NLPHL will have a nodule. One nodule at least you have to see. So sometimes you don't see, you do a FDC marker 21 or 23 to pick up a nodule. So this is the 6 types of NLPHL. Dr. Yashoda Natkunam has published this in the new WHO book, A, B, C, D, E, F. A and B have better prognosis. There's different patterns, you can go through it. NLPHL also has many differentials like classical Hodgkin's, PTGC I told you, T-cell, histocytic B-cell lymphoma we discussed. Nodular variant of lymphocyte-rich classical Hodgkin's. Now this is a rare type of classical Hodgkin's, but it can be confused with NLPHL. Here also the background is more B. Here also the rosetting is done by PD1 cells. So thoda sa ye overlap hai. Then other low-grade B-cell lymphomas we mentioned, like marginal zone lymphomas can look like. Yeah. Now just to show you 2 slides, postgraduates, I would like to ask you, there are 2 Hodgkin's. Which one is which? The postgraduates only. Which is this? There are 2 types of Hodgkin's. One is classical Hodgkin's. This slide is given to me by Jay, I think 10 years back. I kept it, I loved it because you know sometimes you get used to a slide, you don't change it. So I'm here with Jay, teri slide padi hai mere paas. There are 2 cases I'm showing you, both are Hodgkin's. I'm showing you Pax5, which is a nuclear stain. So you have to tell me which is the top lymphoma. Is it classical or NLPHL? How many for classical? How many for NLPHL? Okay, good. This is classical or NLPHL? How many for NLPHL? How many for classical? Yeah, because Pax5 is weak. So here the tumor cells are weak, normal cells are strong, it is classical. Here the tumor cells are strong and normal cells are strong, NLPHL. So 20 is positive, NLPHL, Pax5 is strong. Here Pax5 is weak, 20 is negative. Classical Hodgkin's lymphoma. So now we know this, I think we discussed this, we'll go away. Just to show you rosetting of RS-like cells, like classical Hodgkin's lymphoma, this is a RS cell, will have rosetting by CD4 positive cells. But they need not be PD1 positive, they are not T follicular helper cells. In NLPHL, also in follicular T helper cell lymphomas, the rosetting is of the large size cells is by T follicular helper cells. You can see this rosetting if you can. Here also is nice rosetting by PD1. I'll show you quickly related entities. Now I'm not showing the mimics, will come a little later. Now next is 3-4 cases are like related entities to Hodgkin's. 36. So classical Hodgkin's has similarity in mediastinum with 2 more lymphomas. Primary mediastinal B-cell lymphomas, large B-cell lymphomas and gray zone lymphomas. There are overlapping features between these three. So some cases are classical, some are not classical. There we have problems. So classical cases is easy to identify, diagnose. So I show you a case, 35 male supraclavicular node. Now this you can see lymphoid lesion with some fibrotic bands. There's a necrosis here. And there are tumor cells, fibrosis, tumor cells, necrosis, you can see necrosis, and many tumor cells. They look like RS cells, mononuclear cells, differentials or Hodgkin's. Supraclavicular is part of mediastinum. So you think of Hodgkin's only, 6 markers we did, ALK1 also. So you see here 20 is strongly positive. So now if it looks like Hodgkin's, but 20 is positive. 15 is positive and 30 is positive. So now mediastinal mass or a supraclavicular node, if it is 15, 30 positive, looks like Hodgkin's, but 20 is also positive strongly, we are going towards gray zone lymphoma. So it is a lymphoma which has overlapping features between DL, BCL and Hodgkin's lymphoma. So has features, morphological features also overlapping, immunophenotypic features also overlapping. So I will not spend more time here. Multiple markers we did. Mediastinal gray zone B-cell lymphomas is a lymphoma with overlapping clinical, morphological, immunophenotypic and molecular features between PMBCL and classical Hodgkin's lymphoma, particularly nodular sclerosis. So basically it is a CD20 positive Hodgkin's in the mediastinum. So if a CD20 positive lymphoma is in the mediastinum, you are dealing with gray zone lymphoma. Primary mediastinal B-cell lymphoma is a different disease, a little bit more different. Show you a case. Now this is a nice pink lake and a blue lake. I've shown in last 2-3 meetings, Anita, you must have seen it. You not seen it? Jai? You travel so much. Who travels here? No one travels in Gujarat? Huh? I travel, but I think Gujaratis travel so much. Yeah? So where is this? Huh? Is in Namibia. Now where is Namibia? Okay, Namibia is in which continent? Africa? Okay. Is it southern hemisphere or northern hemisphere? Southern hemisphere, very good. So this is a pink lake in Namibia, and this, if you further go down another 2-3 hours from here, there's a big desert, Namib desert, which enters the ocean. So we drove to that place, but we were not given permission because you have to take a prior permission to see that. But anyway, this pink lake is famous. I do not have a biological explanation, but the interesting story is there are a lot of shrimps in this lake, and the flamingos, they eat the shrimp and they become pink. It is in literature. You go. Algae, some algae. No. Algae. Shrimp eats the algae. Shrimp eats the algae. The flamingo eats the shrimp and becomes pink. See, we are Punjabis. We don't go nearby. We go far. Why should I go nearby? She always says, there's a glacier here. We go to Iceland to see glacier. Why should I go to Lonavala to see glacier here? There are waterfalls. He told me once, there's waterfall. Behind the waterfall, Sumeet, you can go. This is in the, where you said? Near Bombay? Marsage. But Iceland, the waterfall you go behind is so beautiful. So this is Pink Lake there, okay? Okay, anyway, next case. Now this is a core biopsy, fibrosis, some tumor cells, some clearing around the tumor cells. If you can appreciate some nesting pattern, 20 positive, LCA positive. I'll show you a better example of this is a primary mediastinal large B-cell lymphoma. You can see needle core biopsy sheets of tumor cells, large cells, 20 positive. MIB1 is high. They are 30 positive. They are CD200 positive and 23 positive. The sheets of tumor cells. This is a primary mediastinal B-cell lymphomas. Generally occurs in 30 to 40 years old females, more common in females. Primary mediastinal large B-cell lymphomas. I'll skip this. Then I'll show some cases. We discussed in the morning also immune deficiencies. Now this is a tricky area. Lymphoproliferative disorders in immune deficiency settings like HIV, post-transplant, post-chemotherapy, methotrexate, steroids. You have lymphoid proliferations, they can mimic lymphomas, Hodgkin's. So it's very important to get the history, clinical context, and what was the site of lesion. If patient is immunocompromised and you have a Hodgkin's-like disease in stomach or in the lungs, possibly you're dealing with mucocutaneous ulcer. So you stop the immunosuppressant, the lesions will disappear. If you do not stop and you treat for chemotherapy, something else will happen. Patient might recover, but patient never had Hodgkin's. So you have to be careful. But then there is again a very thin line between mucocutaneous ulcers and Hodgkin's. You have to follow these patients. But the ulcers have to disappear once you stop the immunosuppressant drugs. I give you an example. This is a ulcerative lesion in the esophagus, 28-year-old boy from KEM, was immunocompromised. I think HIV is ulcerated mucosa, and there are RS-like cells, large cells. They're all 30 EBV positive, LMP1 positive. It was PAX5 moderate to strong. Second case is a case of rheumatoid arthritis on methotrexate, bronchoscopic biopsy from ulcerating lesion in the done. Again, you know, ulceration, inflammation, and scattered RS-like cells in ulcerative background. Again, 20-30 PAX5 positive. These are both mucocutaneous ulcers. Both patients recovered when you stop the immunosuppressant drugs. So ABV positive mucocutaneous ulcer. So many, history is very important when you diagnose Hodgkin's. Patient is on any immunosuppressant. Is it an extranodal site below the diaphragm? Where's the site? Is it not an extranodal site? Is it in the bone or somewhere else? Mucosal site. So extremely important, the history. Now CD30 can be positive in normal immunoblast. It is positive in normal immunoblast. Doesn't become Hodgkin's. So these are all normal immunoblasts and some plasma cells. No, fail. Can you guess where is this? Oh, you should have said that. This is.
It looked like that there was some smoke arising from some ash cloud.
ये जो तुम hash खा के ना. He is right, but we go to Iceland via Himalayas. So we cross Himalayas, go to Iceland. This is a grass which is green, this is a grass which is red. There are two different colors grass. This is a grass actually on the mountain. This is Ladakh, near Nunkun peaks. I'm not showing you Nunkun today, maybe, yeah, next time. So, next time. That's why once is never enough. So, diagnosis of Hodgkin's, multiple things. So I don't want to leave you confused because we are confused. Here, clinical, morphology, markers, fibrosis, eosinophils, thick capsule, classical RS cells, bad looking tumor cells, multinucleate. But those bad looking RS-like cells can also be seen in angioimmunoblastic T cell lymphomas. I'll show you a case of AITL, which we had no doubt it's classical Hodgkin's. We discussed in Bombay meeting also, everybody says it's classical Hodgkin's, but on the flow, there's a background T cells is all neoplastic. Even on HND of the lymph node, backgrounds was very activated lymphoid cells. I'll show you the case. Okay, so these are the common markers. WHO says you can do so many markers, but these are the essential which we mentioned. Yeah, they are mostly in the nodes and the mediastinum. Primary external Hodgkin's is rare. RS-like cells can be seen in many conditions. RS cells are LCA always negative, 20 mostly negative. 30 can be positive in normal immunoblasts. You have to be careful. PAX negative classical Hodgkin's, careful. MUM1 can be positive in Hodgkin's as well as ALCL. Classical Hodgkin's has a T cell rich background. So, as I mentioned, cells of interest is important. If you think small cells are important, it becomes peripheral T cell lymphoma. If the large cells are important, it becomes Hodgkin's. So you have to, sometimes you are confused, you do IHC, then you go back to H&D. Maybe you change your opinion. No, I thought the wrong. Maybe the small cells were cells of interest. So it can be wrong first time your morphology. You go back, then you realize maybe you missed that. So you see H&D, you see IHC, go back. In the meantime, you take 2-3 opinions also. No, you must take opinions, even if you don't talk to your colleagues. If we don't talk, in my department, we just look at like this. But we take opinions, and we give opinions. And we give a serious opinion. We don't give like, okay, this opinion. No. You give opinion, and if somebody is taking your opinion, honoring you, no? So take your opinion. Next case. 44 male, generalized nodes, B symptoms, left cervical lymph node. Is a diffuse pattern, tumor cells in the histiocyte-rich background. And tumor cells are 20, strongly positive, background is 3. Like NLPHL, but it's a diffuse pattern. It was a symptomatic stage 3 disease. This is T cell, histiocyte-rich B cell lymphoma. Another case of T cell, histiocyte-rich B cell lymphoma, diffuse pattern, background has so many lymphocytes, histiocytes and RS-like cells, which are CD20 positive, and they don't have nodules of CD20 positive. Their small cells are scanty. So NLPHL will show you these nodules, and T cell, B cell lymphoma will be diffuse. Otherwise, they are similar diseases. NLPHL is classically 1A. T cell, B cell lymphoma is generally 3 or 4 disease. So we all agree, diagnosis of Hodgkin's is not FNAC. You need to do a good block section and IHCs. I think this is a case of AITL. You can see this now. This background is bad, but here we in the flow. This is a very beautiful picture. If anybody is planning to do flow or is doing flow, this CD3 and 5 plot. When we do lymphoma screening tube, this population is 5 positive and 3 negative. These are the normal T cells, 3 and 5 positive. This is abnormal population. And in our experience, most of angioimmunoblastic T cell lymphomas are surface CD3 negative. They are cytoplasmic CD3 positive, which on H&D is difficult to differentiate surface from cytoplasmic. On flow, we pick up this. And many of our DLBCLs, marginal zone lymphomas, Hodgkin's lymphomas have turned out to be AITLs based on flow. I'm not giving credit to flow. Maybe we are weak in our interpretations of the lymph node. But yes, these are complementary techniques, flow and microscopy. We need to use both sometimes. In our practice, we use in all tricky situations. So this is a normal population, very classical of AITL. You can do CD4 and other markers. They will be 4 positive, PD1 positive. Now I'll show you quickly mimics. I think we have 10 minutes. I'll show you 3-4 mimics quickly. Young boy, cervical lymph nodes, tonsillar enlargement, 2 weeks. B symptoms present. Diffuse pattern of large cells with small cells. So they're pleomorphism, small cells, very large cells, RS-like cells, and plasma cells. Young boy, tonsillar lesions, and this was from cervical lymph node, and short history. So is it DLBCL or it doesn't look like DLBCL because so many small cells in the background. Pleomorphism in lymphoid cells population. Paracortical expansion. There were B follicles occasional, but many large cells RS-like, mononuclear actually. And if you look at CD3, most cells are 3. Background is totally 3. And there are some large T cells, T immunoblast-like cells. If you can appreciate here. Here you can see CD3. Some cells are slightly largest in size. You see this? These cells are slightly large. This one is large. So you have to see that many cells are small, but there are T immunoblasts in the background. 20 also is positive, but much less than 3. And some large immunoblasts were 20 positive also. So there are T positive majority, which is CD8 positive background, and 20 was scanty, but many large cells immunoblasts were 20 positive. 30 was scattered like 20. PAX5 was weak. You see here weak in the large cells. The EBV was like this. This is Iberish. So this was case of infectious mononucleosis. Again, short history, tonsils, and this morphology. You want to add something, Anita, or you guys, on your experience of infectious mononucleosis?
Infectious mononucleosis, as I said, it occurs suddenly. That is something that no infectious mononucleosis goes on for a very long time unless it becomes chronic active related disease. That's number one. And I don't know if any of you, are there any clinicians in the audience?
Everybody, no?
Huh? Yeah, they have to say that they are clinicians.
There are none.
Everybody says that
They're all pathologists. You know who is a pathologist? Who sits on a stool and watches another. We all are clinicians. We all done MBBS, as Anita says. Yes. Question.
But you know, if you have infectious mononucleosis and say somebody gives a penicillin derivative antibiotic because 2 weeks and the lymph node is in there, pain in the nose, and the person breaks out with a rash, you can bet your bottom dollar that that is infectious mononucleosis. That is a very good test. And like you say, you have to have clinical history as well.
Without history, never diagnose any lymphoma. I do not know about other tumors, but never diagnose any lymphoma without history. Even if it's telling you I'm a DLBCL, take history. Because we have seen 20, positivity, CD20 sometimes can spill out of the cells and falsely can look, even processing is bad. It can look, many cells can look 20 positive. We called it DLBCL. When I review it, I feel so ashamed. Why did I call it DLBCL? It was not all. So you have to be careful. History is very important. Next case, young boy, fever, weight loss, right-sided neck swelling. Lymph node biopsy was done. Fibrosis, eosinophils, tumor cells, RS-like cells. Diagnosis? It looks like Hodgkin's-like cells, eosinophils in the background. But this case was 30. EBV is positive, 30 is positive. 20 negative, LCA negative. So 30 positive, EBV positive. Looks like Hodgkin's. It is not Hodgkin's. Cytokeratin was positive. So once again, cervical node, young chap, single cervical node. Be careful. There could be nasopharyngeal carcinomas can mimic. No, this was very unusual case. It had eosinophilia. 30 was positive. EBV comes positive in nasopharyngeal carcinoma, but generally Iberish comes positive. Here EBV LMP1 was also positive. So it was a very tricky case, but thank God it was picked up. So to conclude, I think I'll stop here. History is very important. Understanding of clinical medicine, all pathologists, you have to have a clinical book with you or go to OPDs, have friends with oncologists or physicians or surgeons, talk to them and learn with them and teach them also and learn with them. You need to know CBCs in all cases, maybe perfect smear morphology. You need biochemistry, you need some LDH, beta-2 microglobulins, ESR. These common tests you need to know, serum proteins, morphology and ancillary techniques, and as I said, radiology. Thank you very much. I finished. Anita turned 75. She gave us a party in where? Taj. So you should be friends with Anita. She takes her friends to Taj. So there are no questions. Thank you.
Thank you so much, sir, for a brainstorming session. And ladies and gentlemen, I would like to invite to one of our distinguished speakers, Dr. Mehta, sir.
Okay, so okay, once the photo shoot is over, Sumeet. Okay, so there are a lot of youngsters here, you know, and we have viruses, virus-driven lymphoproliferations. We have viruses in the computers, right? And does anybody know what virus stands for? It's an acronym, it's not a slang or anything. Yes, I hear correctly. Somebody said, yeah, vitally important resources under siege. So that's what an actual virus does. You know, it hijacks the human B cell in most cases, at least, some of the viruses, and it takes over the functioning of those cells. So these are small organisms. They have their own DNA, RNA surrounded by a protein coat. It hijacks the cell's machinery, that's the host cell's machinery, and it reproduces and makes virions. Now, sometimes they integrate into the host cell, sometimes it just stays as an extra chromosomal form, and they push the cell towards neoplasia. So what are the lymphotropic viruses? A couple of them which are most contributory to lymphoma genesis are the herpes viruses, primarily amongst which is the Epstein-Barr virus or EBV, and the human herpes virus 8, HHV8. The retroviruses include HTLV1, it's human T-cell lymphotropic virus. I think I've incorrectly said leukemia virus, and it's human immunodeficiency virus, HIV. So starting with Epstein-Barr virus, and that's going to take much of the talk because that causes so many diseases. It's a ubiquitous DNA virus belonging to the gamma subfamily of the herpes virus. Almost all of us are infected with EBV. That's said, it's a done thing. It's a lymphotropic virus that usually affects B cells. How do we know that? Supposing you cultured EBV with human lymphocytes, which are obviously a mixture of B and T, about half of them, or at least half of the B cells would become immortal. And then if you cultured them only with B cells, all of them would become immortal. What does that mean? That the other 50%, the T cells are actually regulatory and they control the EBV. So that's, that EBV is B cell tropic and the T cells control the EBV. So here's a small cartoon to understand better what EBV does. You have the EBV virus, the blue corresponds to the outer glycoprotein envelope, the orange is the inner nucleocapsid, and the red thing is the viral genome. So the EBV, that's a virus, binds to B cells via CD21, which is the CR2 receptor, and also in the context of an HLA class 2 molecule. So it kind of latches on to the host B cell membrane. Then the viral glycoprotein actually fuses with the host cell membrane and discharges the nucleocapsid inside the cytoplasm, which in turn the nucleocapsid then kind of latches onto the nuclear membrane and releases the viral genome into the nucleus of the B cell. So you have that red thing here, which is inside the host B cell. That's the normal chromosome here. So it's there inside the nucleus. The viral capsid is outside. The nucleocapsid is on the nuclear membrane. And it doesn't stay like that. It doesn't integrate into the chromosomes. It stays in an extra chromosomal form, and that's called a episome. So it's called a episomal form. So it kind of circularizes as a red thing, and it's there in the nucleus. So EBV is secreted in the saliva, and the human infection occurs via oral transmission. Its oropharyngeal infection leads to what is called a lytic or a productive infection of the B cells that leads to, and subsequently leads to persistence within the B cell by employing what is called the latency programs. So EBV is a transforming agent. It produces blastric transformation and leads to increase in the number of B cells. That's what it usually does. So you have these EBV encoded genes that replicate the viral genome. That happens when you are in the lytic or the productive phase. But it's also smart. It doesn't always want to do it. It will hide. It will hide inside the cell, and it will do so by employing several latency programs. I won't go into them right here, but they have different nuclear membrane proteins, the Epstein-Barr virus encoded RNA, and then they have the kind of membrane proteins, which they use it differentially to have various latency programs and hide inside the cell. At an opportune time when the immune system is down, it will proliferate. So a busy slide here, but I want to tell you EBV causes B cell disease, T cell disease, NK cell disease also, and also it's associated with epithelial tumors. So you had the nasopharyngeal carcinoma that you just saw. It's also associated with smooth muscle neoplasms. In an immunosuppressed state, you can get EBV positive leiomyosarcomas. The B cell diseases, the ones which are obligatorily associated include infectious mononucleosis, EBV positive diffuse large B cell lymphomas, EBV positive mucocutaneous ulcer, large B cell lymphoma associated with chronic inflammation and lymphomatoid granulomatosis. Then there are certain diseases which may be associated but are not always associated, includes plasmablastic lymphomas, Burkitt lymphoma and classic Hodgkin lymphomas. There are diseases which are seldom associated with Burkitt lymphoma, include sometimes myelomas or a plasma cell neoplasm, which is EBV associated, and chronic lymphocytic leukemia. And then there are very important immunodeficiency related disorders that Dr. Sumeet just mentioned about. So it could be primary immunodeficiency, secondary as in with HIV, or post-transplant lymphoproliferative disorders. EBV plays a big role in this. As far as T cell goes, then you have the chronic active EBV infections, either systemic forms, cutaneous forms, chronic active infections in childhood, aggressive NK cell leukemias. There's this extranodal NK T cell lymphoma, nasal or extranasal type. And you also now have in the new classification the primary EBV positive nodal or T NK cell lymphoma. So you can get this primarily in a nodal setting as well. So I'll just take you through a few cases. This is a 24-year-old male who had a history of bulky cervical lymphadenopathy since just about a fortnight, short duration history, had enlarged spleen, fever, sore throat, peripheral smear showed atypical lymphocytes. And if I asked you, we just had this whole discussion, this is screaming to be said that this is infectious mononucleosis. But FNAC was done, which was suggestive of Hodgkin lymphoma, and this prompted actual lymph node biopsy. Some of these images are not the best. These are old times when I had the camera mounted on the microscope. But anyway, so you had on the left side, you have this lymph node, which is showing you some reactive follicle germinal centers, and you have this very dilated, congested sinuses, which me and madam came up with a name for it, bloody sinuses. We used to say that bloody, it's just congested there. And then you have these monocytoid cells in the sinuses, the marginal sinuses here. Interfollicular region showing you this polymorphic population of cells, and these large arrows point to cells which are apparently immunoblast, but they look like mononuclear Hodgkin cells. And then this very typical necrosis, very coagulative type foci of necrosis in the paracortex. And immunostaining revealed CD30 to be positive in all these so-called mononuclear Hodgkin cells, and that was a reason for calling this as Hodgkin, I should imagine, when it was referred. You can see this interfollicular areas also showing the CD30 positive cells, and this is the necrotic area surrounding which is also this CD30 expressing population. When you match it with CD20, almost all of them showed CD20 expression, and when we did this EBERS, they were all expressing EBERS also. So this is actually EBV-related polymorphic lymphoproliferation, and in the appropriate clinical context, this is infectious mononucleosis. These cells, sometimes, and you saw that they are pretty much clustered and kind of loosely aggregated. Sometimes they're in sheets. If they're in sheets, they can actually look like DLBL if you did a needle core biopsy or a FNAC, and if you get things like scattered like this, it could be misconstrued for a Hodgkin lymphoma. So that is something one needs to keep in mind, and that was a reason that this was called as infectious mononucleosis. It probably represents one of the pathologically most misdiagnosed reactive lymphoproliferations. So all the more reason you need to pay attention to the clinical history. As Dr. Borges said, short duration clinical history, it should trigger something. Hodgkin's doesn't present as a short duration enlargement of a lymph node. Fever, sore throat, atypical lymphocytes, or what we call as atypical monos on peripheral smear. Going next to association of EBV with classic Hodgkin lymphoma. So about half of Hodgkin lymphomas will be associated with EBV. If it's a HIV infection, almost all of them will be associated. As far as the subtypes go, lymphocyte depleted, very high numbers will be EBV positive. Mixed cellularity about 2/3, and nodular sclerosing literature is kind of biased, ranging from 10% to 40%, any of them can show you. But RS cells are crippled B cells. Dr. Gujral kind of emphasized that. They are crippled. And what do you mean they are crippled B cells? They have destructive mutations in the immunoglobulin genes that reduces affinity with the antigens. What is the sole purpose of a B cell? What does a B cell exist for? A B cell exists to make immunoglobulin, and in the bargain has to make a proper receptor which actually binds with the correct antigen. If you do not get that binding affinity correct, the body just disposes it off. It's supposed to undergo apoptosis and die. And that's what these cells are supposed to do. These crippled B cells are not supposed to live, but it's the Epstein-Barr virus which provides the alternate mechanism for it to survive and turn neoplastic. So, and it does this by employing latency programs, the latent membrane and proteins LMP1, 2, and EBNA1. So this is a B cell. This is the surface of the B cell. You have the BCR, that's the B cell receptor immunoglobulin. And you have the co-stimulatory molecule CD40 receptor and its ligand CD40. When you have these cells which are antigenically crippled, and they are called abrogated B cell program, these are supposed to die. What the EBV does is, it substitutes for the B cell receptor by its LMP2A protein, and for the CD40 receptor by the LMP1, and gives the survival signals. So these cells which are supposed to die do not die, they actually proliferate, and there is anti-apoptotic signals provided by EBERs, for example, and they survive. And because they are crippled, they will have some of the other mutations in it and lead to neoplasia. So here's a Hodgkin lymphoma. We saw these in the previous talk, and look at that EBV on this side and the very dim PAX5 expression. So that's very typical for a classic Hodgkin lymphoma. Now coming to prototypic EBV-associated neoplasms, on one hand you have the lymphomatoid granulomatosis, on the other hand NK T cell lymphoma. Both are angiocentric, angiodestructive processes, both are extranodal diseases. Lymphomatoid granulomatosis more so in the lungs, and the NK T cell lymphoma in the nasal region. They're both aggressive. The difference being that one is a B cell disease and NK T cell lymphoma, as the name suggests, it's a NK T cell disease. And here are images. On the left side, you have the lymphomatoid granulomatosis. On the right side of the screen, of the red line, is the nasal mass, which shows you this. So what is very apparent at this this one, is that it's very necrotic, and you have this peritheliomatous growth almost. It's just around the vessels, you can see that. And this very typical necrosis that you associate with EBV, you can see this. Moment you see this in the appropriate setting, you should start thinking this is an EBV-related process. Could be neoplastic, could be infectious mononucleosis, but that's a picture you should keep in your mind. This is a nasal mass. You can see this pink thing is all the necrosis, and the viable cell is all blue here. You go to the higher power, and you can see even there is some neurotropic association for both of these diseases. Medium-sized cells, they all look very, very aggressive and neoplastic. One is a B cell disease, other is a NK T cell, so it expresses 3. Mind you that 5 will be lost, and I haven't shown that here. But EBV is positive across the spectrum in almost every cell. So that's lymphomatoid granulomatosis for you, and NK T cell lymphoma. Lymphomatoid granulomatosis, hitherto we used to call them in any site, but per the new classification, it's generally diagnosed, and I emphasize this, in the absence of an underlying immunodeficiency and primary pulmonary involvement is required. If you get this kind of a picture in the CNS or the GI tract, and if you see that it looks like a lymphomatoid granulomatosis, it has to be called an EBV positive large B cell lymphoma, because usually these are associated with underlying immunodeficiency. So you should get primary pulmonary involvement to call it lymphomatoid granulomatosis. So the nasal type of extranodal NK T cell lymphoma, it's a prototypic EBV-driven T cell lymphoma. It's part of the NK cell program. NK cells are usually seen in sites which do not have the time to respond to antigenic challenge after a period of time. So they have sniffed, they swiftly respond to that. And they're usually in extranodal and mucosal sites. And therefore, these are the sites where you get this lymphomatous involvement. So you can get it in the nose, you can get it in the skin, you get it in the testes, in the brain, you can get it in the mammary glands. All of these are sites that you can actually get them. So these are characterized by angioinvasion, angiodestruction, prominent necrosis, expression of cytotoxic molecules, and by definition, you should always get EBV expression in them. Now, some of these lymphomas need the EBERs to be actually positive. You can't do the EBV LMP1 for these. They might be positive, but in a very low numbers. As far as the extranasal site goes, so as I told you, there could be soft tissues, could be GI tract, testes, central nervous system. The reason to identify this nasal versus extranasal, the nasal one tends to be lower grade, lower stage tumors, tend to be stage 1 or 2. The extranasal ones tend to be higher stage, stage 3 and 4, so it's bad outcome for the patient. Having said it, some of these so-called quote-unquote extranasal ones also have a small nasal involvement, so clinically you should push for that. You should write in your report that the nasal one, nasal involvement needs to be ruled out clinically. So here's a gastric biopsy, was referred as a marginal zone lymphoma, and you really couldn't blame somebody because that's what it looks, very monotonous, low grade, and what else do you get in the stomach? You just get one of those common ones, but this one wasn't a marginal zone lymphoma. If you look at it carefully, the nuclei are slightly kind of not so, it's convoluted. It's not round that you get in a marginal zone lymphoma, and here you see this CD3 is positive, 20 is negative. The box next to 3, that's the clue, 5 being negative. So this is either a gamma delta or a NK cell disease. In this case, 2 was positive, negative for 4, 8. Key 67 shows almost 100% labeling of the tumor cell nuclei, 56 positive along with EBER positivity. So this is a NKT cell, rather a NK cell lymphoma. Another case, testicular SOL, you can see on the left side, you can see the seminiferous tubules are kind of been spared, and then you have this very high grade lymphomatous process, and again you can see this swirling around the tubules here. That's what these lymphomas tend to do, and again CD3 was positive, 5 negative, 2 positive, and you can get this, show this EBV association. So it's a NKT cell lymphoma in the testes. So what about EBV association with T cell lymphomas otherwise? Most EBV-associated T-cell lymphomas have a cytotoxic phenotype, which suggests that these tumors may have arisen from the proliferating cytotoxic T-cells that are involved in controlling this EBV infection. So when we talk about those atypical monos that you see in peripheral smear, when you have infectious mononucleosis, those are the CD8 expressing cytotoxic T-cells. They are the ones responsible for controlling the EBV proliferation. They are the ones responsible for giving you that necrotic foci, that coagulative tumor cell necrosis that you see on tissue. That's as a result of the cytotoxic T cells. The speculation is that the disease, because you have to understand that EBV infects the B cells. So how do you get this causal association for T cell lymphomas? Literature is divided. There's no specific or no clear answer to that. But the speculation is that these cytotoxic T cells, which actually control them, somehow or the other are kind of infected by these virus proteins, and they lead to this neoplasm. So LMP1, similar to what it does in B cells, we mimic the cytoplasmic tumor necrosis factor receptor, that CD40 receptor was, leads to survival signals. The EBV provides the anti-apoptotic signals. So basically you are growing and you're not dying, and therefore that's an unlimited quantum of cells to actually to make a neoplastic process. So tumors associated include subsets of PTCLs, you can get AITLs, extranodal NKT, we discussed that. You can get cutaneous T-cell lymphoproliferative disorders, you can get these systemic EBV positive T-cell lymphomas of childhoods, all of them T-cell disease associated with EBV. Commonest association is with angioimmunoblastic T-cell lymphoma, but the funny part is that they do not cause the disease, but it's always the bystander B cell in the AITL which is infected by the EBV virus. So these are kind of affected by the virus. You will have an enlarged immunoblast-like morphology along with them. You do the diagnosis of T-cell lymphoma, is what Dr. Pravin explained to you by that way, but it's the bystander B-cell population sometimes which proliferates and gives rise to a B-cell lymphoma. So sometimes you can get a composite B-cell lymphoma along with the angioimmunoblastic T-cell lymphoma. So here's the T-cell lymphoma, and you saw enough pictures of it, high endothelial venular proliferation on this side. Polymorphic picture, eosinophils, plasma cells, histiocytes, and you have this medium-sized lymphoid cells with clear cytoplasm. Those are lesional, CD3 positive, it's a 4 positive population, PD1 positive, and 23 showing you this extrafollicular dendritic cell proliferation. But the EBV part comes here. These are these big cells here, the very enlarged mononuclear cells, prominent macronucleoli. They are mimicking a mononuclear Hodgkin cell, but versus that, they have very bright expression of 20. You can see that 20 is very bright. Even when you get 20 expression in classic Hodgkin lymphoma, it tends to be dim as compared to the bystander B cells. Here it's very bright. 30 is positive, and here's the EBV positivity in these blasts. Sometimes these proliferate, there's a second mutation, a second hit, which drives this into a B-cell neoplasia. You can then get a composite lymphoma. So coming to EBV and Burkitt lymphoma, in the current classification, there's a strong emphasis to discriminate EBV positive versus EBV negative Burkitt lymphoma, because there are two different theories of how Burkitt lymphoma actually has a genesis. One is the virus driven and one is mutation driven, and both these are different pathways. Having said it, if in the old classification, about 95% of the endemic cases all had association with EBV. Very few, about 1/5 sporadic cases would have EBV association. But if you had HIV, anything from 1/3 to about half of them will have association with EBV. And in this particular disease, it implies the type 1 latency program where the EBNA1 protein causes MYC activation, and EBUS provide the anti-apoptotic signal. So here's a starry sky, high-grade B-cell lymphoma. You can see that. But I want you to pay attention to this for the postgraduates, this one on the right bottom here. You can see this monotonous array, a sea of monotony of these cells, squared off edges, and they're fitting into each other like a jigsaw. All of them, they're neatly fitting into each other. That's a signal that this is likely to be a Burkitt lymphoma. And sure enough, when you do the markers, it's 20 positive, 10 positive. It's marking almost every cell with Ki67 and MYC, and BCL2 was negative. This is an old case, and the trigger to do the EBV in this case was this patient had a prior history of liver transplant, and therefore the EBV was done, and this EBV is brightly positive in this case. Going to plasmablastic lymphomas, these are aggressive high-grade lymphomas which were originally described in the oral cavities, but you can get it in any mucosal site, including perianal region as well. Most of them are seen in the setting of HIV, but you can get them even minus the HIV setting. But the association with the Epstein-Barr virus is very high. Now, interestingly, only EBER association is identified in this case. It's a feature reminiscent of the latency expression in memory B cells with plasmacytoid differentiation. That's called a type 0 latency pattern, where every of its thing is downregulated except the EBERs. That's the only thing which is active and keeps it going in the latency phase. So here's a submandibular lymph node mass in a 50-year-old male. This was a HIV positive patient. And you can see all the sinuses are clogged by all these largish cells, very plasmablastic look, enlarged nucleus, prominent nucleoli, abundant plasmacytoid cytoplasm here. And when you did the stains, CD20 and 3 was negative. These express the plasma cell markers 138 and MUM1 nuclear positivity there, showing you kappa restriction on light chains, PAX5 negative, and EBV was positive. Again, these are old pictures, and subsequently I've learned that although PAX5 turns out to be negative, the plasmablastic lymphomas almost always express OCT2 and BOB1 for some strange reason, but that's something in experience. We have seen that, and that's a thing, so you could do a OCT2 and go further and prove the same. EBV positive diffuse large cell lymphoma occurs over wide age range. You can get it in younger population, elder population. The younger population, mainly a polymorphous or polymorphic picture. Adults can get both monomorphic and polymorphic appearances. The problem is when you have this polymorphic picture, how do you distinguish that from a EBV positive classic Hodgkin lymphoma? You can do that. It's difficult, but you can try that. You can do that if the expression of B cell markers in more than 50% of the tumor cells, and when I say in more than 50, all the B cell transcription factors. Hodgkin's would tend to lose them, but if it's a EBV positive large B cell lymphoma, there's no reason for those cells to actually lose those B cell transcription factors. So that's how you distinguish between those two cases. Now this is an elderly 75-year-old male with axillary lymphadenopathy. Again, if you see closely, this is that very typical necrotic thing that you see for EBV, and you are seeing that here as well. Otherwise, a polymorphic population, you can see a spectrum of large cells, medium-sized cells, small cells, histiocytes. These are very hyperchromatic, almost smudged chromatin on this side, and you can see some eosinophils also hanging around. So this is what you would get for an EBV positive large B-cell lymphoma, 20 expression, 30 PAX5 and EBER. Also, at this point, I do tell you that CD30 expression if you get it in appropriate, all of these contexts of these necrosis and elderly population, CD30 is a soft indicator that there is an underlying EBV infection. You might want to therefore also check for EBV status if you get the CD30 positivity. EBV association with CLL, SLL, Dr. Gujral showed you this. It has no direct causation or anything for CLL, but you get this very enlarged para-immunoblasts in this CLL proliferation, and these are stimulated by EBV. And these are those kind of big cells. You can see this is a background of CLL. You can see this very huge, large cells, mononuclear cells. Sometimes they're binucleate, very prominent macronucleoli. Remember what the EBV does. It leads to blastic transformation and cell proliferation. So those are responsible for this huge sizes. The background is CD20, the DIM5, 23 positive and 3 negative. And you can see these big cells are all CD20 positive, CD30 positive. On the top left, you have this EBV, that's EBER. So that's the whole explanation for these para-immunoblasts showing you this expression pattern. So synopsis for this EBV lymphomagenesis: EBV infects B cells. It encodes proteins which mimic growth, transcription, anti-apoptotic factors. It usurps the regulated homeostatic cellular function of B lymphocytes to its own advantage to drive the neoplasia. Now, causal association ranges from something very benign, a condition like an infectious mononucleosis, to something very lethal like a nasal NK T cell lymphoma. It's associated with classic Hodgkin lymphoma, B cell lymphomas, T cell lymphomas. So the entire spectrum of lymphomas can have EBV association in them. Going to the next virus that I'm going to discuss is the HHV8 virus. It's a member of the adenovirus. But suffice to say, again, it infects the B cell like the other herpes viruses, and it remains in a latent stage with the viral latency-associated nuclear antigen called LANA. And the antibody that we use is also the HHV8 LANA protein. What are the causal associations? Kaposi sarcoma, HHV8-associated plasma cell variant of Castleman's disease, and primary effusion lymphoma. These are the three things that are usually associated with HHV8 lymphoid associations. There's also an HHV8-associated diffuse large cell lymphoma also. So unlike, talking of Kaposi sarcoma, unlike classic Kaposi sarcoma, the AIDS-related or the HIV-related ones tend to appear on the upper body, the head-neck region, but they can infect the the palate, the alveolus, it can infect the lungs, it can infect the stomach, any of these organs as well. And this is one such case. This was a known HIV positive individual who had an ulcerated lesion in the stomach, and this is a biopsy from that. And you can see this very spindle proliferation. You can see this, there's some hemorrhage between the spindle cells. This is the very limited slit-like vascular spaces. And what I've highlighted here is this intercytoplasmic globules that you tend to see with Kaposi sarcoma. It's expressing CD31, CD34, which are vascular markers. And here you have the HHV8 LANA protein. That's a nuclear stain. And you can see this lesional cells showing you positivity for HHV8 LANA. And this is another case which is a known, again, a retrovirus disease positive patient, 30-year-old male on highly active anti-retroviral treatment. He developed generalized lymphadenopathy, and a cervical lymph node was biopsied. So this is the lymph node. You can see this CD20 showing you these germinal centers, CD3 showing you the interfollicular T cells. The section has gone through the hilum, so that's what you're seeing in the center of the lymph node. And CD23 is highlighting the FDC meshworks. But what is important to notice here, you can see that FDC meshworks are showing whole gamut of germinal centers, something which is hyperplastic, something is midway, somewhere it's just almost completely regressed. You can see these very tiny ones here. And CD38, which is a plasma cell marker, is showing you sheets of plasma cells in the interfollicular region. So all of these, along with this mixed appearance of germinal centers where you're seeing something which are very hyperplastic follicles to something which is on its way out, regressed follicles. And even the hyperplastic germinal centers you can see here, they're just full of FDC meshworks. And the interfollicular region we saw by CD38 is full of plasma cells. So this whole spectrum of findings suggests that this is a plasma cell variant of Castleman's disease. This is the hyperplastic follicle with prominent FDC meshworks, P24 GAG protein. It's an antibody which tells you that it's an HIV infection in these individuals. So marked interfollicular plasmacytosis, increased vascularity, and follicular hyperplasia and regression define the plasma cell variant of Castleman disease. But what is something again unique with HHV8 infections is the follicle dissolution that you see with this kind of tumors. And this is accompanied by marked tropism of these virally infected plasmablasts, or what you call as immunoblasts, in the mantles of these follicles. They are, for some strange reason, kind of homing to these mantle cells. And in a very enigmatic way, they almost are always lambda restricted. IgM positive, they are HHV8 positive and EBV negative. They express OCT2 but not PAX5. They express BLIMP1 but not CD138. And as opposed to other Castleman's disease where the sinuses are actually packed off or they are obliterated, in this disease you can see sinus dilatation actually. So here's a regressed follicle, and you can see this follicle dissolving. What do you mean by follicle dissolution is that the mantle starts actually kind of disintegrating. You can't really make out the mantle very well here, but this arrow is pointing to what we are seeing as an immunoblast, which is in the remnant mantle there. More of these areas, you can see this blue arrow is pointing towards that tropism of the plasmablasts, immunoblasts to the mantles. Better highlighted here by MUM1, which is showing you this positivity, and HHV8, which is showing you these blobs within the mantle cell. So that's the thing that you see. Another important observation, if somebody is observed here, this is the FDC meshwork, and that's what the LANA protein does. For some reason, it highlights the FDC mesh, the wisps of the FDC meshworks as well. So that's something that is seen with the LANA protein immunohistochemistry. And on light chain, this is actually light chain in situ hybridization. You can see those cells are all lambda restricted. They are negative for kappa. That's the enigmatic thing. No clear answer as to why the HHV8 LANA prefers doing this lambda restricted and lambda restriction. So in a summary of this follicle dissolution, this is the lambda restriction. You can see this HHV8 in the follicles here. Rather the mantles here. They are all IgM, EBV negative. IgD highlights the mantle, the corona around the germinal center. OCT2, a bit difficult to identify, but it's positive, and PAX5 is negative. This is the synopsis of that whole follicle dissolution. You can also get micro lymphomas which develop from these HHV8 positive plasmablasts, and from there on you can get the HHV8 positive diffuse large cell lymphoma. But the story doesn't end here. This node also had mildly thickened capsule. This is the low power that I showed you. This is the area here. This is the area, and you can see that these are spindle cells, slit-like vascular spaces. There are all these erythrocytes within this lumina. This is actually a Kaposi sarcoma in the same lymph node. And this is the lymph node capsule's trabeculum, which is going inside the lymph node. And you can see this is all HHV8 positive. Incidentally, if you see here, that's one of those nodes which is showing you this tropism of the mantle cells by the same punctate dot-like positivity for those immunoblasts. And the high power shows you that these are the Kaposi sarcoma cells in the same lymph node. Another area of the lymph node near the hilum also showed similar involvement. So this is in an HIV positive individual. This is an HHV8 associated multicentric Castleman disease, the plasma cell variant, and an associated Kaposi sarcoma. From that we go to the human T lymphotropic virus, the HTLV1 virus. These are different because these are retroviruses, and in the age of COVID now, all of us know what a retrovirus is, right? So that's what these take an extra step to change their RNA genes into DNA, which means they need to have a reverse transcriptase and an integrase within its genome to do that function. Now, HTLV1 virus infects again the CD4 expressing T lymphocytes transmitted by sexual contact or from mother to infant through breastfeeding. Most of the times it's harmless, but maybe in as many as say maybe 1 in 20 infected individuals eventually develop a type of adult T-cell leukemia lymphoma. It's called ATLL, that's what we usually call it, which is clonally integrated HTLV pro virus within the neoplastic cells. So here's a case that I had come across, a 30-year-old male, bilateral cervical lymph nodes. Patient had skin rashes and elevated serum calcium levels. And this is, it's a very obvious malignant lymphoma. Can't see much at this side, but what you can see is some large cells are standing out, but at the background are all these medium-sized lymphoid cells, which are the neoplastic cells. You can see them in high power here. They have convoluted nuclear membranes, but these large cells, they're obnoxiously huge, cerebriform nuclei, convoluted nuclear membranes, multinucleation, all kinds of pictures are being shown in this. But what's important to notice here, it's a T-cell disease, 3 expression, CD2 expression. Importantly, they tend to lose CD7. However, that's not a great thing because most T-cell lymphomas tend to lose CD7. That's the first antigen to be lost in a T-cell lymphoma. But these diffusely express CD25, 4 positive, 8 negative. Sometimes you can get both double positivity, double negativity as well. This disease also happened to involve the liver. So that's the core biopsy which was done in the same patient. So this one is an ATLL. Having diagnosed it, we kind of persisted, told them to get the serum HTLV1 titers, and sure enough, the HTLV1 titers were elevated. So ATLL, you get a paracortical expansion by medium to large size lymphoid cells, irregular nuclei, and you have these very funny cerebriform giant cells, so that the cells can look Hodgkin-like, you can look like anaplastic large cell lymphoma, you can even get small cell variants, so a spectrum of morphologic findings. So you need to kind of keep this in the back of your mind. If you get this kind of a pattern, and if you have CD3 bright and you have CD7 loss, then you can try doing a CD25 and kind of getting the serum HTLV1 titers. HIV transmission, all of us know about it. So again, it's basically breaching the mucosal barrier, infecting the local mucosal lymphoid tissue, and again the CD4 lymphocyte, CD4 expressing T cell is the one which is all the action where it is happening. So HIV doesn't itself really cause a lymphoma, unlike a EBV, for example. What are the causes of enlargement, lymph node enlargement in a patient who is HIV? You can get non-Hodgkin lymphomas, you can get Hodgkin lymphomas, you can get Kaposi sarcomas, nodal Kaposi sarcomas, multicentric Castleman disease, a variety of infections, including tuberculosis. And the commonest cause of isolated or generalized lymphadenopathy is the HIV virus itself. And it's called the persistent generalized lymphadenopathy. You get a spectrum of changes in the lymph node which is benign HIV associated, starting from follicular hyperplasia to depletion of the follicles. The follicular hyperplasia could resemble a follicular lymphoma, and when you have the depletion of the follicles, actually looks just the paracortical expansion, makes it appear like a T-cell lymphoma. So a lot of these morphologic changes can simulate a lymphoma. Basically, HIV-associated lymphomas, all lymphomas that occur in a non-HIV patient can occur in a HIV individual. The commonest ones, the first thing that maybe students that say that is plasmablastic lymphoma. Yes, it is heavily associated with HIV, but in my experience, I think it's still the DLBCL, which is the commonest one that you get with HIV. Hodgkin lymphomas, of course, you can get it, but plasmablastic lymphomas, a high proportion of them, because of their EBV association and underlying immunodeficiency, you can get plasmablastic lymphomas. Now, infection with HIV is associated with a greatly increased risk of lymphoma development, although the role of virus appears to be indirect. There's no direct causation for it. However, a disease which is directly caused by it is a lymphoepithelial cyst, which is usually seen in the parotid region, but this predates the anti-heart era. When nowadays with this anti-heart treatment, you tend not to get these lymphoepithelial cysts, but I had one I thought I should share with you. This is a parotid region cyst. You can see this cyst lining by what appears to be an epithelium and this lymphoid follicles in the wall of the cyst. On higher power, you can see this 20 is marking the follicles, CD3 the interfollicular cells. Cytokeratin is expressed by the cyst wall epithelium, 23 by the FDC meshworks in the lymphoid follicles. The P24 GAG protein, again, harbinger that it tells you that this is an HIV infected individual. That's the high power of the epithelial line thing and the P24 GAG protein. So if you get this, this is actually almost certainly indicative of an underlying HIV infection, but rare in the anti-heart era. So I think that's all that I have, and I hope your time was well spent listening to this viral lymphoproliferations. If there are any questions, I can take them, or we have Dr. Sumeet's next talk.
Thank you so much, sir, for an informative session. So before we proceed further with our next lecture, we would like to thank some of our distinguished delegates. First of all, the judges of the poster competition. We would like to felicitate Dr. Biren Parikh, sir. So may I please call Dr. Hina to felicitate Dr. Biren Parikh, sir. Next, may I please call upon Dr. Maulik Vora to felicitate Dr. Minesh Gandhi, sir. May I please call Dr. Neha Lewa to felicitate Dr. Kinara Patel. Next, may I please call Dr. Urvi Prajapati to felicitate Dr. Pooja Jarwani. May I please call Dr. Komal Desai to felicitate Dr. Bhaskar, sir. Lastly, for the poster judges, I would like to call Dr. Ritesh Gohil to facilitate Dr. Shakira ma'am. Moving on, we need to felicitate our paper judges as well. Can I please call Dr. Hina to felicitate Dr. Mehta Parikh? Can I call Dr. Neha to felicitate Dr. Urvi Parikh? Dr. Urvi, can you please present Dr. Grishma Thakur with a memento? I would like to call Dr. Ritesh Gohil to felicitate Dr. Purvi Patel. Dr. Maulik Vora, can you please come and felicitate Dr. Neelam Patel? And Dr. Komal Desai, can you please felicitate Dr. Nidhi Sheth? Thank you so much, judges, for your invaluable time. So now, without further ado, please join me in welcoming Dr. Sumeet Gujral, sir, as he continues his lecture on flow cytometry.
It's already on the screen. Good. So, I come to the last of my talks today, and I'm standing between you and Anita. She's going to be talking about accessory cell lesions, the last talk of the day. I'll talk about flow cytometry and its role in lymphomas briefly in 25 minutes. So we know that flow is another way to do immunophenotyping. One is immunohistochemistry, second is flow. The difference is that flow is mainly used for samples which are in the liquid. So lymphomas, we need all this, and immunophenotyping by IHC or by flow, by immunofluorescence too. Solid tissues, immunohistochemistry, liquid tissues, flow. When I say liquid tissues, you could do FNAC also. So the advantage of flow over IHC is flow gives you multicolors. Means on one, like let's say this on IHC, this is BCL2. This is a normal lymph node showing you the negative germinal center, the mantle zone and the T zone are cells. Brown color is positive for BCL2. But the germinal center B cells are negative. There are some T helper cells which are positive. Now if I want to know what is 3 and 20, I have to put another slide. Though my morphology tells me that this is area for 20 and this is area of 3. But I may be wrong sometimes. So IHC is generally single color. Few laboratories do 2 color IHCs. But flow has an advantage. At one time, let's say this is, you see these multiple colors here? Let's say one color, one dot. Pick up this one dot. I'll just do that laser pointer. This one dot here, red dot or green dot, one dot means one event. One event means could be a cell, most likely a cell, or could be a debris or a noise. So let's say one cell. Now the flow cytometry at one time on one cell can tell you 10 markers. So let's say this is one cell sitting here. I can study 10 antibodies on one cell at one time. So this is called as multicolor immunophenotyping. Another advantage of flow is it gives you patterns. Like this is a pattern of maturation. This is CD16 on the y-axis, 13 on the x-axis, and these are the myeloid cells. So these blue cells are the blasts, myeloblasts. They mature slowly, promyelocytes. They become myelocytes, they lose 13 and 16. They become metamyelocytes, they gain 16, and they become neutrophils, this green color. They gain both 13 and 16. So here on the 45, this is the neutrophils, the green color, which is positive for 13 and 16. So myeloblasts, promyelocytes, metamyelocytes, and neutrophils. So these are the maturation patterns. So this is again beautifully drawn by the flow cytometry. Obviously flow can give you the large number of cells you can study, faster, MRD, blah, blah. But two major advantages, as I said, patterns, and second is multicolor. IHC, obviously, you have microscopy, you have architecture, you have morphology, you have microscopy. So here there is no morphology here. Here you compare. Yeah.
You also know where on a slide that the antigen actually is, which you can't tell.
Here in flow you can tell. Yeah.
Which of the cells is actually doing it?
So the question is, Anita asks that on IHC you can say this is cytoplasmic or a nuclear stain or a membrane stain, but you can't say on the... Huh? Oh, that way, yeah. Yeah, that's true. So you can't say that. That's why I said architecture. You in the biopsy you see the architecture, you see the follicles, you see the nodules, you see the RS cells. You can't see that. And obviously where the IHC is going there. Is in the germinal center, nodules or outside the nodules. Yes. We could pick up a flow. I don't want to debate, but experts pick up. Experts pick up. I am not an expert. I said that. So let's not fight over this. They are complementary. We're friends. We have to go out for dinner. We have, it is complementary. Pathology is complementary. Even you don't talk to your colleagues, you take their opinion. So we are complementary to each other. Flow, molecular, cytogenetics, all techniques are required. You can't say one is better than other. Sometimes we say FNAC is not required, but FNAC has its role somewhere it has its role. So all technologies have their role. But we have to know our limitations. Flow has its limitations? Yes, surely it has. Okay, so we do both in our practice, because we do mostly lymph node biopsies and IHCs, but when we have a tricky situation, we put a needle and do flow, and we get more information, we get a little more confidence and more teeth to give a diagnosis. We should know that peripheral blood, we know that peripheral blood has 20 to 40% lymphocytes. Your blood or my blood will have 20%, 30% lymphocytes. And out of these 30% lymphocytes, 70% are T cells. So most of your lymphocytes are T cells. 10% or 15% are B cells, 5 to 10% are NK cells. Plasma cells you rarely get in peripheral blood. So mostly T cells. So you have to be careful when you see flow, most cells will be T cells. It doesn't become T cell lymphoma. It is normal. So that normal histology, normal anatomy, normal cells you have to know. So the best marker for B cells is 19, for T cells is CD3. Specific, 3 specific. Sensitive is 7. 7 is a better marker actually for T cells, but it is not specific. So in our practice, when I have to do 2 T cell markers, I do CD3 and 7. If I have to do 2 B cell markers, I do 20 and PAX5, or 20 and 17 and alpha, or 20 and 19. But 2 T cell markers, 3 and 7. We know that common lymphomas, B cells are B cells. 85, 90% lymphomas in the peripheral blood we see. CLPDs, we call it chronic lymphoproliferative disorders, which are low-grade lymphomas, are mostly B cell type. T cell chronic lymphoproliferative disorders are rare. Now, which is the commonest mature B cell lymphomas which come to the bone marrow? It is hepatosplenic gamma delta T cell lymphomas, which comes as lymphomas in the peripheral blood. I'm talking about in the peripheral blood. The commonest mature T cell lymphomas is hepatosplenic gamma delta T cell lymphomas. The rest, Sézary syndrome is rare, TPLL is rare, ATLL is rare. They are there, but you see rare. Very, very few cases, 2-3 cases in a year. Gamma delta T cell lymphoma we see more. And 90% of the lymphomas in peripheral blood are B cell, out of which 70% are CLL. The commonest is CLL, 70%. Then marginal, follicular, SLL, hairy cell, they are all 5%, 5% types. And in the end, 5% would be T cells. And amongst the T cells, the commonest is gamma delta T cell lymphomas, which looks like ALL. On morphology, it can look like acute lymphoblastic leukemia. So there are 4 lymphomas. On morphology, it's difficult. So you either do flow or you do IHCs to subtype. We have 2 types of panels. If you're doing flow for lymphomas, you have 2 types of panels. One is screening panel, second is diagnostic panels. So screening panel means a sample comes to the lab with a history of lymphoma. So your technician can run the sample straight. Put a lymphoma panel. Let's say you have 10 color, one lymphoma tube. You have a 15 color lymphoma tube. So you have 15 markers in that tube. There could be T marker, B marker, NK, plasma, one CD34 also, blastic marker. And you put your sample into this, and the technician has already run the sample. You come in the morning and you can get an idea whether this is a normal sample or abnormal. If it is abnormal, T cells are abnormal, or B cells, or NK cells, or plasma cells. If plasma cells are abnormal, then you do a directed plasma cell tube. Next tube would be only plasma. You don't have to do T, B, NK markers then. So first you do screening tube, then you do the diagnostic tube. But this is done in very few labs. Not many labs do it. Most labs do diagnostic panels, which are 3 tubes, T, B, mainly 2 tubes. So diagnostic panel tube, directed tubes. So this is our screening tube, which is 15 antibodies. This is 13 color, 18 antibodies now, the screening tube. So you can see there's 16, 14, 5, 4, surface CD3, 8, 7, 34, 19, 10, 305, 45, 38. I'll just show you of a normal lymph node FNC. If you do put a needle in a lymph node and if you do flow, what will you see? So let's see, this is CD45, which is LCA, this is side scatter. Side scatter tells you granularity in a lymph node Forward scatter tells you size. So here I'm not showing you size, here granularity and 45. So these are your areas of neutrophils. And this is area of cells which have less granules, but they are 45 strong. These are all lymphocytes. Lymph node, mostly you'll get lymphocytes, you won't get neutrophils there anyways. So 99% cells are lymphocytes. Next you, CD3 and 19. These are your T cells and these are your B cells. So red color is B cells, purple I've given purple to T cells. So let's see the red color. The B cells are kappa lambda. They are polyclonal. Half of them kappa, 55%, 43% are lambda. And when I do CD5, there are some B cells expressing CD5. We always have a small population of B cells, normally in our blood, even in lymph nodes, expressing CD5. Then you could do T cells and you look at CD4 and CD8. You have ratio 2:1 generally, CD4 positive T cells and CD8 positive T cells. So this is a normal lymph node, FNA flow. So now you have a lymphoma case. Similarly, you could, if you do multicolor as a short screening tube, you can separate gamma delta T cells, monocytes, B cells, playing different permutations and combinations. Now my next slides are how to detect the abnormal B cells and abnormal T cells on flow. For B cells, obviously, if the B cells are expressing CD5, they're abnormal, beyond a normal range. But the best use of flow is to detect clonality. It's easiest to do clonality by flow for B cells. On IHCs, it's difficult to do. You can do for plasma cells. For otherwise B cell lymphomas, it's very difficult, or unless you do, like Jai showed you a picture of, in situ hybridization. On IHC, it's difficult to get the results of clonality for B cells. Plasma cells have a lot of globulins, secretion, so you can get light chains, but not for the B cell lymphomas, like follicular hyperplasia, follicular lymphoma. You can't do clonality by IHC. It doesn't work that well. But flow is very good. So here flow will show you clonality. Let's see, these are the B cells, 19 positive. You can do clonality, kappa lambda, they are polyclonal. This is another population, 19 positive B cells. You do kappa lambda, they are all lambda. So this is clonal. So you could make out this is clonal B cells, these are polyclonal B cells, these are clonal B cells. So this is possibly dealing with the tumor. Similarly, how to detect abnormal T cells? Let's say CD3, and this is CD3 and this is CD4 here. These are the normal T cells. Now these cells are CD3 negative, but CD4 positive. They could be monocytes, but I have excluded monocytes. So these are abnormal T cells, CD4 positive, surface CD3 negative. Cytoplasmic CD3 was positive. This was case of AITL. Another way to show you CD3 here, CD5 here. Another population 5 positive, 3 negative, abnormal. And the same population is 5 positive, red color, 4 positive. This is again population of AITL. Another normal T cell subsets. This is 4 positive, 8 positive, double negative are very few, double positive are very few. Double negative T cells are, which are the double negative T cells? They are the normal gamma delta T cells. In your and my blood, 95 to 97% T cells are alpha beta. 2 to 3% cells are gamma delta, and those gamma delta cells are double negative. The alpha beta cells are either CD4 or they are CD8. That's why the role of ALPS. In the ALPS, autoimmune lymphoproliferation syndromes, the alpha beta cells become double negative. You understand? We'll show you a case. So here, this is abnormal T cells. These red dots, you see so many double positive, 4 positive, 8 positive. And this is another case, double negative. Now this is a case of ALPS. I'll show you later. Double negative T cells. These were TDT negative, and they were 5 negative. They had other features consistent with ALPS. But this is a case of ALL, double positive. It was acute lymphoblastic leukemia. You could do T cell clonality by flow, which is the fastest and cheapest. You can do by doing only one. We used to do V beta repertoire by doing 24 antibodies. Now we do only one, TRBC1. So this is an excellent antibody to do the clonality for T cells. I told you gamma delta T cells, they are very few, they are double negative, they are very bright CD3 positive T cells. Then we have granular cells, but they are in the peripheral blood mostly, so I will not spend time here. But one has to be careful. Loss of one marker does not become lymphoma. Double positive T cells do not become lymphoma if they are a small percentage. Double negative, double positive, loss of one marker. So in context, every is a soft pointer towards your diagnosis, but it doesn't become a lymphoma just because that one marker is lost. I think I skipped this. There are CD4 positive lymphomas, there are CD8 positive lymphomas, there are double positive lymphomas. I'm not going into details of this. This is well described. Panels, similarly for B-cell lymphomas, I will skip this algorithms. We have been reading this for many years. We know that first we do CD19, then we do CD5. If 5 is positive, we have CLL mantle. If 5 is negative, we go ahead with 10, then look for follicular lymphomas. If 10 is negative, then we look for marginal zone lymphomas, hairy cell leukemias. 10 positive could be Burkitt's also. So these are the algorithms given all over. If anybody wants, I will be happy to share, but these are commonly known. I'll skip this. I'll show you quickly some cases now. A 55 male came with low-grade fever, cervical nodes, axillary nodes, liver is big, spleen is big, normal CBC. Bone marrow revealed 25% these large cells. So they may be blast, they do not look like mature, they look abnormal, either blast, but they're too large. So we're not sure, but patient has generalized nodes, cervical, axillary, and large nodes. So looks like lymphoma in the bone marrow infiltration. So you do the flow. In the flow, side scatter, forward scatter, the blue color is our cells of interest. They have a slightly higher forward scatter than the normal lymphocytes, and the size is also large. And 45 is strongly positive. So if I look at the 19 and 20, this is 19, 20, all these my large B cells express 19 and 20 both. They have high forward scatter, high side scatter, 45 strong, so they are not B blast. 45 generally is lost in blast. They are strong, so possibly we are dealing with a mature B cell lymphoma, and 20 is also strong. Generally 20 is negative in B cell ALLs. So 45 strong, 20 strong, possibly large B cell lymphoma. Size is large. We did other markers, 38 is positive, kappa light chain restriction. You see this kappa and lambda? So in ALLs, you do not see the light chain restrictions. It doesn't, both are negative because they don't produce the light chains. But in lymphomas like DLBCL, Burkitt's, or any other lymphomas, you can do this light chain restriction very well. So this tells you again, we are dealing with a mature B-cell lymphoma, which is large size. Other stains were done, 200 is positive, 25 was positive. BCL2 is positive. BCL6, very weak. But IgM positive, BCL2 positive. MIB1 was 26%. So now flow, 26% means almost 70-80%. For Burkitt's, when we do the flow, 30 to 40% is almost like 100% what we see in the biopsy. So Burkitt's in our experience and also in the literature, around 40% of MIB1 by flow is equivalent to 100% on IHCs. So this case was a case of diffuse large B-cell lymphoma. I go to next case. 18-year-old young boy, headache, dizziness, blurring of vision, CBC, peripheral smear shows 50% blasts. 18-year-old boy, peripheral smear shows 50% blasts. These are the blasts, some vacuoles, not like Burkitt's, but some vacuoles are there. Maybe Burkitt's, may not be, we do not know, but looks like a high-grade hematolymphoid neoplasm, possibly acute leukemia. We did the markers. Look at the CD45, very strong. Now, if you have CD45 strong, you start doubting it's acute leukemia. Sometimes it can be 45 strong, but mostly CD45 is weak or it is lost. Then we do other markers, 20. Now, 20 is also pretty moderately strong positive. These are normal B cells, these are tumor cells. Slightly weaker than normal, but positive. So 20 positive, 45 strong tells you possibly these are not acute leukemia. This is again a mature B-cell lymphoma. And they were vacuoles, so possibly are we dealing with Burkitt's? But we can't be sure. Then we did more markers, 19 positive. Lambda light chain restriction. See, all cells are lambda. So this is definitely this is a high-grade B-cell lymphoma. Then there are markers like 180 for marginal zone negative, 148 for mental cell, it was positive here weekly. MIB1 was 50%. Now this is very high. BCL2 is negative. This red color is BCL2 in the tumor cells. These are the normal B cells, BCL2 and 19 positive. The tumor cells are 19 positive, BCL2 negative. So another marker is 81. CD81 is very good marker for Burkitt's by flow, and 44 classically comes negative, which comes positive in diffuse large B-cell lymphomas. So putting these finer points together, we gave a diagnosis of Burkitt consistent with Burkitt's lymphoma. It was confirmed on the biopsy. Obviously, you take help of the biopsy here. The flow is not the diagnostic in Burkitt's, is the mostly a biopsy diagnosis. Case 3, 40-year-old male came to us with pancytopenia and splenomegaly. What's your diagnosis? Postgraduates? Hairy cell leukemia. You should think of hairy cell leukemia. Okay, then we did bone marrow. Pancytopenia, you do bone marrow. 27% lymphocytes and 12% plasma cells. Your diagnosis? It was hairy cell leukemia. Now what's your diagnosis? It still could be hairy cell leukemia. It could be Waldenstrom's, you know, because you have lymphocytes, you have plasma cells. You start thinking, why so many plasma cells? So let's study the case. So we did the flow. The red cells are the B cells, 1920 positive. You see this beautiful? Their B cells are 37% by flow, 45 strong. They are all 20 positive, 10 negative, 5 negative, and show kappa light chain restriction. So we have a B cell lymphoma. And 11C and 25, beautifully positive, very classical for hairy cell leukemia. 11C and 25. Then after that we did multiple markers. 103, 305, 200, 123, all are very classical markers for hairy cell leukemia, and luckily, thankfully, all markers are positive. But as Jai told you in the morning, maybe Pravin, that BRAF mutations you have to do. In this case, I don't remember if we did, but this was hairy cell leukemia based on morphology, history, and flow. So diagnosis is hairy cell leukemia. What next? Shall I go to next case? Plasma cells. So plasma cell ko bhi kuch karna padega. There are 10-15% plasma cells. What are they doing in the bone marrow? Because your or my bone marrow should not have more than 1 or 2% plasma cells. 15% plasma is too much. So what do you do for plasma cells? As Dr. Jai told you, 138, MUM1 and 38. These are good markers for plasma cells. So based on 38 and 138, you select your plasma cells. They are all kappa. Those were lambda, these are kappa now. So plasma cells are also clonal now. So we have a clonal plasma cell population. So we have a plasma cell neoplasm along with hairy cell leukemia. So now what plasma cell neoplasm? Patient didn't have complaints of lytic lesions, didn't have CRAB defined as for myeloma. Didn't have myeloma features, but the M band was around 3 grams. So this became a smoldering myeloma. So MYD88 was negative, Waldenstrom's, BRAF mutations were positive. We did actually in this case. So our patient had 40-year-old male, M band was 3.2. Because it was more than 3, it becomes smoldering myeloma. If it was less than 3, it becomes MGUS. So we finally called it hairy cell leukemia with smoldering myeloma. Now we pick up many MGUS on flow. Many cases who come for other things, for staging of Hodgkin's, you pick up MGUS. Now this is a very classical pattern of Waldenstrom's, CD38 and 120. Like these are the B cells differentiating to become plasma cells. This kind of pattern comes. I think I'll skip this. Just to give you an example, for each marker, do not think that CD38 comes only in plasma cells. Now CD38 comes in all cells. So you have to know, like CD45 can come in all cells, is a LCA. Similarly, CD43 can come in all cells. So for each marker, you have to read where all it can come in normal cells. So if you see here, CD38 is a beautiful marker for myeloma, for lymphoma screening, and MRD for BLL. And is also expressed in thymocytes, activity T cells, hematogones, monocyte, dendritic cells, plasma cells. Where not. and there is obviously targeted therapy. Next case, 60-year-old male. How much time I have left? 5 minutes? I'll finish just next 5 minutes. 60-year-old male with chronic dermatitis, generalized lymph node. Generalized lymph nodes this age has to be lymphoma. Patient had pericardial effusion. Now this is the pericardial fluid, we did the flow. And if you look at the flow, 45 is strong in all cells. I don't have morphology. But if you look at CD7, the 7 had, this is strong, weak and negative for 7. So 7 had a very heterogeneous spread. CD3 is homogeneous. All cells express 3 strongly, but 7 is strong, moderate and weak. So this tells you 7 is abnormally, some cells are strong, some are moderate, some are lost for 7. So this is 7. So this is abnormal population. This may be normal. So we did multiple markers just to show you here CD4 and 8. Look at this color. This is green color if it is green. 4 is more and 8 is good. Ratio is maintained here. Now this blue or purple, 4 is much more. This is abnormal. And this brown color, all cells are brown or all are 4, no 8. So this is all CD4 positive. This is almost all 4 positive. This is normal, 4 and 8. So we are dealing with a T cell population which is showing loss of 7, which are all CD4 positive, 8 negative. Then you do other markers like CD10. Same with 10. They are all 10 positive. They are all BCS6 positive. They were again AITL, case of angioimmunoblastic T cell lymphoma. I will skip this case. I go to my last case, 2 cases, but quickly I'll take a minute only. A young girl came with high fever, hepatosplenomegaly, bad cytopenia, bicytopenia. Peripheral smear shows blast. Bone marrow came to us. I reported it normal, but aspirate was showing blast. So I reviewed the bone marrow. The bone marrow flow shows 45 strong and CD3 positive. Can't be ALL. 45 strong and surface CD3 positive. In ALLs, surface CD3 is negative, cytoplasmic CD3 is positive. So this is a mature T cell lymphoma. So it was all gamma delta. So we are dealing with gamma delta T cell lymphoma, and they were all double negative, 4-8 negative. I reviewed the bone marrow biopsy, which I had shown you in the morning, this intrasinusoidal spread. So this is a classical picture of hepatosplenic gamma delta T cell lymphomas. You can miss if you do not do CD3. So if you have a case of pancytopenia in your practice and bone marrow looks normal, it's a good idea to do 3 and 20 to pick up these intrasinusoidal spreads which you might miss. I've shown it to one of my colleagues. Neeraj is not here. Neeraj came to Tata Hospital, and then when I went to Calcutta to visit him, he showed me a case. He said, tell me diagnosis. I missed it again. I had shown him how to pick up sinusoidal cells. So you miss these cells, you have to be careful. So history, please do 3 and 20. If patient has a pancytopenia, you're not coming to any conclusion, you will pick up these intrasinusoidal fine spreads. In the liver biopsy, it's easy, but in the bone marrow, it can be tricky. Yeah, I think these are the pictures of T cell lymphomas, hepatosplenic, many cases. My last case, young, actually kid, infant, came to us with a high white cell count, 1 lakh, almost 1 lakh count of TLC, and peripheral smear shows 95% lymphocytosis. So we thought ALL came from Vadia, and lymph node also came. Now lymph node shows both follicular as well as paracortical T zones, expanded T zones with cells look very bad, angry looking, mitotically active, not much apoptosis though, but angry looking, little pleomorphic lymphoid cells, small to large, some plasma cells, but TDT negative. They're all 3 positive. All cells are 3 positive, 20 negative, double negative. So this is a case of ALPS. I will not spend time here. So we pick up now more ALPS on the lymph nodes, but flow is again very helpful here. These are the alpha beta positive cells which are double negative. So one has to be careful about these entities which may mimic lymphoblastic lymphoma, autoimmune lymphoproliferation syndromes, but they are TDT negative. Jai showed you TDT can be positive in many cells, but I just want to add that TDT negative do not diagnose ALL. TDT has to be positive in ALL. So there is literature says 99% cells cases are positive. So 1% I do not know what the case is. But to call anything as ALL, TDT has to be positive. If TDT is negative, do not call it ALL. Though TDT can come in many benign things, like neuroendocrine tumors and Merkel cell carcinomas and others, hematogones also. Yeah, this is again another case of ALPS. I think I'll stop. Thank you.
Thank you so much, Sumeet sir, for an informative session. So, as we approach towards the end of our academic sessions, I would like to invite Dr. Anita ma'am, who's going to share her expertise on accessory cell proliferation. So, everyone please put a huge round of applause for Dr. Anita ma'am.
Well, all good things have to come to an end. This is the last talk of the whole day. I have to appreciate the patience of the young people, particularly those at the back who have sat through all of this very complicated stuff. I don't know how much of it you actually understand and how much of it you're actually going to practice. But if you've got some concepts, I think our job is done. I'm going to give a talk on accessory cell lesions. I'll tell you what an accessory cell is. But before that, I really want to thank the organizers of this meeting for giving me the opportunity to come once again to Ahmedabad and meet a number of my friends over here. But more than that, to give me the liberty to assemble a team that I thought would really do a very good job. And I think that you have been benefited by listening to Sumeet and Pravin and Jay. I'm sure that you have, and it is really my great pleasure to have them all over here with me in Ahmedabad. So thank you all three of you, for having made my job very much easier. So I'm going to talk about accessory cell proliferations. You just have to switch off your brains, okay? Because this is just going to be a long and I hope pleasurable look at some of these cases that you are hardly ever likely to come across. Some of them, yes, you will see in your daily practice, or some of the students will see it in their institutes, but the majority of them you probably will not see. And that's why I've called it curiosa et meaning and exotica. So it is a kind of exotic thing. So let's start. What are accessory cells? Anybody, you knew that you were coming to this meeting, and you saw this accessory cell lesion. So anybody at the back over there would like to tell me what is an accessory cell? I've put it up here, right? You can see it. Yeah, so what did you think were accessory cells? Did any of you even imagine that, what is an accessory cell? But here it is. All right, they are cells that assist in an adaptive immune response. And you know that we have two kinds of immune response. I'm sure all of you are studying, at least reading a little bit of immunology, because you might be asked in the exam, how much of it do you remember afterwards? I don't know, but we have two kinds of immunity. We have an innate immunity and we have an adaptive immunity, okay? And you've been hearing about NK cells, yeah? And these are cells that, as somebody said when they were speaking, is that, when there isn't a time for a response to happen, the body has to respond immediately. And these are cells that are involved in innate immunity. Those are not accessory cells. But there are cells that are involved in innate immunity, and those are histiocytes, okay? So histiocytes also respond during an innate immune response. But by and large, accessory cells are those that help the usual adaptive immune cells that work in an immune response, that is the T cells and B cells, to actually do their jobs, okay? They are not lymphocytes, as I said, or NK cells. Histiocytes and dendritic cells are, what we consider to be accessory cells. And like we know, many of these dendritic cells are antigen-presenting cells, all right? Now, this is a nice, let me see if I can get my pointer, okay? Is that pointer? No, sorry. Pointer options. And let's do laser, okay. Does the laser come up? Yes. All right. This is a nice diagram that was taken from the previous WHO. I'm not very certain. Sumeet, do you know whether this is in the new WHO? But it was a nice diagram anyway. So I've put it over here. And it's not exactly as it was over there. I have actually modified it, but I've modified it for you to understand. Now you see all these, I don't know whether people at the back can even read this, what are all the different markers that are seen at each step of development, but these are not markers that we use in histopathology. This is what Sumeet was talking about when they do a lot of flow cytometry, but they do define different stages of differentiation. But you see a line over here, and that line from top to bottom, as you see over here, yes, divides these accessory cells into two groups. And one is the group that has its origin in a myeloid stem cell, and the other one has got nothing to do with the hematolymphoid system at all. This is a mesenchymal stem cell. Of course, everything goes back to the zygote, like I suppose we all go back to Adam and Eve, but there is some sort of division. And there are two really kinds of these dendritic cells and histiocytes. One lot that owes its lineage to the myeloid stem cell, and the other one to the mesenchymal stem cell. And they are different, they look different, they have a different kind of function in this adaptive immunity. Now, if you look at the next level of cells over there, you will see that one side goes down and becomes a histiocyte. A monocyte, a histiocyte is that different lineage, okay? The other ones are those that ultimately end up being Langerhans cells and their kind of progeny, and the different variant of them, which is known as plasmacytoid dendritic cells, okay? And this Langerhans cell type, which is CD1A positive, which, as we all know, is S100 protein positive, then divides up into one that remains, they call Weil cells or Langerhans cells in sort of everyday parlance. But there is another group which are known as interdigitating reticulum cells, and they are related to one another because of what kind of markers they actually express. And what is that marker? We'll talk about it when we have a little chart of what they express. Okay, so when you're talking about what kind of tumors or proliferations you see in these accessory cells, there you will see. If the monocyte, which is an immature thing, it's an AML, no? So it's the various AMLs that have a monocytic differentiation. When you come down all the way to histiocytes, you see some things over there. ECD is Erdheim-Chester disease, then there is the Rosai-Dorfman disease, then you have juvenile xanthogranuloma, that is what JXG is, and malignant histiocytosis. Okay, that's what you get from the histiocyte arm. Here you get the Langerhans cell histiocytosis. Here you have the interdigitating cell tumor, which we will talk about. At this level, you know, there are two related cells, and you can see their dendrites, and they seem to have some, you know, sort of commonality, and sometimes they express this, and sometimes they express that, and that is known as an indeterminate cell, which can give rise to an indeterminate type of tumor. And this one, you know, when you get an immature tumor of the plasmacytoid dendritic cells, Dr. Sumeet showed you a very nice case of blastic plasmacytoid dendritic cell neoplasm, which is a very, very vicious, high-grade neoplasm. Now, what happens on the mesenchymal cell? Now, I just want you to look at this cell, okay, here at the bottom, the straight arrow. And you see, it is the most dendritic of all cells. And that's why it's drawn like that. It's got these hairy, long, hairy-like processes, and that is the follicular dendritic cell. And that follicular dendritic cell is called a follicular dendritic cell because get up, awake. Why? Because it is present in the follicle. Then the only thing that forms a follicle is a B cell follicle in a lymph node, okay? So that's where you see this. Whereas these two, one the interdigitating cell and the Langerhans cell is usually associated with antigen presentation, that's the interdigitating reticulum cell in the T cell area. And there is something that is called a fibroblastic reticulum cell or fibroblastic dendritic cell, which funnily enough can also express cytokeratin, okay? Now, that was in WHO 2017, and we had this diagram, and you had dendritic cells and histiocytic neoplasms, and you had this thing which says that there was a myeloid stem cell and there was a mesenchymal stem cell. In the new WHO 2003, you have two different things. These are not placed under one heading. What is there in this? Histiocytes and dendritic cell neoplasms now are myeloid, and that's what they are called, okay? So the myeloid stem cell ones are called histiocytes and dendritic cell neoplasms. The one that are now derived from mesenchymal stem cells are known as stromal derived neoplasms of lymphoid tissue. You don't have to look at what's there on the right hand side. We'll just go to what the WHO says as far as the stromal neoplasms of lymphoid tissue. And you see, yes, it does have follicular dendritic cell and fibroblastic dendritic cell or reticulum cell tumors, but it now has something which we used to normally deal with in the soft tissue tumor books, and that is an intranodal myofibroblastoma. Now that has come into the WHO hematolymphoid book, and so many of these vascular stromal tumors that are present in the spleen. So you can read that. There's the littoral cell angioma, there's the splenic hamartoma, and sclerosing angiomatoid nodular transformation of the spleen. Okay, they were ambiguous. They didn't find a place almost anywhere, but now they are firmly in the hematolymphoid neoplasms under stromal neoplasms of lymphoid tissue. Something similar is also there in this, that there is a competing, there are two competing classifications now. One is the WHO, the other is the International Consensus Classification. And if you look at their classification, it's more or less the same, except that they haven't done this myeloid and stromal neoplasms of lymphoid tissue. But I just want to say one word about this society. It's a very old society, and it's called the Histiocytic Society, okay? And it deals with what the WHO is now calling just the histiocytic and dendritic cell neoplasms of myeloid lineage. The Histiocyte Society does not talk about follicular dendritic cells or follicular reticular cells. For years, they have been they have what they say, plowing their own furrow, and I think they have made the WHO reconsider what are these histiocytic and dendritic cell neoplasms. They force them to have a separate category, and of course they're not following what the Histiocytic and Dendritic Cell the Histiocyte Society does. But just in brief, the Histiocyte Society has the L group, which is the Langerhans group. And if you look at what's there in the Langerhans group, you'll be very surprised to see that it's not just the Langerhans cells, it's also Erdheim-Chester disease. And you think, hey, Erdheim-Chester disease is a disease of histiocytes which don't share anything with the Langerhans cells, which are CD1A positive and S100 protein positive and Langerin positive. Then why is it in that? Well, the reason that the Histiocyte Society has done that, and I'm just explaining this to you because somewhere or the other you might come across this and think this is nutty that they have done this and they must be bonkers, but no. You often get in the same patient Langerhans cell disease, that is Langerhans cell histiocytosis, and Erdheim-Chester disease. But apart from that, both of them show BRAF V600E mutations. Okay, and it's they feel that the stem cell that is giving rise to this, obviously they are all myeloid stem cells. There's something happening to the myeloid stem cell right in the beginning. Apart from that, there is the C group, which is the cutaneous histiocytic group, which is mainly that juvenile xanthogranuloma. There is the R group, which is Rosai-Dorfman disease. There is the M group, and the M group is all malignant histiocytoses. It doesn't matter whether it's a malignant Langerhans cell histiocytosis or just a histiocytic malignancy in general. It gets into that M group. And finally, there's an H group which doesn't exist in the classification in the WHO, and that is called the H group, which is HLH. Yes, HLH does appear in the WHO, but not under the myeloid, dendritic, and histiocytic neoplasms. All right, so now here we come to what we do in immunohistochemistry. I'm not talking about the differentiation markers that you see on flow. Okay, and here you will notice that these are, Langerhans cell, interdigitating reticulum cell. This is the follicular dendritic cell. You have the macrophage or histiocyte, and then you have this fibroblastic reticulum cell or fibroblastic dendritic cell, which also can be cytokeratin positive. So the C in the first thing stands for cytokeratin. Okay, and we do a certain number of common markers. This is, I think, an interesting way of investigating these tumors. Okay, so you do CD1A, S100 protein, Langerin, CD68, 163, 21, 23, 35. You don't have to do them all, but you do. There is also podoplanin, which has not been mentioned over here, which is D240. There is CK and SMA, and then there is CD4 and CD31. Now, Langerhans cells express CD1A, S100 protein, and Langerin. The interdigitating dendritic cell, notice that it neither, although it is very closely related, in fact, it splits from its precursor between the Langerhans cell and the precursor of this cell. It only expresses S100 protein. It doesn't express the CD1A or the Langerin. And so then you can understand if you haven't got CD1A or you have not put up Langerin, you just have S100 protein, perhaps you may, if you don't know the clinical context, miss what we call an interdigitating cell tumor. The histiocytes, you notice, will express CD68 and 163. All right, and here you have the follicular dendritic cells express this. They express 21 or 23 or 35 or all of them. May also express facin, clusterin, as well as podoplanin, which is D240. And you know that D240 is, where else is it expressed? What do we use D240 for on a regular basis? Yes? In the lymphatics, very good. What else do we use it for? In any other tumor? Yeah, to look for lymphatics, yes. A seminoma, no? We use D240 to look at seminomas. And all of this tells you one thing, all right? that you can't do one marker and say that this is this or this is that. You have to use a judicious panel of markers, and you also have to correlate it with what you are seeing and also the clinical picture. Immunohistochemistry is not like magic. Nothing is like magic, not even a molecular marker, which you think is so specific, okay? When push comes to shove, that so specific thing just, lets you down. All right, but what I think is important is, of course, you see CK and SMA may be present in the follicular reticulum cell, because after all, it's a mesenchymal cell. But just note there and keep it in mind. What do you think CD4 is? And you've been saying lots of CD4, CD4, CD4. What have you been seeing CD4 as? What? It is a T cell marker, right? So peripheral T cells can be 4, or they can be 8, or double negative, double positive, all this you've been hearing. But let me tell you that CD4 is regularly expressed in histiocytes. Okay, so don't believe that because you've got CD4, that is a T cell. No, it could even be a myeloid cell, right? Just like CD7. And as Sumeet told you, he loves CD7, because CD7, you love it, right? Sumeet, he's shaking his head, yes. I don't know how many times I've heard Sumeet say that he's in love with CD7. He said it in front of his wife, so it's all right. He's in love with CD7 because it's such a wonderful marker of a myeloid lineage. Okay, so it can be of myeloid lineage, but this is 4 I'm talking about. And notice that CD31, what is CD31 otherwise used for? Vascular marker. It is also expressed in histiocytes. So we have to be a little cute about that. Okay, so now you can just, all the serious stuff is over, just lean back and look at cases. All right, here's a case. This is a 48-year-old male who presented with a cutaneous swelling on the left thigh, and we had a wide excision of the thigh lesion, and the skin showed this nodular growth, which was 5 centimeters, a pretty big growth on the skin. In India, nothing surprises me, and particularly if it is from Calcutta. They are the most long-suffering people in West Bengal. Ask Jay. The biggest lesion on the skull, the biggest lesion on the thigh. And you wonder, how have they been carrying this bulk around for all this time? But then you have to be, are there any Bengalis in the audience? If you are, I beg your pardon, but you do carry your burdens for a very long time before you do something about it. And then you sue your doctor. That's very, very typical, okay? All right, now here we are. Sorry? Mycosis fungoides. Who said mycosis fungoides? There's somebody who put a hand up. You do know that I'm talking about accessory cells, right? Now, so I just want to know, why you said mycosis, and it is, no, it's not hypoglycemia, it's something in the slide. So what is it that made you think of mycosis? Come on. You said something that is very, very observant. So, there it is. She said that this shows epidermotropism, and indeed it does. So she gets full marks for observation, but gets not so many marks for interpretation. Okay, so there is observation and then interpretation of I hope you don't mind me saying that. I don't mean anything that is bad. Yes, there is epidermotropism. Okay, you don't see what is that zone between the epidermis and a tumor, that Grenz zone. There is no Grenz zone over here, okay? It's flush with the epidermis and is actually showing you infiltration of this epidermis, all right? And you have these very, they are very atypical cells. I don't think that they look like, normal lymphocytic infiltration of the skin, although it's very hard, I'm telling you, tell the difference between a cutaneous lymphoma and just a reaction, you know, maybe just a photosensitivity reaction or whatever. And here, you see the bottom edge of this tumor where the tumor is actually advancing into adipose tissue. Now, I don't think that you would call this mycosis fungoides. Yes, there is a spindling over here. You can see mitoses. You can also see very abnormal forms. Look at that, okay? And you can see, you know, what does that even look like? And you've been seeing very many of them during the day. It was mentioned by Sumeet, it was mentioned by Pravin. Hallmark cells, yes, the embryoid or hallmark cells are there. So now somebody's seen that and will think, what? Cutaneous ALCL. See, again, you're making an observation and you have come to some peculiar interpretation. Okay, so we can't just see hallmark cells and say, aha, this is a cutaneous ALCL. There is nothing aha in medicine, all right? Look. And now look at it carefully. What do these cells look like? Grooving, wonderful. See this. You can see there is a nice big groove. Somebody said that there is a mitosis. Who said there is a mitosis? Put up your hand. Okay, there's somebody here. Oh, there, the lady in the black sweater. You said there's a mitosis, right? I say it's not a mitosis. Can you tell me why I'm differing with you? Why? Huh? You thought that this was a, you know, mitotic figure like a caterpillar across the cell, right? What is the first thing that happens when a cell goes into mitosis? The first thing that happens before the cell starts to actually, you know, form all the figures that you see, mitotic figures. What? Dissolution of the nuclear membrane. Can you see the nucleus membrane? Oh, there it is, of course. Can you not see the nuclear membrane just where my arrow is? So that's not a cell, that's the nucleus. And therefore, this is a groove in the nucleus, all right? So somebody who said there were groove nuclei, yes. And just look what is that? It's coffee bean. That is what a coffee bean nucleus is, okay? And then you're seeing other things. You see this, which you saw before. It looks like an embryo. Very good. So that's an embryo. So you've got some hallmark cells, you've got coffee bean cells, and look at all the rest of them. They're all grooved, or they have what somebody might say, you know, cerebriform, or maybe even you might want to say walnut shapes and all. So, but whatever it is, these nuclei are highly, highly irregular. Yeah? Now, I don't think that this is an ALCL, this is not a cerebriform, so therefore Caesarea, therefore, you know, mycosis, all this thing is going on, and there is epidermotropism, etc. Okay? Here you see this is obviously malignant, it's full of necrotic, it's full of necrosis. There is a lot of necrosis over here, you can see this, you see the number of mitoses, etc. So now what is this? All right, obviously it's a malignant tumor. It's very unlikely to be of epithelial lineage. Could it be, it's not melanocytic, although, you know, you see something close to the, you know, to the basement membrane of the overlying epidermis. Could it be myeloid? When it's such irregular nuclei, and particularly if I'm talking about accessory cells, then, you know, histiocytic dendritic cells, or as somebody thought, maybe it's an ALCL, but the rest of it is very unlikely. All right, so we have to do, we had to do immunohistochemistry. You see the whole lot of things. It's not a melanoma, it's not of myeloid lineage, or in that sense of the word. Okay, so what is this? This is S100 protein, and it is very, very strongly expressing S100 protein, and it is expressing CD1A. And if you're doing CD1A, that's how CD1A should come out. It's a membrane stain. It is not one of these wishy-washy things that is all cytoplasmic here and there. You want to say CD1A is positive, that's how it should be in histology, okay? So now, what do you think? It's Langerhans, these are Langerhans cells, but it's a malignant tumor, right? So, this is, Langerin was not done, but I think this one is MIB1, and you can see the huge proliferation fraction in this tumor. We didn't have Langerin at that time. Now, of course, we have Langerin, and we can do it on immunohistochemistry. The diagnosis in this case is a Langerhans cell sarcoma, okay? Now, in the WHO 2023, it's called a Langerhans cell sarcoma. So also in the international consensus classification, but in group M of the histiocytes, it would have been called a malignant histiocytosis. And you can see all this. It's a rare disease, and it's very aggressive. Okay, now I just want the youngsters at the back. A firm diagnosis of LCH, whether it's benign or malignant, rests on what? Number 1, number 2, number 3, or number 4? Come on, shout. Number 1 is expression of S100 protein alone, expression of CD1A alone, expression of CD23 and 21, or expression of Langerin on immunohistochemistry or Burbeck granules on EM. So which one? 1, 2, 3, or 4? 4, very good. Yes, that's the racket-shaped granule that you see on electron microscopy, and this is why you cannot rely on any of the others. S100 protein is present in so many other histiocytic and dendritic as well as melanocytic lesions. CD1A is regularly expressed in lymphoblastic lymphoma of T cell type. S100 protein and CD1A are in our everyday practice, if you may not have Langerin, are acceptable in a given clinical context to make a diagnosis of Langerhans cell histiocytosis, okay? Langerin, as I say, is the icing on the cake, and some of us have the cake, okay? And we want to have the cake and eat it too. All right, this is Langerhans cell histiocytosis, which is classical, and you see all the eosinophils, and you see those coffee bean nuclei, and so on and so forth. All right, and here is a case, and here not only am I showing you Langerin, CD1A, but I'm also showing you BRAF, and because BRAF, we have a nice good antibody, and I think Jay showed you, a case in which you can actually show BRAF in the tissues by using this antibody against the mutant protein. All right, good. Next. Come on, here's a 74-year-old male with multiple nodules and plaques over the limbs and the trunk. Biopsy of a skin lesion was done. Now, nobody's going to jump to conclusions, right? I hope not. All right, here's the skin, and it's a very nice skin biopsy. And once again, you see that there is a very heavy infiltrate in the top heavy infiltrate, because this is in the upper dermis, and there is a sort of perivascular and a very patchy infiltrate in the lower dermis, and you can see that there is even a slight bulging of that, because he had plaques and he had nodules as well. So here is a nodular kind of lesion, and here what do you see? Come on, do you see something here which you didn't see in the previous case? What is that? Grenz zone. Very good. Now, what else do you notice? Because at low power, there are many things that you need to do, okay? I say you have to do 5 things at low power. Anybody knows? What are the 5 things you have to do at low power, or ask yourself, or what questions are you supposed to do at low power? The number of times I have said it. Number 1, what question do you ask? Is there any normal tissue? Number 2, is there any abnormal tissue? Number 3, what is the relationship of the normal to the abnormal? Number 4, what is number 4? What is the pattern, if any, in the abnormal? And number 5, where should I concentrate my high power on? So is there any normal tissue? What's the answer? Yes. What's that normal tissue? Huh? Epidermis. All right. Is there any abnormal tissue? What's the answer? Yes, good. What is the relationship of normal to the abnormal? So it is this lesion is not arising in the epidermis, right? It is squarely in the dermis. Doesn't make too much difference over here, but if I had a squamous carcinoma or I had some other kind of tumor, I think it is important whether that tumor is rising from the epidermis or it's from the dermis and ulcerating the epidermis on top. So that is about the relationship. What's number 4? What is the pattern? Now tell me the pattern. You do this best at low power. So what's the pattern? Yes? Come. What's the pattern? It's diffuse and it is in columns. Can you see that? Yeah, so it's in columns, but it is a diffuse kind of pattern. Look, you can actually see the columns over there. They're marching one behind the other. What do we call it in some parts of the body? Indian file. Yes, you can see that pattern. Even where it is swirling in some places, it's there. But would you call this epithelioid? You think this pattern is epithelioid? No. Why? Because it's not got a cytoplasm. Acha, that's interesting. Huh? How do you define an epithelioid pattern? What? As opposed to a round cell pattern. As opposed to a mesenchymal pattern. Because there are 3 major patterns. And then there is a mixed pattern, you know, epithelial and something. Yeah? Cohesiveness. Whoever said cohesiveness is absolutely right. Epithelial cells stick together. That is the characteristic of epithelial cells. It might be acquired by non-epithelial cells like epithelioid sarcoma, epithelioid leiomyoma, epithelioid leiomyosarcoma, synovial sarcoma, but that is what an epithelial or epithelioid pattern is. And do you think that this is epithelioid? The answer is no. It is not epithelioid, although it is marching in columns, okay? Single chords or columns. So then there is something that one has to remember. Look, it's even going around like a carcinoma of the breast. That is like we see in a lobular carcinoma of the breast. But we know it is not. It is not epithelioid. So what is that tumor that does it? And we are talking about accessory cell lesions. Anybody can think of? Look at them. I'm just showing you pattern after pattern after pattern. And it's got big nucleoli. Can you see the nucleoli? Yeah, they're there. I mean, there is some amount of cytoplasm. There is a little bit of cytoplasm that is sort of going away from the nucleus, that is kind of dragging itself. Dendritic cells, okay. Yeah, we're talking about dendritic cells, all right? So this is what it looks like. It's non-epidermotropic. And the cells are diffusely arranged but also form Indian file cords. There's a very high proliferation index. You see lots of mitoses. And there is one hematolymphoid neoplasm, malignant tumor, that you should think about when you see this. Whether it's in the skin, whether it's in the orbit, whether it's in the breast even. Okay, it's a hematolymphoid neoplasm that does this. And once you've seen it, it should not get out of your mind unless your mind is cluttered with all sorts of other useless information. Okay? Now, I'll tell you, you can see all this. It's all negative. There's no CD117, TDT, 725, whatever else you want. Okay? And what is this? So then it must be hematolymphoid, okay? Because there are very few things that express LCA. In fact, I don't know that are anything that doesn't express it, that expresses and that is not hematolymphoid, okay? And what is this? CD4. So now, blastic plasmacytoid dendritic cell neoplasm, yes. So now what do you see? There's no CD8, there is CD56, and you saw all of this in the flow, and when somebody was talking about it. You can't see too well. It looks, you know, that CD123 is very, very dim, if there is any. There's CD43, which is a good marker of myeloid cells, particularly immature myeloid cells, although it's actually a T cell marker. And there is some, I'm not even sure whether the 68 is in, it's too bright for it to be in the tumor cells. It's probably in the accompanying histiocytes. And Sumeet will tell us what this is. Come on, Sumeet, read the flow. You have to put on your spectacles and earn your keep. Come on.
Okay, from here, this is the red dots are the cells of interest, I presume. This is CD, HNADR, I think. What is this? DR?
I can't see from here.
This is 33, is myeloid marker, CD64. CD56 and CD4 are positive, yes. So 56 and CD4 are positive. 123 is also positive.
It's huge.
Cyto CD3 is negative. This is normal T cells. MPO is negative. So based on 4, 56 and
The fact that he's got skin lesions.
123 skin lesions and DR is positive.
So
Yeah, it fits into.
there we are. Okay. So you see the diagnosis is blastic plasmacytoid dendritic cell neoplasm. So before we even had the, the benefit of Sumeet's, he was woken out from his sleep, but you are not dreaming, I hope. So this is a blastic plasmacytoid dendritic cell neoplasm. It's a horrible neoplasm to have. See, that's how the WHO actually defines it. You can go to the WHO website and you can get it. But yes, you require 4, you require 56, and one of the other ones that are on top mentioned over there if you're doing flow. Okay, but otherwise you can just do any 3 of these neoplasms if you don't, markers, if you don't have flow. So very good. So we saw that. Now, let's come to the next one. Here is a 7-year-old male who presented with an acute abdomen. And when he was explored, it showed that he had quite a sizable, for a 7-year-old, 4 centimeter mass in the jejunum. Okay? And he had a past history. In fact, he was being followed up because he had a treatment for ALL. Now let's see. So obviously, if somebody is going to come back after treatment for ALL, you assume that maybe he has got, a recurrence of his ALL, but why it should be in the jejunum is another issue. Okay? Now you see these. I'm sure Jay will remember this case. This tumor has got 2 morphologies. See, on one side, it's all round and in sheets. On the other side, it's a little bit more spindly. Okay? But there's no doubt about it, it's malignant. Now you might think that the round one may be the ALL and the spindly one may be something else, but it's we have to be on this side. There is, you can see the mitoses, you can see the anisonucleosis. You see the pleomorphism now appearing on the left-hand side of the screen, and the spindling that is happening on the right-hand side of the spleen. So you've got round cells and spindle cells and convoluted nuclear shapes and all the rest of it. And you might think, okay, it's a high-grade hematolymphoid tumor. God knows, did he actually have an ALL or something else? ALCL and a histiocytic neoplasm. Now you do all the immunohistochemistry, and there is no c-KIT, there is no CD34, there's no 20, there is no 3, so it's not at least not the usual myeloid neoplasm, no TDT, no MPO, no c-KIT. But what does it have? It's LCA again, okay, more on the round cell type side, less in the spindly type, and then you have to go through the motions, and you see that this is CD68. You can see it expressed better in the spindly side, and less frequently the cells are showing this on the round cell type. But when you do a CD163, which is a good alternative marker, and sometimes I like to do 163 because it shows up so beautifully, and all of the 163 is not necessarily of showing you that it is histiocytes, but it demonstrates these very well. There's no S100 protein, as you can see over there. So it's not S100 protein. So we have some lysozyme. So these cells are also expressing lysozyme, which is a histiocytic marker. And our friend CD4. So what does CD4 mean over here? Histiocytes. Okay, so CD4, and the MIB1 is very high. So of course, this is a histiocytic sarcoma. All right. So what is interesting is that histiocytic sarcomas may precede, they may occur simultaneously, or they may be subsequent to other malignant lymphomas, leukemias, MDS, CLL as part of Richter syndrome. And in this case, this child had it had a acute lymphoblastic lymphoma that was treated, and he was doing well until he came up with this. It's also a very curious thing, and I never got to the bottom of why it happens. You get histiocytic sarcomas in the mediastinum in the same way, either with or subsequent to a germ cell tumor, okay, in the mediastinum, which only occurs in males. Why is that so? Only in males. Now I know that Pravin and Jai know it because I said it millions of times. That except very occasionally for a teratoma, yes, you never ever get a germ cell tumor in the mediastinum of a female, a real true female. So if you want to diagnose a germ cell tumor, even a teratoma in the mediastinum of a female, either your diagnosis is wrong or that's not a female, okay? So that's the reason that histiocytic sarcomas only occur in the mediastinum with germ cell tumors, and they occur only in males. There are some little things like that you know, old people like me remember. You know that we can remember what happened in the past, but I can't remember what I ate for lunch. Okay, so here is another case, and this is a 20-year-old medical student, and Jai will remember this because I will show you what Jai presented somewhere. With inguinal lymphadenopathy of short duration. Okay, he had no history of fever or weight loss, and the FNA from the lymph node was suggested to be a non-Hodgkin's lymphoma. Okay, and he had lots of lots of lymphadenopathy all over. He also had hepatosplenomegaly. And this is the size of his node. It's not very large, and it is diffusely infiltrated. Okay, and you see this, and let me show you the high power, because the high power is good. Once again, what do you see? Ah, yes, you see very long cells with grooves, yeah, in the nuclei. Not much cytoplasm, but enough. There are a lot of mitotic figures over here, and you see a little lymphocytes here and there running around in this. You see this? So I don't think that you get any prizes for saying that this may be histiocytic. You might even have wondered whether this is a sarcoma, but to get a lymph node like this, so beautiful, so round, so well circumscribed, diffusely involved with a sarcoma, I think that would be a very odd kind of thing. You can see the number of lesions. So what is it? Diffuse large cell proliferation, etc. And it makes sense that if you've got a node that is totally replaced like this with something that has got histiocytic, it's probably a histiocytic lineage tumor, and it needs immunohistochemistry. So of course you do 20 and 3 and 5, and is it positive, all of this? All negative, yes. Those who don't do immunohistochemistry see some brown. No, that's in the normal population of 20 and 3. And then you can get very frustrated because you do a whole lot of immunohistochemistry and nothing has actually worked, okay? But you do an LCA, and the LCA is there. Can you see it? The bright things are the normal population of lymphocytes, but in the background, I don't know if the people at the back can see it, but you can see that there is a nice penciled outline of the membrane by leukocyte common antigen, that's CD45. On the other hand, there's no PAX5, okay? There's no 117, there's no CD34, there's no CD68. Oh my God, we thought at least 68 or 163 would be positive. Not there. So now has our thing gone down the drain? And then somebody said, it must be follicular dendritic cell tumor, all right? Now, what do you think? Follicular dendritic cell tumor? There's no 21, there's no 23, there was no 35, there was no CD1A, but lo and behold, what turns up? S100 protein. Now come on, the diagnosis is, there you are. But before that, what do you have to, what did I do? I did something awful. No, it's come back. I just hammered this thing too badly. All right, so when there is something that's S100 protein, you know, so I think Jay said that myeloma was the melanoma of the hematolymphoid system. So we've got a melanoma that should be considered, no? You've got S100 protein. So we had to do HMB45, melanase, HOX11, microphthalmia transcription factor. We did CD123, we did CD56. All of it was negative. No langerin, no lysozyme, no BRAF 600E. There is CD4 has come to our rescue. Yes. So yes, it's got some relationship to histiocytes, and there is CD11C. Okay. And I think Jay presented this somewhere at the European Association for Hematopathology, and they did, because it was selected as one of the cases to be discussed over there, and that is NPM, that's nucleophosphamine 1, and this is an interdigitating dendritic cell sarcoma, which was presented by Jay. Okay, and this is the clinical course. This patient was already pretty, although he was asymptomatic, but this is the course. You look at his bone marrow, it is full of this disease. You can see that S100 protein in the bone marrow, which is marking those cells. It's there in the liver. It's there in the bowel. So he just had a small lymph node for which he came, and just see what it all turned out to be. So that is, you know, and the message is always rule out an amelanotic spindle cell melanoma, because they can look like anything with crinkly nuclei or without nucleoli, and everything that they have told us about this. And you can see that these are very aggressive tumors. So what I'm telling you is, I don't want to show you any more of these cases, because you've seen enough. We've come to 5 o'clock. What time are we supposed to close this? 5. So there you are. I think you have seen enough of these of these tumors. There's no point, and I was just trying to make some points. Okay, don't think that CD4 is a T cell marker. It can be a marker of myeloid. It can be a marker of histiocytes. All right. It can be when you see S100, can't assume that these are, because this happens to be a histiocytic and dendritic cell or accessory cell thing. Yeah, so then you think, yes, S100 protein may be interdigitating, but it could very well have been a melanoma. And let me tell you, who confessed to having done or made that kind of wrong diagnosis? No other than Professor Carl Lennart. Anybody in the back know who is Professor Carl Lennart? Yes? What? You never heard of Professor Carl Lennart? Lennart lymphoma. Yes, he was responsible for the Kiel classification. And every time you see that KI67 and the KI this and the KI that, it's from Kiel. And you know where Kiel is? Yes, it's German. It's up in the north of Germany, quite close to Hamburg, okay? So he presented a case at one of the International Association of Pathology meetings, and in those days, you know, they used to cut slides and make slide boxes, and you had to pay whatever it is, $50 to get a box, and then you had to see it, and then you went there, and all these big professors used to tell you the answers. And there popped up Professor Lennart, and he was doing a hematolymphoid course, so we had some 10 or 12 cases, and he came to the case that was almost identical to this, okay? And he said, I put it in the course because I made a diagnosis of interdigitating dendritic cell sarcoma, okay? And he said, I have to eat my words because this patient has a liver full of metastasis, and that is a melanoma. Okay, so Carl Leonard missed a melanoma, so any one of us can miss a melanoma. So please, what was said, please, if you get something that is S100 protein positive, do a SOX10, do an HMB45, do a melanA. If you are still not happy, do a microphthalmia transcription factor marker, and only when you're satisfied, because this is a very rare disease. And before you make a rare disease, your back diagnosis, your back has to be against the wall. Okay, so thank you very much. I think we can wind up now. Listen, I just want to tell you that there are lots of slides, and many of them are there in my presentation. If you want to use it for teaching, I don't have a copyright on any of this, so please use it, so long as you don't, start putting it on YouTube and, sort of disseminating it. If you want to use it in your everyday teaching, I give you full permission to do so. Okay, thank you very much indeed. And once again, thank you for inviting us, all of us. And I think I can speak on behalf of Jay. Can I speak on behalf of you? Can I speak on behalf of Pravin and Sumeet? I speak on behalf of them to say that we have had a really wonderful experience. You guys have been very interactive over there, and I enjoyed it, and we all did. Thank you.
Thank you so much, ma'am. It was really great of you to share your knowledge with us. And as they say, all good things come to an end. But before concluding the CME, we need to congratulate our paper and poster winners. So we begin with the winners of the paper presentation. The first rank goes to Dr. Bhavini Gangwani from BJMC. And may I please request Dr. Mehta Parikh ma'am to present her with the prize. The second prize goes to Dr. Sabarish Krishnan. Can we call him on stage? Yes, thank you. May I please request Dr. Pravin Mahajan sir to present our second winner with the prize. The third position is secured by Dr. Kiran Meena, who is from Rabindranath Tagore College, Udaipur. I request Dr. Biren Parikh sir to present her with the prize. Okay, we do not have her here, so thank you sir, we will let her know. Now moving on for the poster presentation winners. The first prize, there is a tie between Dr. Kruti Bhatt, who is the consultant pathologist at Unipath Labs, and Dr. Henisha Tahiliani from GCRI. I request Dr. Anita ma'am to present them with their prizes. The second position is secured by Dr. Darshini Kotecha. I please request Dr. Sumeet Gujral sir to present her with the prize. BJMC. BJ. And the third position is secured by Dr. Samrat Bardoli, who is from GCRI. I request Dr. Jay Mehta, sir, to present him with the prize. Congratulations to all the winners. And ladies and gentlemen, as we conclude our CME, I would like to extend my heartfelt gratitude to each and every one of you, and most importantly to our esteemed delegates who have shared their valuable time and knowledge with us and made this CME possible. And on behalf of the organizing committee, I, Dr. Yukti Shah, I extend my sincerest thanks to my colleagues, my seniors, Dr. Nisarg Parikh sir, my head of the department, Dr. Falguni ma'am, for their invaluable contribution. I would like to invite Dr. Nisarg Parikh sir to give his vote of thanks. Without him, this CME would not have been possible. So may I please welcome Dr. Nisarg sir.
Dear friends, well, we had an exhausting session on the topic of lymphoma, right from the 9 a.m. in the morning up to the 5 a.m. evening, where we are having a battery of lymphoma experts from Mumbai. For that, I, on behalf of Department of Pathology, thank Dr. Madam Anita Borges for arranging this whole program. Without her help, this would not have been possible. Many, many thanks to Dr. Sumeet Gujral sir, Dr. Pravin Mahajan sir, and Dr. Jay Mehta sir. Thank you all. Thank you all.
Good evening, everyone. I hope everyone enjoys today's session till 5 p.m. Am I right? As the head of department, today I stand here with a great, profound sense of gratitude with all the efforts that make these events a remarkable success. First and foremost, I like to thank all the esteemed guest speakers who gave their valuable time and shared their expertise with us and gain our knowledge regarding the lymphoma update. Thank you so much, Dr. Anita ma'am, Dr. Gujral sir, Dr. Jay Mehta sir, and Dr. Pravin Mahajan sir. In a closing, I would like to thank all the delegates who gave their time, their participation and their constant support. And for these events make possible, I would like to thank our chairman sir, Dr. Purvesh Shah, our medical superintendent, Dr. M.M. Prabhakar sir, our dean sir, Dr. A.T. Lewa sir, and our additional MS, Dr. Chaitri Shah, for their unconditional support. I would also like to thank IT department, these multimedia teams that make the event possible, live streaming on YouTube, and make their event available for the future reference also in a recording form. So thank you so much, the team. I would also like to thank others admin staff like Nilima Ben, Anubhai, maintenance department, Vimal, and their team, and their SI, that Mr. Lokesh, and their team to clean whole the event venue and make available for us to use for a better functions. So once again, thank you everyone for your valuable time and make this event successful. And my heartiest congratulations to my department staff. So I request all of you a big cloud of applause for my department staff for your wonderful support. Otherwise, I won't be able to make this event possible. Thank you so much, all the team. Thank you very much.